Hello, future nurses. Are you tired of failing the NCLEX again and again? And deep down wishing you could finally pass it on your very first try? If yes, then stop scrolling, because this video might just change your life. If you stay with me till the very end, your chances of passing the NCLEX will skyrocket. Why? Because in this video, I've included only the exam-focused topics that actually appear on the test. No extra fluff, no wasted hours, just the exact content you need to cross the finish line with confidence. But wait, I don't want you to just pass eventually. I want you to pass now, in your very next attempt. That's why we created the Ultimate NCLEX Crash Course, a proven shortcut that has already helped over 100,000 nursing students pass successfully. And now, it's your turn. Just scan the QR code to get free access to practice tests, important questions, PDF notes, and the Ultimate Crash Course, or simply use the link in the description box of this video. You can also join our Telegram and WhatsApp channels to receive even more free content, including daily practice questions, notes, and test series. Don't wait, because every day you delay, someone else is moving ahead and securing their license while you're stuck behind. So, are you ready? Let's dive in. And by the end of this video, you'll see exactly how success is within your reach. Let us begin with one of the most critical areas of emergency nursing, triage, and disaster tags. In any emergency, the first priority is deciding who needs help immediately and who can wait. Emergent or immediate cases involve life-threatening conditions such as airway obstruction or crushing chest pain, and these patients require action right away. Urgent cases are serious but not instantly fatal, like major fractures. Non-urgent cases involve minor injuries such as sprains or abrasions. In a disaster, colored tags guide priority. Red means immediate and survivable if treated quickly. Yellow means delayed but serious. Green is for the walking wounded, and black is expectant or deceased. The golden rule is simple. Red tags come first. Once patients are prioritized, the next step is the primary survey using ABCDE. Airway is always checked first, and if there is spinal injury, a jaw thrust is used instead of a head tilt. Breathing comes next. Look at effort, check oxygen saturation, and assist as needed. Circulation follows. Monitor pulse and blood pressure, control bleeding, and start fluids. Disability means a quick neurological check with AVPU or Glasgow Coma Scale. Finally, exposure. Remove clothing to assess injuries while preventing hypothermia. This systematic sequence ensures no life-saving step is missed. Now let us turn to poisoning, a frequent NCLEX favorite. The rule is clear. Do not induce vomiting and never give syrup of ipecac. Activated charcoal may be used, and sometimes gastric lavage or bowel irrigation. Antidotes are key memory points. Naloxone for opioids, flumazenil for benzodiazepines, and N-acetylcysteine for acetaminophen. Vitamin K reverses warfarin, protamine reverses heparin. Digoxin immune fab is used for digoxin, and glucagon rescues beta-blocker overdose. These antidotes are high-yield NCLEX questions. Imagine you are on the floor and a patient suddenly deteriorates. This is when the rapid response team must be activated immediately, whether for chest pain, stroke signs, acute shortness of breath, severe hypotension, or sudden loss of consciousness. Acting early saves lives. If the crisis escalates into cardiac arrest, rhythm recognition is everything. For shockable rhythms like ventricular fibrillation or pulseless ventricular tachycardia, the sequence is CPR, defibrillation, epinephrine, and amiodarone. For non-shockable rhythms such as asystole or pulseless electrical activity, defibrillation does not work. Instead, the focus is on high-quality CPR and epinephrine. Remember, only ventricular fibrillation and pulseless ventricular tachycardia are shockable. Finally, let us tie it together with emergency drugs and their adrenergic effects. Alpha-1 stimulation causes vasoconstriction and raises blood pressure. Beta-1 stimulation increases heart rate and contractility, vital in shock. Beta-2 stimulation relaxes airways for bronchodilation and also relaxes the uterus. Dopamine is dose-dependent, renal perfusion at low doses, cardiac stimulation at moderate doses, and vasoconstriction at high doses. Epinephrine is the ultimate emergency drug, increasing heart rate, blood pressure, and opening airways, especially in anaphylaxis and cardiac arrest. Dobutamine strengthens heart contractility, often used in shock and heart failure. NCLEX Pearl In disaster triage, always treat red tags first. And in cardiac arrest, remember, defibrillation is only for ventricular fibrillation and pulseless ventricular tachycardia, never for asystole or PIA. Neurological emergencies. Let us begin with one of the most detailed neurologic imaging studies, the cerebral angiogram. This test outlines the blood vessels of the brain, making it critical for detecting aneurysms, arteriovenous malformations, stenosis, or vessel occlusions in stroke. A catheter is threaded through the femoral or carotid artery, and contrast dye is injected to highlight the vessels. From a nursing standpoint, preparation is everything. Keep the patient NPO for 4 to 6 hours, check for iodine or shellfish allergies, verify pregnancy status, and assess kidney function. Anticoagulants raise bleeding risk, so that must be reviewed as well. Post-procedure, monitor the insertion site for bleeding, check distal pulses, keep the patient on bed rest, and watch closely for neurological changes. NCLEX Pearl. If a patient suddenly develops weakness, confusion, or speech changes afterward, think embolus. Next up is the CT scan, one of the most common imaging tools. It helps identify tumors, hemorrhage, infarction, and hydrocephalus. If contrast is ordered, renal function and allergy screening are mandatory, and the patient may need to remain NPO. Your role here also includes reassurance. Explain that the procedure is painless, but they must remain very still. Now, moving to the electroencephalogram, EEG, a frequent NCLEX favorite. It detects seizure activity, sleep disorders, behavioral changes, or even brain death. Preparation is very specific. Wash hair without oils or sprays. Avoid caffeine and usually avoid sedatives or benzodiazepines because they suppress seizure activity. Sometimes anticonvulsants are held as ordered. During the test, flashing lights or hyperventilation may be used to trigger seizure patterns. NCLEX. Pearl, never give benzodiazepines before an EEG. Let us transition into clinical assessment with the Glasgow Coma Scale, GCS. This tool scores eye-opening up to 4, verbal response up to 5, and motor response up to 6, for a total of 15. A score of 15 is normal, while 8 or less means coma and the need for aggressive monitoring. Watch for posturing. Decorticate is flexed arms toward the core, while decerebrate is arms extended, which indicates a worse prognosis. On NCLEX, remember, decerebrate equals more serious. From here, we move into intracranial pressure, ICP monitoring, used for patients with GCS of 8 or less or severe head injuries. Devices may include intraventricular catheters, bolts, or sensors. Normal ICP is 10 to 15 millimeters of mercury. Rising pressure shows up as headache, irritability, altered consciousness, pupil changes, abnormal respirations, or posturing. The priority nursing concern is infection. Strict aseptic technique is non-negotiable. Next is the lumbar puncture, also called spinal tap. It collects cerebrospinal fluid to diagnose meningitis, multiple sclerosis, syphilis, or subarachnoid hemorrhage. Positioning is vital, either side-lying fetal or seated and leaning forward. Ensure the bladder is empty before the test. Afterward, keep the patient flat for 4 to 6 hours. Encourage fluids and monitor for spinal headache or cerebrospinal fluid leakage. If severe, an epidural blood patch may be needed. NCLEX. Pearl, never perform a lumbar puncture when increased intracranial pressure is suspected, as it risks brain herniation. Now onto advanced imaging, the MRI. It gives excellent detail of soft tissue, tumors, lesions, and inflammation. Safety checks are crucial. Patients with pacemakers, aneurysm clips, or other metal cannot undergo MRI. Remove jewelry and provide sedation for claustrophobic patients if needed. Building further, the PET scan evaluates brain metabolism, tumors, and perfusion using a small injection of radioactive glucose. Again, stillness during the test is key. Do not overlook the skull X-ray. While less sensitive than CT or MRI, it still identifies fractures, dislocations, and abnormalities in bone structure. Before we move on to the next important NCLEX topic, I want to give you something even more powerful. If you're serious about passing on your very next attempt, we've created the ultimate NCLEX crash course, a proven shortcut that has already helped over 100,000 nursing students succeed. And here's the best part. It's an all-in-one solution that gives you everything you need to pass the NCLEX. Live classes and recorded lectures, 5,000 practice questions, 30 full-length practice tests, ebooks and PDF notes, a complete student planner. Nigerian Naira questions discussed in comprehensive lectures. Literally everything required to clear the exam with confidence. Just scan the QR code on your screen or click the link in the description to enroll in the crash course and get instant access to free content like PDF notes, practice tests, and NCLEX quizzes. Plus, you can also join our Telegram and WhatsApp channels for even more free resources. Now let us begin with the very foundation of pain. Its types. Acute pain is short-term, protective, and tied to healing. Think of a surgical incision or broken bone. It triggers the sympathetic nervous system, so you may see increased heart rate, blood pressure, sweating, and anxiety. Chronic pain, on the other hand, persists for more than 6 months and often lingers long after tissue healing. These patients may show fatigue, depression, or poor functioning. But unlike acute pain, physical signs are often absent. Now let us divide pain into nociceptive and neuropathic categories. Nociceptive pain results from tissue damage or inflammation. It is described as throbbing or aching and may be somatic, visceral, or cutaneous. Neuropathic pain comes from damaged nerves and is described as burning, shooting, or pins and needles. Classic examples include diabetic neuropathy, phantom limb pain, and postherpetic neuralgia. Here is your NCLEX Pearl. Neuropathic pain does not respond well to opioids alone. It requires adjuvant therapy such as antidepressants, anticonvulsants, or antispasmodics. Once we know the type of pain, the next step is pain assessment. The PQRST method is highly effective. P for provoking or relieving factors, Q for quality, R for region or radiation, S for severity, and T for timing. Some add a final S for setting. For scoring, adults usually use the numeric rating scale. Children may use the Wong-Baker Faces scale, and infants or nonverbal patients are assessed with the FLACC scale. Face, legs, activity, cry, and consolability. Pain management begins with non-pharmacologic interventions, which are often overlooked but powerful. Relaxation techniques, guided imagery, and distraction with music or conversation can ease distress. Physical strategies like heat, cold, massage, or acupuncture may provide relief. And technology-based methods such as TENS help block pain signals. When medications are needed, we follow the World Health Organization's 3-step ladder. For mild pain, 1 to 3, use non-opioids like NSAIDs or acetaminophen. For moderate pain, 4 to 6, add weak opioids such as codeine, often with adjuvants. For severe pain, 7 to 10, strong opioids like morphine, fentanyl, or hydromorphone are used, again with adjuvants when appropriate. Now, let us break down non-opioids. NSAIDs such as ibuprofen, naproxen, or diclofenac work well but carry risks of gastrointestinal upset, bleeding, and kidney injury. Aspirin can cause tinnitus, vertigo, and bleeding, and it is never given to children because of Reye's syndrome. Acetaminophen is easier on the stomach but toxic to the liver. Maximum dose 4 grams per day. Overdose is treated with acetylcysteine, Mucomyst. Next are opioids, the heavy hitters. Morphine, hydromorphone, fentanyl, and oxycodone are used for moderate to severe pain, cancer care, or end-of-life comfort. Remember, chronic pain should be treated with around-the-clock dosing, not just as needed. Fentanyl patches are for long-term use only, not acute pain. Watch for side effects: constipation, sedation, nausea, urinary retention, and the most dangerous, respiratory depression. Always check respiratory rate before administration. If it is less than 12 per minute, hold the medication and notify the provider. Overdose is reversed with naloxone, Narcan. To close, let us consolidate with high-yield NCLEX pearls. Pain is always what the patient says it is. It is subjective. Acute pain shows sympathetic signs, chronic pain often does not. Non-opioids have a ceiling effect, so more is not always better. NSAIDs increase bleeding and kidney risk, acetaminophen increases liver risk, and opioids increase respiratory risk. Always pre-medicate before painful procedures, like dressing changes. And most importantly, the best strategy is multimodal, combining medications with non-pharmacologic methods for safe, effective pain control. Let us now dive into one of the most urgent neurological conditions you will face in both practice and on the NCLEX, meningitis. At its core, meningitis is inflammation of the meninges, the protective layers around the brain and spinal cord. The cause is key: viral meningitis, also called aseptic, is most common and usually self-limiting. But bacterial meningitis is a true medical emergency, highly contagious and potentially fatal, so immediate intravenous antibiotics are the priority. Prevention is powerful here. The Hib vaccine protects against Haemophilus influenzae type B. The meningococcal conjugate vaccine, MCV4, is essential for adolescents, college students, and military recruits. And the pneumococcal vaccine guards against Streptococcus pneumonia. Now, what does meningitis look like clinically? The symptoms are dramatic. A sudden, severe headache with nuchal rigidity, or stiff neck, is classic. Add in photophobia, fever, chills, nausea, vomiting, and altered mental status ranging from irritability to coma. Seizures often occur due to rising intracranial pressure. On exam, remember Koenig's sign, pain on leg extension, and Brudzinski's sign, hip and knee flexion with neck flexion. In meningococcal meningitis, a red macular rash may appear. Systemic findings like tachycardia or signs of increased ICP may also be present. Diagnosis hinges on a lumbar puncture with cerebrospinal fluid analysis. Bacterial meningitis typically shows cloudy cerebrospinal fluid, high white cells and protein, and low glucose. Viral meningitis usually has clear cerebrospinal fluid, elevated white cells, slightly increased protein, and normal glucose. Blood cultures may confirm the pathogen. Here is a life-saving NCLEX rule. If increased intracranial pressure is suspected, always perform a CT or MRI first. Doing a lumbar puncture under high ICP can cause fatal brain herniation. Nursing interventions are all about safety. Patients with bacterial meningitis go on droplet precautions until 24 hours of antibiotics are complete. Keep the head of bed at 30 degrees, reduce environmental stimulation, and avoid activities that increase ICP like coughing or straining. Seizure precautions must be in place. Monitor closely for SIADH. You will see concentrated urine with diluted serum. Watch also for septic emboli, which can cut off blood supply and lead to gangrene, stroke, or organ failure. Supportive care includes hydration, pain control, fever management, and ongoing neurological checks. Treatment starts urgently. Intravenous antibiotics such as ceftriaxone, cefotaxime, or vancomycin are frontline. Corticosteroids like dexamethasone reduce inflammation and help prevent hearing loss. Anticonvulsants are used for seizure control. Analgesics and antipyretics manage pain and fever. But opioids are avoided because they can mask neurological changes. Complications remain a serious threat. Increased ICP can progress to brain herniation. SIADH may cause hyponatremia. Septic emboli can result in ischemia, stroke, or limb loss. Long-term patients may face hearing loss, cognitive decline, or hydrocephalus. Let us finish with some high-yield NCLEX pearls. Droplet precautions are mandatory for the first 24 hours of bacterial meningitis treatment. Never perform a lumbar puncture if increased ICP is suspected. CSF clues. Bacterial is cloudy with low glucose. Viral is clear with normal glucose. Vaccination, Hib, meningococcal, pneumococcal, is your strongest prevention tool. SIADH equals concentrated urine with diluted blood. Seizure precautions and a 30-degree HOB position reduce life-threatening complications. NCLEX, takeaway. Meningitis demands rapid recognition, immediate antibiotics, and strict precautions. Always think safety first. ICP, seizures, and droplet isolation are your nursing priorities. Before we dive into the next NCLEX topic, let me share something even more powerful with you. If you're serious about passing on your very next attempt, we've built the ultimate NCLEX crash course, a proven shortcut that has already guided over 100,000 nursing students to success. And here's the best part. It's a true all-in-one solution that gives you everything you need to pass with confidence. Live classes and recorded lectures. 5,000 practice questions, 30 full-length practice tests, ebooks and PDF notes, a complete student planner, Nigerian Naira questions covered in comprehensive lectures. Literally everything required to clear the exam once and for all. Just scan the QR code on your screen or click the link in the description to enroll today and unlock instant free access to PDF notes, practice tests, and NCLEX quizzes. You'll also be able to join our Telegram and WhatsApp channels for even more free resources to boost your prep. Now, let's continue with the next NCLEX topic. Let us begin with the fundamentals. A seizure is a sudden, uncontrolled burst of electrical activity in the brain. This abnormal firing can alter consciousness, motor control, sensations, or even autonomic responses like heart rate or breathing. When seizures occur repeatedly because of ongoing abnormal brain activity, we call that condition epilepsy, a chronic disorder that demands long-term management. So what triggers seizures? In pediatrics, the number one cause is a high fever, leading to febrile seizures in children under 2. Neurologic causes include head trauma, cerebral edema, meningitis, tumors, strokes, or hypoxia. Metabolic issues such as low sodium, low glucose, or low calcium can also set off seizures. Do not forget lifestyle and external triggers. Stress, fatigue, caffeine, flashing lights, and sleep deprivation are classic exam points. And of course, genetics, toxins, and drug or alcohol withdrawal can all play a role. Now that we know the causes, let us break down the types of seizures. Under generalized seizures, the most well-known is the tonic-clonic seizure, or grand mal. In the tonic phase, patients may sense an aura, then suddenly stiffen, lose consciousness, and stop breathing briefly, sometimes turning cyanotic. This is followed by the clonic phase, with rhythmic jerking that lasts 1 to 2 minutes. Afterwards comes the postictal phase, confusion, headache, and drowsiness. Another generalized type is the absence seizure, or petit mal, common in children. It involves a brief lapse in awareness, staring, lip smacking, or eyelid fluttering, often mistaken for daydreaming. Myoclonic seizures involve sudden, quick jerks of the extremities. Atonic seizures, or drop attacks, cause a sudden loss of muscle tone, making the patient collapse unexpectedly, which carries a high risk of injury. On the other hand, focal or partial seizures start in one hemisphere. A simple focal seizure does not affect consciousness, but motor or sensory changes occur. A complex focal seizure impairs consciousness, often with automatisms like lip smacking or repetitive hand movements. So, what do we as nurses do during a seizure? The top priority is always airway and safety. Lower the patient gently to the ground, position them on their side to keep the airway clear, loosen tight clothing, and move objects away. And here is a big NCLEX pearl. Never restrain the patient and never put anything in their mouth, not even a tongue blade. After the seizure, continue side positioning, assess vital signs and neurological status, and allow rest. Documentation is critical. Record onset, duration, activity, and recovery. And for every patient on seizure precautions, always keep suction and oxygen equipment ready at the bedside. Let us now shift our attention to a classic NCLEX favorite, Parkinson's disease. This is a progressive neurodegenerative disorder that slowly robs patients of smooth, controlled movement. At its core, the problem is chemical. Dopamine production falls while acetylcholine activity remains high. This imbalance is caused by degeneration of the substantia nigra, the part of the brain that helps regulate motor control. When dopamine decreases, acetylcholine dominates, overstimulating the basal ganglia and leading to the abnormal movements that define this condition. So, how do these patients present? The hallmark features can be remembered with the acronym TRAP. T stands for tremor, specifically a resting tremor, often described as pill rolling between the fingers. R is for rigidity, where muscles become stiff and joints show cogwheel resistance. A stands for akinesia or bradykinesia, meaning slowness or even absence of movement, making daily activities and gait initiation difficult. And P stands for postural instability, leading to stooped posture and a high risk for falls. Beyond TRAP, you will often see a shuffling gait, mask-like facial expression, difficulty swallowing or chewing with aspiration risk, soft or slurred speech, and later on, depression or dementia as the disease progresses. Diagnosis is largely clinical. There is no definitive lab test. Providers look for the TRAP pattern and often confirm it by observing improvement with dopaminergic therapy. Now let us focus on nursing care priorities. Aspiration prevention comes first. Keep patients upright during meals, use thickened foods if needed, encourage small bites, and have suction equipment ready at the bedside. For mobility, provide range of motion exercises, yoga, and assist with slow, deliberate walking, always guarding against falls. With communication, encourage clear, slow speech and explore alternative methods if speech becomes too limited. And do not forget nutrition. Encourage adequate intake and monitor for unintended weight loss, which is common. When it comes to medications, the cornerstone is levodopa-carbidopa. This combination increases dopamine in the brain and improves motor symptoms. Teaching is key. It works best on an empty stomach, but patients should avoid high-protein meals, as protein interferes with absorption. Watch for side effects such as dyskinesias, hallucinations, and confusion. Another option is benztropine, an anticholinergic that helps with tremor and rigidity, but it is contraindicated in patients with glaucoma or urinary retention. Dopamine agonists like pramipexole or ropinirole may also be used to mimic dopamine and improve movement. Complications unfortunately increase over time. Aspiration pneumonia is a major concern because of swallowing difficulty. Malnutrition and dehydration may follow from poor intake. Falls and fractures are common due to rigidity and instability. And finally, in late disease, depression and dementia can greatly impact quality of life. Let us wrap this up with high-yield NCLEX pearls. Parkinson's equals low dopamine, high acetylcholine. TRAP equals tremor, rigidity, akinesia/bradykinesia, postural instability. Levodopa-carbidopa. Avoid high-protein meals. Monitor for dyskinesia and hallucinations. Benztropine, effective for tremors but unsafe in glaucoma or urinary retention. Top nursing priorities: safety first and aspiration prevention always. NCLEX. Takeaway: Parkinson's management is all about restoring balance between dopamine and acetylcholine, supporting mobility, preventing aspiration, and protecting patient safety. Before we move on to the next important NCLEX topic, I want to give you something even more powerful. If you're serious about passing on your very next attempt, we've created the Ultimate NCLEX Crash Course, a proven shortcut that has already helped over 100,000 nursing students succeed. And here's the best part. It's an all-in-one solution that gives you everything you need to pass the NCLEX. Live classes and recorded lectures. 5,000 practice questions. 30 full-length practice tests. Ebooks and PDF notes. A complete student planner. Nigerian Naira. Questions discussed in comprehensive lectures. Literally, everything required to clear the exam with confidence. Just scan the QR code on your screen, or click the link in the description to enroll in the crash course and get instant access to free content like PDF notes, practice tests, and NCLEX quizzes. Plus, you can also join our Telegram and WhatsApp channels for even more free resources. Let us now turn our focus to a condition that is both common in practice and a frequent NCLEX favorite: Alzheimer's disease. This is a progressive, irreversible neurodegenerative disorder most often seen in adults over the age of 65. The underlying pathology centers on the buildup of beta-amyloid plaques and neurofibrillary tangles, which damage neurons and ultimately lead to brain atrophy. Now, who is at risk? The number one factor is advanced age. Family history and genetic mutations also play a strong role. Patients with a history of head trauma, repeated toxic exposures, or even recurrent viral infections such as herpes simplex are more vulnerable. These risk factors often appear in NCLEX questions, testing whether you can identify populations most at risk. Clinically, the first and most classic symptom is short-term memory loss. Over time, long-term memory also declines. As the disease progresses, patients develop poor judgment, impaired problem-solving, personality changes, and behavioral disturbances. Eventually, they lose the ability to perform activities of daily living, becoming completely dependent. To better understand the disease, let us quickly review the 7 stages of Alzheimer's. Stage 1, no impairment. Stage 2, very mild decline, occasional forgetfulness. Stage 3, mild decline, noticeable memory lapses. Stage 4, moderate decline, difficulty with complex tasks, personality changes. Stage 5, moderately severe decline, requires assistance with activities of daily living. Stage 6, severe decline, incontinence, wandering, agitation, confusion. Stage 7, very severe decline, loss of speech, swallowing, and ambulation, complete dependence. Here comes your NCLEX pearl. Short-term memory loss is always the earliest sign. Now let us move into nursing interventions. In early stages, reorientation with clocks, calendars, and labels is useful. Keep communication short, simple, and repetitive to minimize frustration. Establish structured routines for meals, toileting, and sleep to reduce anxiety. The environment should remain calm and consistent, with gradual changes only. Above all, safety is the top priority. Remove loose rugs and clutter, install locks on doors, ensure good lighting, and mark stairs clearly. In high fall risk patients, placing a mattress on the floor may prevent serious injury. Next, let us discuss medications. The cornerstone is donepezil, Aricept, a cholinesterase inhibitor. It slows disease progression by boosting acetylcholine levels, improving memory and daily functioning. Remember, it is not a cure, only a way to slow decline. Side effects include GI upset, dizziness, bradycardia, and syncope, so patients need careful monitoring. Other cholinesterase inhibitors include rivastigmine and galantamine. Another drug, memantine, is an NMDA antagonist that works on glutamate pathways and may be combined with cholinesterase inhibitors for additional benefit. Complications often develop as the disease advances. Patients face aspiration risk due to swallowing difficulties, malnutrition and dehydration from poor intake, skin breakdown from immobility and incontinence, and injury from wandering. On top of this, caregiver role strain is a major issue, making family support and respite care essential components of management. Let us close with high-yield NCLEX pearls. The earliest sign is short-term memory loss. In late stages, prioritize safety over independence. Donepezil slows cognitive decline but requires monitoring for bradycardia. Patients thrive with structured routines, gentle reorientation, and low stimulation. By stage 7, patients are completely dependent for all activities of daily life. NCLEX. Takeaway: Alzheimer's care is about recognizing early memory loss, protecting patient safety as decline progresses, supporting families, and knowing the role and limitations of medications like donepezil. Let us now turn to 3 major neuromuscular disorders that NCLEX loves to compare: multiple sclerosis, amyotrophic lateral sclerosis, and myasthenia gravis. While all 3 involve weakness and progressive disability, the key differences between them are exactly what NCLEX tests. So, pay close attention to the unique features. Multiple sclerosis, MS. We begin with multiple sclerosis. MS is an autoimmune disorder that attacks the central nervous system, causing demyelination and plaque formation in the brain and spinal cord. This slows or blocks nerve transmission. It usually begins between ages 20 and 40, is more common in women, and follows a relapsing remitting course. What makes symptoms flare? Think extremes: heat, infections, stress, pregnancy, and fatigue. A common NCLEX trap: hot baths make MS worse, not better. Symptoms vary widely, but classic findings include vision changes like diplopia or nystagmus, motor symptoms like weakness, spasticity, and poor coordination, and speech and swallowing problems that raise aspiration risk. Cognitive impairment, bowel and bladder dysfunction, and sexual dysfunction may also occur. Diagnosis is confirmed by MRI, which reveals characteristic plaques. Treatment focuses on slowing progression and managing symptoms. Immunosuppressants such as cyclosporine and prednisone are used. Baclofen or dantrolene for spasticity, and interferon beta to reduce relapses. Nursing priorities include energy conservation, temperature regulation, and stress reduction. Now let us move to ALS, also known as Lou Gehrig's disease. ALS is a progressive degeneration of upper and lower motor neurons, leading to total paralysis. It usually develops in middle age, and survival is typically only 3 to 5 years after onset. Here's the crucial NCLEX distinction. ALS affects motor neurons only. The mind stays sharp. Patients gradually lose muscle strength, beginning in the extremities, progressing to dysarthria, dysphagia, and respiratory failure. Nursing care is centered on maintaining a patent airway. Suction, possible tracheostomy, and ventilator support are often required. Communication aids are critical since speech declines while cognition remains intact. There is no cure, but riluzole, a glutamate antagonist, may slightly slow progression. Most patients eventually die of respiratory failure or pneumonia. So remember this pearl: ALS equals progressive paralysis with intact cognition. Let us review myasthenia gravis. This is an autoimmune disorder where antibodies destroy acetylcholine receptors at the neuromuscular junction. The hallmark is fluctuating muscle weakness that worsens with activity and improves with rest. Classic signs include ptosis, drooping eyelids, diplopia, and difficulty chewing or swallowing, which greatly increases aspiration risk. Respiratory weakness can progress to a myasthenic crisis. Triggers include infection, stress, pregnancy, and heat. Diagnosis often involves the edrophonium tensilon test. Here's the NCLEX trick. If symptoms improve, myasthenic crisis. If symptoms worsen, cholinergic crisis from too much medication. Always have atropine ready as the antidote for cholinergic crisis. Nursing care includes airway protection, aspiration precautions, small frequent meals, thickened foods, and upright positioning. Patients may also need eye protection with artificial tears or patches. Medication therapy centers on pyridostigmine or neostigmine, given on time and ideally before meals to improve chewing and swallowing. Prednisone and other immunosuppressants may help, and advanced cases may require plasmapheresis or thymectomy. High-yield NCLEX pearls, MS, autoimmune, demyelination, relapsing remitting, plaques on MRI, symptoms worse with heat. ALS, motor decline only, cognition intact, respiratory failure. Common cause of death, riluzole slows progression. MG, fluctuating weakness, ptosis, swallowing difficulty, aspiration risk. Tensilon test distinguishes crises. Pyridostigmine improves strength. NCLX. Takeaway, MS, ALS, and MG may all present with weakness, but their causes, courses, and nursing priorities differ. On the exam, spotting those key distinctions is the secret to choosing the right answer. Before we move on to the next important NCLEX topic, I want to give you something even more powerful. If you're serious about passing on your very next attempt, we've created the Ultimate NCLEX Crash Course, a proven shortcut that has already helped over 100,000 nursing students succeed. And here's the best part. It's an all-in-one solution that gives you everything you need to pass the NCLEX, live classes and recorded lectures, 5,000 practice questions, 30 full-length practice tests, ebooks and PDF notes, a complete student planner, Nigerian Naira questions discussed in comprehensive lectures. Hekum, literally everything required to clear the exam with confidence. Just scan the QR code on your screen, or click the link in the description to enroll in the crash course and get instant access to free content like PDF notes, practice tests, and NCLEX quizzes. Plus, you can also join our Telegram and WhatsApp channels for even more free resources. Headaches are one of the most frequent complaints patients bring up. But on NCLEX, the key is not just recognizing the pain, it is being able to distinguish the type of headache and respond with the correct intervention. Before we break them down into migraines and cluster headaches, let us highlight some common triggers that apply to both. Environmental factors like strong odors, bright lights, allergens, and even weather changes can provoke headaches. Lifestyle habits also play a big role. Stress, fatigue, irregular sleep, or anxiety are classic triggers. Hormonal shifts such as the menstrual cycle or oral contraceptive use commonly set off migraines. And diet is another big one. Foods high in tyramine like aged cheese, red wine, and cured meats, as well as MSG, nitrites, dairy, and even caffeine may all trigger attacks. Migraines are among the most disabling forms of headache. They are considered a neurovascular disorder and often run in families. The pain is usually unilateral, throbbing, and located behind one eye or ear, lasting anywhere from 4 to 72 hours. Associated symptoms include photophobia, phonophobia, nausea, and vomiting. Some patients experience an aura beforehand. Visual changes like flashing lights or sensory changes like tingling. For nursing care, the priority is comfort. Place the patient in a quiet, dark, cool environment, elevate the head of the bed about 30 degrees, and help them avoid triggers. For mild migraines, medications include non-steroidal anti-inflammatory drugs, acetaminophen, and antiemetics. For severe migraines, triptans such as sumatriptan or ergotamine are used, both of which cause vasoconstriction. For prevention, providers may prescribe beta blockers, anticonvulsants, or antidepressants. Now let us compare that to cluster headaches, which are very different. Cluster headaches are linked to hypothalamic activation and trigeminal nerve involvement. The pain is intense, sharp, and non-throbbing, lasting 30 minutes to 2 hours, but occurring multiple times a day in clusters that may last for weeks to months. Unlike migraines, cluster headaches are more common in men aged 20 to 50. Distinct autonomic signs occur on the same side as the pain: tearing of the eye, nasal congestion or rhinorrhea, ptosis, and redness or watering of the eye. The onset is sudden, and importantly, there is no aura. Treatment is also different. The NCLEX favorite intervention is 100% oxygen therapy via mask, which relieves cluster headaches but does not help migraines. Other options include triptans, ergotamine, and NSAIDs for acute attacks. For prevention, corticosteroids or calcium channel blockers like verapamil may be used. High-yield NCLEX pearls. Migraines. Long-lasting, 4 to 72 hours. Throbbing, often with aura, plus photophobia, phonophobia, and nausea or vomiting. Cluster headaches. Short, 30 to 120 minutes. Very intense, occur in groups, common in men, with autonomic signs like tearing, congestion, and ptosis. Oxygen therapy. Effective for cluster headaches, not for migraines. Medications. Triptans and ergotamines relieve both, but are contraindicated in coronary artery disease because of vasoconstriction. Emergency pearl. Any sudden, severe, first headache must be treated as a possible subarachnoid hemorrhage until proven otherwise. NCLEX. Takeaway. Migraines are long, throbbing, and disabling. Cluster headaches are short, sharp, and recurrent. Know the triggers, know the interventions, and remember oxygen for clusters, not migraines. Let us now move into the world of eye disorders, a high-yield section for NCLEX that often tests your ability to distinguish between different vision changes and the nursing priorities that follow. We begin with macular degeneration, the most common cause of vision loss in people over 60. This condition is caused by degeneration of the macula, the central part of the retina responsible for sharp vision. As the disease progresses, patients lose central vision, but their peripheral vision remains intact. There are two main types, the dry form, which is more common and progresses slowly, and the wet form, which is less common, but progresses rapidly. Symptoms include blurred vision, a central blind spot, and eventually, potential blindness. Nursing care focuses on maximizing function, encouraging a diet rich in antioxidants, carotene, vitamin E, and vitamin B12, and connecting patients with adaptive resources, such as magnifiers, large print reading material, and community support services. Here is your NCLEX pearl. Macular degeneration leads to central vision loss, while glaucoma causes peripheral vision loss. Now let us shift to cataracts, another extremely common condition, particularly in the elderly. Cataracts are the result of lens opacity, causing gradual and painless vision loss. Symptoms include decreased visual acuity, blurred or double vision, sensitivity to glare, halos around lights, and most notably, an absent red reflex on examination. The only definitive treatment is surgical removal of the lens with placement of an artificial intraocular lens. Postoperative nursing care is critical. Patients should be taught to wear sunglasses outdoors, report any signs of infection such as yellow or green drainage, increased pain, or worsening vision, and avoid any activity that increases intraocular pressure. This includes bending, sneezing, coughing, straining, lifting more than 10 pounds, or hyperflexing the head. Driving and sports are avoided until cleared by the provider, and full recovery generally takes 4 to 6 weeks. Moving on, we come to glaucoma, which is all about increased intraocular pressure. The normal range is 10 to 21 millimeters of mercury, but in glaucoma, poor drainage of aqueous humor causes pressure to rise, leading to optic nerve damage. There are two major types. The first is open-angle glaucoma, a chronic condition where drainage is only partially blocked, leading to a gradual increase in pressure. Symptoms may be subtle, mild eye pain and progressive loss of peripheral vision, often described as tunnel vision. The second type is closed-angle glaucoma, which is an emergency. Here, the drainage pathway is completely blocked, leading to a sudden, rapid rise in intraocular pressure. Symptoms include severe eye pain, halos around lights, blurred vision, nausea, photophobia, and a sudden onset of visual disturbance. If untreated, blindness can occur quickly. Nursing care in glaucoma focuses on monitoring intraocular pressure and administering medications on a strict schedule, usually every 12 hours, and lifelong. These medications include pilocarpine, which constricts the pupil to increase aqueous outflow, beta blockers such as timolol, which reduce aqueous humor production, and carbonic anhydrase inhibitors such as acetazolamide, which also lower intraocular pressure. For acute emergencies, intravenous mannitol, an osmotic diuretic, is used to rapidly reduce pressure. Patients should be taught proper eye drop administration. Space multiple drops by 5 minutes and use punctal occlusion, pressing the inner canthus to prevent systemic absorption. Education is crucial. Patients must avoid activities that increase intraocular pressure, such as bending at the waist, straining, coughing, sneezing, or lifting heavy weights. And most importantly, glaucoma medications are lifelong and should never be stopped suddenly. Now let us consider retinal detachment, a true ophthalmic emergency. This occurs when the retina separates from the underlying supportive tissue, cutting off its blood supply. The hallmark symptoms are sudden floaters, flashes of light, or the sensation of a curtain or shadow descending over the visual field. This requires immediate surgical intervention, which may include laser repair, cryotherapy, or a scleral buckle. Without prompt treatment, permanent blindness can occur. To wrap up, let us consolidate with some high-yield NCLEX pearls. Central vision loss is a sign of macular degeneration, while peripheral vision loss is classic for glaucoma. Cataracts present with painless, progressive loss of vision, halos around lights, and an absent red reflex. Glaucoma medications must be continued lifelong. Never stop abruptly. Closed-angle glaucoma is always an emergency. And finally, sudden floaters, flashes, or a curtain over vision point to retinal detachment, which requires immediate surgery. Before we dive into the next NCLEX topic, let me share something even more powerful with you. If you're serious about passing on your very next attempt, we've built the ultimate NCLEX crash course, a proven shortcut that has already guided over 100,000 nursing students to success. And here's the best part. It's a true all-in-one solution that gives you everything you need to pass with confidence. Live classes and recorded lectures, 5,000 practice questions, 30 full-length practice tests, ebooks and PDF notes, a complete student planner, Nigerian Naira questions covered in comprehensive lectures. Literally everything required to clear the exam once and for all. Just scan the QR code on your screen or click the link in the description to enroll today and unlock instant free access to PDF notes, practice tests, and NCLEX quizzes. You'll also be able to join our Telegram and WhatsApp channels for even more free resources to boost your prep. Now, let's continue with the next NCLEX topic. Alright, let's dive into ear disorders, a crucial topic for the NCLEX. We'll start with one of the most common ear issues, otitis media, or middle ear infection. So, what puts someone at risk for this condition? Well, recurrent colds and respiratory infections are a big trigger, especially in children. Speaking of kids, those with enlarged adenoids are more prone, and remember, children are more susceptible overall because their eustachian tubes are shorter and more horizontal, making fluid drainage tricky. Now, how does otitis media actually present? Picture a child tugging at their ear. You might notice a red, bulging tympanic membrane, sometimes with fluid or bubbles behind it. Of course, ear pain, fever, and irritability are also common. So, if you're administering eardrops, keep this handy tip in mind. For children under 3, gently pull the ear down and back. But for adults, the technique flips. Pull the ear up and back. This small adjustment ensures the medication reaches the middle ear effectively. Transitioning smoothly, let's move deeper into the inner ear with Meniere's disease, which can be quite challenging for patients. The hallmark of this disorder is the classic triad: tinnitus, which is ringing in the ears, unilateral hearing loss, meaning one ear is affected, and vertigo, causing dizziness and balance problems. But it doesn't stop there. Patients may also experience nausea, vomiting, nystagmus, and fatigue. Now, what causes Meniere's disease? Viral or bacterial infections can play a role, and certain medications, known as ototoxic drugs, can damage the inner ear. Key NCLEX meds to watch for include aminoglycosides like gentamicin, loop diuretics such as furosemide, chemotherapy agents like cisplatin, and even metronidazole. Awareness here is critical. Asking a patient if they hear ringing or changes in hearing can be a lifesaver. When it comes to management, several strategies can help. Medications like anticholinergics, antihistamines, and droperidol can reduce nausea, vertigo, and tinnitus. But nursing care extends beyond drugs. Encourage patients to rest in a quiet, dark room during vertigo attacks, avoid sudden head movements, and limit stimulants like caffeine, alcohol, and nicotine. Dietary modifications also help. Restrict sodium intake to minimize fluid retention and space fluids evenly throughout the day. Let's wrap this up with some high-yield NCLEX pearls you absolutely cannot miss. For otitis media, remember the bulging red tympanic membrane often following a URI, and the eardrop technique differs for children versus adults. For Meniere's disease, the triad, tinnitus, hearing loss, and vertigo, is your key identifier. Always ask about exposure to ototoxic medications, and remember that management focuses on safety, environmental control, and lifestyle modifications like reducing salt and avoiding stimulants to prevent exacerbations. So, there you have it. A concise, high-yield overview of ear disorders that hits all the NCLEX essentials. Next, we'll move into the auditory assessment techniques to help you pick up subtle changes early and prioritize patient safety effectively. Now that we've reviewed ear disorders, let's move on to another critical topic, head injuries. A scenario where rapid assessment and prioritization can make all the difference on the NCLEX. First things first, your initial priorities in any head trauma are all about safety and stabilization. Think of a car accident or any traumatic injury. Always stabilize the cervical spine until a spinal injury is ruled out. Remember, don't skip this step. Spinal precautions save lives. And as always, follow the ABCs: airway, breathing, circulation. No matter the severity, these come first every single time. Now, once the patient is stabilized, your focus shifts to recognizing signs of increased intracranial pressure, or ICP. Early warning signs can be subtle but critical. Irritability and restlessness are often the first clues. Patients may also complain of a severe headache. Or you might notice a deteriorating level of consciousness. The Glasgow Coma Scale is your go-to tool here. Pupils may become non-reactive, unequal, or fixed and dilated, and breathing patterns can shift to Cheney-Stokes or even apnea. Remember, Cushing's triad, which appears later, is a red alert: rising blood pressure with a widened pulse pressure, bradycardia, and irregular respirations. Another hallmark to watch for is a CSF leak, which shows as clear fluid from the nose or ears and forms the classic halo sign, a bloody center surrounded by a yellow ring. This is an emergency because it increases the risk of meningitis. Once ICP is suspected or identified, nursing interventions are vital to prevent further damage. Keep the head of the bed at 30 degrees unless there's a contraindication, and maintain neutral head and neck alignment, avoiding flexion or extension. Prevent increases in abdominal pressure by using stool softeners and discouraging straining, coughing, sneezing, or blowing the nose. Make sure catheters are not kinked, and avoid suctioning whenever possible, as this can spike ICP. In critical situations, hyperventilation can be used temporarily to lower ICP by decreasing CO2, which causes cerebral vasoconstriction. And of course, don't forget seizure precautions. Head injuries increase seizure risk. Next, let's touch on medications commonly used in head injury management. Mannitol, an osmotic diuretic, helps lower ICP but requires close monitoring of electrolytes and serum osmolality. Pentobarbital decreases the brain's metabolic demands, while phenytoin is used to prevent post-traumatic seizures. Pain management is also crucial, so opioids like morphine and fentanyl may be administered, but always monitor for sedation and respiratory depression. In some cases, surgical management becomes necessary. A craniotomy may be performed to remove a clot or decompress swelling. The positioning post-surgery depends on the location. Supratentorial surgery patients should have their head elevated at 30 degrees to prevent ICP spikes, whereas infratentorial surgery patients are positioned flat on either side to protect the incision and minimize pressure. Head injuries can also lead to serious complications. Brain herniation is an absolute emergency. Look for dilated or fixed pupils, decreased level of consciousness, abnormal posturing, and irregular respirations. Endocrine complications can also arise due to pressure on the hypothalamus. Keep an eye out for diabetes insipidus, which presents as polyuria and hypernatremia, SIADH, which causes fluid retention and hyponatremia, and cerebral salt wasting, which leads to hyponatremia and hypovolemia. Each requires a different management approach, so careful assessment is critical. Before we wrap up, let's hit the high-yield NCLEX pearls you absolutely must remember. The first sign of increased ICP is irritability, not the late triad. A halo sign indicates a CSF leak, which increases meningitis risk. Hyperventilation is a temporary measure to reduce ICP. Remember that HOB positioning differs by surgery type. Supratentorial patients at 30 degrees, infratentorial patients flat or on the side. And finally, after head trauma, carefully monitor for DI versus SIADH, as they represent opposite fluid balance issues and require different interventions. All right, now that we've covered head injuries, let's shift our focus to strokes, also known as cerebrovascular accidents, or CVAs. The This is another high-stakes NCLEX topic, because rapid recognition and intervention can save brain function and even lives. Before we move on to the next important NCLEX topic, I want to give you something even more powerful. If you're serious about passing on your very next attempt, we've created the ultimate NCLEX crash course, a proven shortcut that has already helped over 100,000 nursing students succeed. And here's the best part. It's an all-in-one solution that gives you everything you need to pass the NCLEX. Live classes and recorded lectures, 5,000 practice questions, 30 full-length practice tests, ebooks and PDF notes, a complete student planner, Nigerian Naira questions discussed in comprehensive lectures, literally everything required to clear the exam with confidence. Just scan the QR code on your screen, or click the link in the description to enroll in the crash course and get instant access to free content like PDF notes, practice tests, and NCLEX quizzes. Plus, you can also join our Telegram and WhatsApp channels for even more free resources. First, let's differentiate the types of strokes. There are three main categories. Hemorrhagic strokes occur when a cerebral artery ruptures, often from an aneurysm, leading to bleeding into the brain tissue. Thrombotic strokes happen when a clot forms directly in a cerebral artery, usually associated with atherosclerosis. And embolic strokes occur when a clot travels from somewhere else in the body, most commonly from the heart in atrial fibrillation, and lodges in a cerebral artery. Recognizing the type is critical because management strategies differ significantly. Next, we should understand the risk factors that make patients more susceptible. The biggest one is hypertension, which is a silent killer for the brain. Other contributors include diabetes mellitus, smoking, atrial fibrillation, hyperlipidemia, obesity, and a sedentary lifestyle. As nurses, these risk factors guide our primary prevention teaching and help identify high-risk patients early. Now, what about general symptoms? Stroke can present subtly or dramatically. Watch for visual disturbances, dizziness, or loss of balance. Patients may have slurred speech or facial drooping, and one-sided weakness or numbness, clinically referred to as hemiparesis or hemiplegia. Remember, early recognition of these symptoms is essential for timely intervention. A key NCLEX pearl is understanding left versus right hemisphere strokes. The mnemonic to remember is simple. Left equals language, right equals reckless. Left-sided strokes affect language, leading to aphasia, which can be expressive, receptive, or global. Patients may also struggle with reading, writing, math, and analytical tasks, along with right-sided hemiplegia, or hemiparesis, and hemianopsia, a visual field loss. Right-sided strokes, on the other hand, often present with poor impulse control and judgment, spatial perceptual deficits, and one-sided neglect, meaning they may ignore their affected left side, along with left-sided hemiplegia, or hemiparesis. Moving on, swallowing and nutrition are vital considerations. Dysphagia is common, so always check the gag reflex before feeding. Ensure the patient is sitting upright with the neck slightly flexed forward during swallowing, and consider thickened liquids. Early referral to speech therapy can prevent aspiration and improve long-term outcomes. In terms of nursing care, proper positioning is key. Reposition frequently to prevent pressure injuries, use pillows and heel protectors, and maintain a safe environment. For patients with homonymous hemianopsia, teach the scanning technique. Encourage turning the head toward the affected side when ambulating or eating. Also, promote mobility and prevent contractures with range of motion exercises and splints. Let's discuss medications. Antiplatelets like aspirin and clopidogrel help prevent recurrent ischemic strokes, while anticoagulants are important for patients with atrial fibrillation. Thrombolytics, such as TPA or alteplase, must be administered within 4.5 hours of symptom onset, but only for ischemic strokes, which makes determining the type of stroke a crucial first step. Additional supportive medications may include antihypertensives and statins as indicated. Sometimes surgical interventions are necessary. Carotid artery angioplasty with stent can open narrowed arteries, while clot retrieval thrombectomy is an option for eligible ischemic stroke patients. Timing and eligibility are critical factors, so careful assessment and coordination with the team are required. Stroke patients are also prone to complications. Early on, aspiration and pneumonia is the most common. Increased ICP is particularly concerning in hemorrhagic strokes, and long-term patients may experience permanent disability or depression, so psychosocial support is essential. Finally, let's highlight the high-yield NCLEX pearls. Always confirm whether a stroke is ischemic or hemorrhagic before administering thrombolytics. Blood pressure must be controlled under 180/110 before giving TPA. Left-sided strokes typically present with aphasia and math or logic difficulties, while right-sided strokes are marked by impulsivity, poor judgment, and neglect. And safety is always paramount. Focus on fall prevention, aspiration precautions, and scanning techniques to protect the patient. That wraps up our focused overview of strokes. Next, we'll dive into neurological assessments and monitoring, so you can detect subtle changes early and prioritize interventions effectively, which is crucial for NCLEX success. Now that we've mastered strokes, let's turn our attention to spinal cord injuries, another critical NCLEX topic where early recognition and proper interventions can mean the difference between lifelong disability and optimal recovery. First, let's break down the types of paralysis based on injury level. Injuries to the cervical spine can result in quadriplegia or tetraplegia, meaning all four extremities are affected. If the injury is below T1, only the legs are involved, which we call paraplegia. And for injuries above C4, there's a high risk of respiratory compromise because the phrenic nerve is affected. So these patients may require intubation and mechanical ventilation. Always remember, the higher the injury, the greater the systemic impact. Next, let's talk about assessment findings. Patients may lose the ability to feel light touch, pain, or temperature, and deep tendon reflexes are often absent initially. Muscles are typically flaccid at first, but over time, depending on the level of injury, spasticity may develop. Neurogenic shock is common acutely, presenting with hypotension and bradycardia. And don't forget the loss of bowel and bladder control, as well as impaired temperature regulation, all of which are vital clues for NCLEX scenarios. A key concept to understand is upper motor neuron versus lower motor neuron lesions. Injuries above L1/L2, involving the upper motor neurons, cause spastic paralysis and a spastic neurogenic bladder, which tends to retain urine but may empty involuntarily. Injuries below L1/L2, affecting lower motor neurons, lead to flaccid paralysis and a flaccid neurogenic bladder, meaning urinary retention occurs. So intermittent catheterization is often necessary. This distinction is a classic NCLEX high-yield point. Moving on to nursing interventions, let's start with bladder and bowel management. Intermittent catheterization and structured bladder training are key, along with a bowel regimen, stool softeners, and a high-fiber diet to prevent complications. Position changes are essential to prevent orthostatic hypotension, so move the patient slowly and consider compression stockings. Skin care is also vital to prevent pressure injuries, and always maintain a clear airway, suction as needed, and monitor oxygen saturation. For patients experiencing neurogenic shock, characterized by hypotension, bradycardia, and loss of sympathetic tone, close monitoring is mandatory. Now, regarding medications, glucocorticoids like methylprednisolone can reduce spinal cord edema. Vasopressors, such as norepinephrine or dopamine, support blood pressure during neurogenic shock, while atropine may be needed for severe bradycardia. For spasticity, muscle relaxants like baclofen or dantrolene are commonly used. Each of these medications has a specific NCLEX rationale. So, know not just the drug, but why it's used. Complications are an important area. First, orthostatic hypotension. Patients should change positions slowly and use compression stockings, with vasopressors as needed. Next, autonomic dysreflexia, which occurs in injuries above T6, is a true NCLEX emergency. Triggers include a distended bladder, fecal impaction, tight clothing, or skin irritation. Classic signs are extreme hypertension, severe headache, blurred vision, bradycardia, diaphoresis above the lesion, and pallor below. Interventions include sitting the patient upright to lower BP, loosening clothing, checking for bladder distension, assessing for fecal impaction, notifying the provider, and administering antihypertensives if unresolved. Finally, patients with high cervical injuries are at risk for respiratory failure, which is always a priority. Let's wrap up with the high-yield NCLEX pearls. Injuries above C4 put the patient at risk for respiratory arrest, making airway management top priority. Remember the UMN versus LMN bladder differences. UMN equals spastic bladder. LMN equals flaccid bladder. Neurogenic shock presents with hypotension, bradycardia, and warm, dry skin, while autonomic dysreflexia presents with hypertension, bradycardia, and headache. Your first action is to sit the patient up and remove the triggering cause. And finally, always monitor for secondary complications such as pneumonia, pressure ulcers, and urinary tract infections. That concludes our focused NCLEX review of spinal cord injuries. Next, we'll explore traumatic brain injuries and rehabilitation principles, which build on these concepts and are crucial for prioritizing patient care effectively. Before we move on to the next important NCLEX topic, I want to give you something even more powerful. If you're serious about passing on your very next attempt, we've created the ultimate NCLEX crash course, a proven shortcut that has already helped over 100,000 nursing students succeed. And here's the best part. It's an all-in-one solution that gives you everything you need to pass the NCLEX: live classes and recorded lectures, 5,000 practice questions, 30 full-length practice tests, ebooks and PDF notes, a complete student planner, Nigerian Naira, questions discussed in comprehensive lectures. Literally everything required to clear the exam with confidence. Just scan the QR code on your screen or click the link in the description to enroll in the crash course and get instant access to free content like PDF notes, practice tests, and NCLEX quizzes. Plus, you can also join our Telegram and WhatsApp channels for even more free resources. Moving forward from spinal cord injuries, let's dive into critical respiratory procedures and assessments, starting with arterial blood gases, which are essential for evaluating oxygenation, ventilation, and acid-base balance. The radial artery is the most common site for ABG collection, but before you puncture, always perform the Allen's test to ensure collateral circulation via both radial and ulnar arteries. This prevents ischemic complications in the hand. After drawing the sample, firm pressure must be applied. 5 minutes for most patients, but 15 to 20 minutes if the patient is on anticoagulants. Be aware of potential complications. Hematoma is common and managed with pressure, whereas air embolism is rare but life-threatening. If it occurs, position the patient on the left side in Trendelenburg. Monitor for shortness of breath, chest pain, anxiety, and air hunger, and notify the provider immediately. Remember, on the NCLEX, air embolism is always a red flag emergency. Next, let's discuss bronchoscopy, which allows direct visualization of the airway, removal of secretions or lesions, and collection of biopsies. Pre-procedure care includes keeping the patient NPO for 8 to 12 hours, administering atropine to reduce secretions, and applying a local anesthetic like lidocaine to the throat. Post-procedure, your priority is airway assessment. Expect blood-tinged sputum, dry cough, or a sore throat, which are normal, but watch for bronchospasm, stridor, or dyspnea, which are emergencies. Do not allow oral intake until the gag reflex returns, typically around 2 hours after the procedure. NCLEX often tests this, so always check airway first. Never rush to give fluids or food. Finally, let's cover thoracentesis, a procedure where a needle is inserted into the pleural space to remove fluid or air, instill medications, or obtain diagnostic samples. Patients may present with shortness of breath, cough, or chest pain beforehand. Proper positioning is critical. Have the patient sit upright, leaning forward over the bedside table with arms supported, and instruct them to remain completely still. Never remove more than 1 liter of fluid per session, as exceeding this can cause cardiovascular collapse. Post-procedure, monitor respiratory status, breath sounds, oxygen saturation, and vital signs frequently. Complications include pneumothorax, which presents as sudden dyspnea, tracheal deviation, asymmetric chest movement, tachycardia, and shallow respirations. Also watch for mediastinal shift, bleeding, infection, or hypotension if significant internal bleeding occurs. Here are the high-yield NCLEX pearls to lock in. For ABGs, always perform the Allen's test and remember air embolism equals left side plus Trendelenburg. For bronchoscopy, ensure NPO before, gag reflex after, and know that blood-tinged sputum is expected, but bronchospasm is a priority emergency. For thoracentesis, sit the patient upright leaning forward, limit removal to 1 liter, and monitor for pneumothorax. Sudden dyspnea with tracheal deviation is a red flag. Understanding these procedures not only helps you pass the NCLEX, but ensures safe, effective patient care in real clinical settings. Because airway, oxygenation, and hemodynamics always come first. Continuing from thoracentesis, let's now focus on chest tubes, which are critical in managing pleural space problems like pneumothorax, hemothorax, pleural effusion, or after thoracic surgery. Understanding the indications and proper placement is essential. Remember, air rises. So for a pneumothorax, the chest tube tip points up toward the shoulder, whereas blood or fluid settles. So for hemothorax or effusion, the tip is directed down toward the posterior or inferior chest. The chest tube drainage system has 3 key chambers. The collection chamber receives fluid or blood from the pleural space, and documentation is crucial. Hourly for the first 24 hours, then every 8 hours. If drainage exceeds 70 milliliters per hour, the provider must be notified immediately, as this could indicate ongoing bleeding. Next is the water seal chamber, which contains 2 centimeters of sterile water acting as a one-way valve, allowing air to exit but preventing re-entry. Titling, the rise and fall of fluid with respiration, is expected and a sign the system is working. However, continuous bubbling indicates an air leak, which is abnormal and requires intervention. The suction control chamber regulates pressure, usually at negative 20 centimeters of water. For wet suction, gentle continuous bubbling is normal, while dry suction relies on a regulator and should show no bubbling. Nursing care focuses on promoting lung expansion and patient safety. Position the patient in semi or high Fowlers, and encourage coughing, deep breathing, and incentive spirometry every 2 hours. Check the water seal level every 2 hours and refill as needed, and mark drainage levels with time and date at the end of each shift. An X-ray after insertion confirms proper placement. Essential supplies must always be at the bedside: sterile water, occlusive dressing with petroleum gauze, and enclosed hemostats for provider use only. Safety cannot be overstated. Never strip, milk, or clamp tubing unless specifically ordered by the provider. If the system breaks, place the distal end in sterile water to re-establish the water seal. If the tube is accidentally pulled out, cover the site with an occlusive dressing taped on 3 sides, allowing air to escape while preventing attention pneumothorax. During removal, instruct the patient to take a deep breath, exhale, and perform the Valsalva maneuver to prevent air entry, then apply a petroleum gauze dressing. Be alert for complications. Tension pneumothorax can occur if the tube is kinked or clamped too long. Signs include tracheal deviation away from the affected side, absent breath sounds on that side, dyspnea, chest asymmetry, and respiratory distress. Other complications include infection and re-expansion pulmonary edema, especially if a large volume is drained too quickly. For the NCLEX, here are the pearls to remember. Titling is normal, but continuous bubbling signals an air leak. Report drainage over 70 milliliters per hour immediately. Never tape an occlusive dressing on all 4 sides if the chest tube comes out. Always leave one side untaped. Keep sterile water and an occlusive dressing at the bedside at all times. And during removal, the Valsalva maneuver prevents air embolism. Mastering these points ensures both safe patient care and NCLEX success. Before we move on to the next important NCLEX topic, I want to give you something even more powerful. If you're serious about passing on your very next attempt, we've created the ultimate NCLEX crash course, a proven shortcut that has already helped over 100,000 nursing students succeed. And here's the best part. It's an all-in-one solution that gives you everything you need to pass the NCLEX. Live classes and recorded lectures, 5,000 practice questions, 30 full-length practice tests, ebooks and PDF notes, a complete student planner, Nigerian Naira, questions discussed in comprehensive lectures. Literally everything required to clear the exam with confidence. Just scan the QR code on your screen or click the link in the description to enroll in the crash course and get instant access to free content like PDF notes, practice tests, and NCLEX quizzes. Plus, you can also join our Telegram and WhatsApp channels for even more free resources. Shifting our focus from chest tubes, let's now discuss oxygen therapy and mechanical ventilation, which are fundamental in managing respiratory compromise. Oxygen delivery devices vary in flow, FiO2, and clinical use. A nasal cannula delivers 1 to 6 liters per minute, providing a FiO2 of 24 to 44%. And while comfortable, it can dry the nasal mucosa. A simple face mask delivers 5 to 8 liters per minute with FiO2 of 40 to 60%. But remember that 5 liters is the minimum to prevent carbon dioxide rebreathing. A partial rebreather mask requires 6 to 11 liters per minute. and the reservoir bag must stay partially inflated. For the highest non-intubated oxygen delivery, a non-rebreather mask provides 10 to 15 liters per minute, achieving FiO2 of 80 to 95%. Always ensure the reservoir bag is 2/3 full and check valves and flaps hourly. A Venturi mask delivers the most precise oxygen concentration, making it ideal for chronic obstructive pulmonary disease patients, while aerosol masks or face tents are reserved for facial trauma, burns, or post-operative airway surgeries. Recognizing hypoxia early is critical for prompt intervention. Early signs include tachypnea and tachycardia, restlessness, anxiety, pale skin, and hypertension, often accompanied by respiratory distress with nasal flaring, use of accessory muscles, or adventitious breath sounds. If untreated, hypoxia progresses to late signs such as confusion, stupor, cyanosis, bradypnea, bradycardia, hypotension, and dysrhythmias, which can rapidly become life-threatening. Oxygen therapy must always follow safety precautions. Use the lowest effective oxygen level, avoid prolonged high oxygen delivery to prevent oxygen toxicity, and keep smoking, oils, flammable substances, and synthetic fabrics away from oxygen sources. For COPD patients, maintain SpO2 between 88 and 92%, as over-oxygenation may suppress respiratory drive. Non-invasive ventilation is an important tool before intubation or after weaning. Continuous positive airway pressure, or CPAP, maintains constant airway pressure, often used for sleep apnea, whereas bi-level positive airway pressure, or BiPAP, provides 2 pressure levels, useful for sleep apnea or ventilator weaning. For mechanically ventilated patients, ensure suctioning of the endotracheal tube as needed under sterile technique, perform frequent oral care and repositioning, and always have a manual resuscitation bag with oxygen at the bedside. After extubation, encourage coughing, deep breathing, and use of the incentive spirometer, and monitor oxygen saturation and vital signs every 5 minutes initially. Ventilator alarms can indicate serious issues. Remember the NCLEX formula: high pressure equals a kink or obstruction, and low pressure equals a leak or disconnection. Low pressure alarms can result from disconnection, cuff leak, or tube displacement, while high pressure alarms may indicate secretions, mucus plugs, patient biting the tube, kinked tubing, coughing, bronchospasm, pulmonary edema, or pneumothorax. Immediate assessment of the patient, airway, and ventilator is required to prevent complications. Finally, some high-yield NCLEX pearls. The Venturi mask is the most precise oxygen delivery, especially for COPD. The non-rebreather mask delivers the highest FiO2 short of intubation. Early hypoxia manifests as restlessness and tachycardia, while late hypoxia presents with cyanosis and bradycardia. Always assess ventilator alarms. High alarms signal obstruction, low alarms signal disconnection. After extubation, monitor the patient closely and keep emergency re-intubation equipment ready. Mastery of these concepts ensures safe respiratory care and NCLEX readiness. Moving forward from oxygen therapy, let's focus on asthma, a chronic inflammatory disorder of the airways that leads to intermittent and reversible airflow obstruction. Patients often present with wheezing, typically expiratory first, along with coughing, prolonged exhalation, and decreased oxygen saturation. In chronic cases, especially when asthma overlaps with COPD, a barrel-shaped chest may develop due to long-term hyperinflation of the lungs. Diagnosis relies on pulmonary function tests, which confirm the disorder and help monitor its progression. Additionally, patients often use a peak flow meter at home to track lung function. Perform the test 3 times and record the highest value, interpreting results using the traffic light system: green for good control, yellow for caution, and red for emergency, prompting immediate intervention. Nursing interventions focus on maximizing oxygenation and relieving airway obstruction. Positioning the patient in high Fowlers helps lung expansion, while administering oxygen as prescribed supports tissue oxygenation. Continuous monitoring of respiratory effort and oxygen saturation is essential, especially during acute exacerbations. Medications are divided into rescue and long-term control categories. Rescue medications include albuterol, a short-acting beta-2 agonist that provides rapid bronchodilation, though it may cause tremors and tachycardia, and ipratropium, an anticholinergic that relieves bronchospasm, with dry mouth as a common side effect that can be managed by sucking on sugar-free candies and increasing fluid intake. For long-term control, salmeterol, a long-acting beta-2 agonist, is used for prevention and should never be used for acute attacks. Theophylline, a methylxanthine bronchodilator, requires careful monitoring for toxicity, presenting as nausea, vomiting, tachycardia, or even seizures. Glucocorticoids, whether inhaled or oral, reduce airway inflammation, and patients must rinse their mouth after inhalation to prevent oral thrush. Leukotriene receptor antagonists, such as montelukast, are particularly helpful for allergy-related or exercise-induced asthma. A critical complication to recognize is status asthmaticus, a life-threatening severe airway obstruction that does not respond to standard therapy. Management requires high-flow oxygen, continuous nebulized bronchodilators like albuterol and epinephrine if severe bronchospasm occurs, with preparation for possible intubation and mechanical ventilation if the patient deteriorates. High-yield NCLEX pearls include remembering that the peak flow meter result is the highest of 3 readings. Albuterol is the rescue drug, while salmeterol is for prevention, and mouth rinsing after inhaled steroids prevents thrush. Also, manage dry mouth from ipratropium with candies or fluids, and always recognize status asthmaticus as an emergency requiring oxygen, bronchodilators, epinephrine, and possibly intubation. Mastery of these interventions ensures effective asthma management and safety in both acute and chronic care settings. Shifting our focus to pulmonary embolism, or PE, this is a sudden obstruction of the pulmonary artery caused by a solid, liquid, or gas embolus, with the most common origin being a deep vein thrombosis from the legs or pelvis. Risk factors are diverse and include oral contraceptive or estrogen therapy, tobacco use, obesity, and a sedentary lifestyle, as well as recent surgery, particularly orthopedic, pelvic, or abdominal procedures. Patients with long bone fractures may develop a fat embolism, while hypercoagulable states such as cancer or clotting disorders and conditions like atrial fibrillation further increase PE risk. Clinically, PE often presents suddenly with dyspnea, tachypnea, chest pain, anxiety, and a sense of impending doom, accompanied by tachycardia, hypotension, cough, and sometimes hemoptysis. In cases of fat embolism, petechiae may appear, and patients usually demonstrate low oxygen saturation and adventitious lung sounds on assessment. Diagnostics play a critical role in confirming PE. D-dimer elevation indicates clot degradation, while CT angiography remains the gold standard for diagnosis. Arterial blood gas analysis may reveal hypoxemia, and a ventilation perfusion scan can show perfusion defects. Nursing care begins with positioning the patient in high Fowlers to improve oxygenation, administering O2 therapy to maintain SpO2 above 95%, and frequent monitoring of vital signs and lung sounds. Emotional support is essential, as anxiety is common due to the sudden and life-threatening nature of PE. Medication management focuses on preventing clot extension, dissolving existing clots, and minimizing complications. Anticoagulants include heparin intravenously, with a therapeutic APTT of 60 to 80 seconds, enoxaparin subcutaneously as a low molecular weight heparin, and warfarin orally, monitored with PT/INR aiming for 2 to 3. Patient teaching is key. Maintain consistent vitamin K intake from green leafy vegetables. Avoid aspirin and NSAIDs. Use a soft toothbrush and electric razor. Avoid prolonged sitting or crossing legs, and use compression stockings while encouraging mobility. For massive or life-threatening PE, thrombolytics such as alteplase, streptokinase, or urokinase may be administered cautiously due to high bleeding risk and should be infused slowly to reduce hypertension. Potential complications include cardiogenic shock, pulmonary infarction, hypoxemia leading to respiratory failure, and right-sided heart failure, also called cor pulmonale. High-yield NCLEX pearls emphasize that the most common cause of PE is DVT, and the first action when PE is suspected is to raise the head of the bed, apply oxygen, and call the provider immediately. Anticoagulants prevent clot extension, while thrombolytics actively dissolve clots. Remember therapeutic ranges: INR 2 to 3 for warfarin and a PTT 1.5 to 2.5 times normal for heparin. Consistency in vitamin K intake is crucial. It should not be avoided entirely. Finally, petechiae in a patient with a long bone fracture is a clue suggesting fat embolism rather than a standard thrombotic PE. Recognizing these clinical cues and interventions ensures timely, life-saving care for pulmonary embolism. Now, let's dive into cardiac assessment and diagnostics, starting with cardiac biomarkers, which are essential for myocardial infarction diagnosis. Troponins T and I are the most specific indicators of cardiac injury. Normally, their levels are 0.00 to 0.04 nanograms per milliliter, but they rise within 3 hours of a myocardial infarction. Troponin I remains elevated for about 7 days, whereas troponin T can stay elevated for 2 to 3 weeks, making both useful for different time frames after an MI. Myoglobin, on the other hand, rises the earliest, within 2 hours after ischemia, but it is nonspecific because skeletal muscle injury can also increase its levels, and it returns to normal within 24 hours. Creatine kinase MB, CKMB, is specific for cardiac muscle, rises in 3 to 6 hours, peaks around 24 hours, and normalizes within 2 to 3 days, helping to confirm cardiac injury when troponins are unavailable or delayed. Next, evaluating cardiac risk includes reviewing the lipid profile, where total cholesterol should be less than 200 milligrams per deciliter. HDL or good cholesterol ranges from 35 to 70, with higher levels being protective. LDL should ideally be less than 100, and triglycerides should remain under 150. Moving on to echocardiography, this non-invasive ultrasound measures heart structure and function, providing data on ejection fraction and wall motion, with a normal EF ranging from 55 to 70%. To assess the heart under stress, exercise or pharmacologic stress tests are used. Patients are typically NPO for 2 to 4 hours, and they should avoid tobacco, alcohol, and caffeine while wearing comfortable clothing and shoes for the treadmill, or allowing medications like adenosine or dobutamine to safely increase heart rate for those unable to exercise. For hemodynamic monitoring in the ICU, invasive devices such as an arterial line or pulmonary artery catheter are used. Central venous pressure, CVP, normally ranges from 1 to 8 millimeters of mercury, and elevations in CVP, pulmonary artery pressure, or pulmonary artery wedge pressure, combined with decreased cardiac output, indicate heart failure. Arterial lines require precise care. The transducer must be leveled at the phlebostatic axis, zeroed after placement, and placement is confirmed with a chest X-ray. Coronary angiography or cardiac catheterization is an invasive procedure to detect coronary artery blockages. Before the procedure, patients must be NPO for 8 hours, screened for iodine or shellfish allergy due to contrast dye, and have renal function assessed. Post-procedure care includes lying flat for 4 to 6 hours to prevent bleeding, frequent vital signs checks starting every 15 minutes, then every 30 minutes, and finally, hourly for several hours. The groin site should be monitored for bleeding or hematoma, and pedal pulses, temperature, and color of the extremity are closely observed. Adequate fluids are encouraged to flush the dye, and if a stent is placed, antiplatelet or anticoagulant therapy is continued for 6 to 8 weeks to prevent thrombosis. A life-threatening complication to watch for is cardiac tamponade, which is identified by Beck's triad: hypotension, jugular vein distension, and muffled heart sounds, along with a paradoxical pulse defined as a drop in systolic blood pressure greater than 10 millimeters of mercury on inspiration. The emergency treatment is pericardiocentesis, where the excess pericardial fluid is aspirated with a needle. High-yield NCLEX pearls include remembering that troponin is the most specific marker for myocardial infarction. Myoglobin rises first, but is nonspecific, and an ejection fraction below 40% signals heart failure. After cardiac catheterization, patients must remain flat for 4 to 6 hours, with vigilant monitoring of bleeding and distal pulses, and CVP should be maintained between 1 and 8 millimeters of mercury. Recognizing cardiac tamponade quickly is crucial because hypotension, jugular vein distension, and muffled heart sounds represent a medical emergency requiring immediate intervention. Shifting our focus now to cardiac rhythm management, let's explore pacemakers, which are devices used to maintain an adequate heart rate in patients with conduction problems. Pacemakers can function in 2 main modes: fixed rate, also called asynchronous, which fires at a constant rate regardless of the patient's intrinsic heart activity, and demand or synchronous mode, which monitors the heart's intrinsic activity and fires only when the heart rate falls below a preset threshold. Indications include symptomatic bradycardia, complete heart block, sick sinus syndrome, and certain heart failure patients who require biventricular pacing. Immediately after insertion, patients are advised to minimize shoulder movement on the affected side, and a sling may be used to prevent lead dislodgement. Self-monitoring is crucial. Patients should check their pulse daily and report sudden changes, and hiccups may indicate lead displacement because the diaphragm is being stimulated. Lifestyle and safety education includes carrying a pacemaker ID card, avoiding heavy lifting or contact sports for about 2 months, and staying away from magnets or devices like garage door openers that can interfere with pacemaker function. Microwaves are safe, but MRI is contraindicated unless the pacemaker is MRI compatible, and airport security can trigger alarms, so patients should notify TSA agents. If an implantable cardioverter defibrillator is present, patients may receive shocks, but bystanders are safe. Common complications include infection at the insertion site, lead displacement or malfunction, pneumothorax or hemothorax, and pacemaker syndrome, which is hemodynamic instability due to pacing. High-yield NCLEX points are that fixed pacemakers fire constantly. Demand pacemakers fire only when needed. Hiccups post-insertion indicate lead displacement. Post-op patients require a sling and limited shoulder movement. MRIs are contraindicated, and pacemaker ID cards should always be carried. Before we jump into the next NCLEX topic, I want to give you something that could completely change your preparation. If you're aiming to pass on your very next attempt, the Ultimate NCLEX Crash Course is your shortcut, already trusted by more than 100,000 nursing students who cleared their exam successfully. What makes it different? It's an all-in-one package designed to cover every part of your NCLEX prep. Interactive live classes and easy-to-watch recorded lectures. 5,000 exam-style practice questions. 30 complete practice tests. Ebooks and PDF notes for revision. A ready-to-use student planner. Nigerian Naira questions broken down in detail during comprehensive lectures. This isn't just another review, it's everything you need in one place. Scan the QR code right now or use the link in the description to enroll instantly and grab free content, including PDF notes, practice tests, and NCLEX quizzes. You'll also get access to our Telegram and WhatsApp channels for even more free resources to keep you ahead. Now, let's transition to myocardial infarction and cardiac interventions, a critical NCLEX topic. An MI occurs when a coronary artery is blocked, leading to ischemia and necrosis of heart tissue. Classic symptoms include crushing chest pain radiating to the jaw or left arm, but in women and elderly patients, presentation may be atypical, manifesting as nausea, diaphoresis, dyspnea, fatigue, or non-classic chest discomfort. EKG findings help differentiate STEMI, which shows ST elevation and is the most dangerous, from NSTEMI, which shows ST depression or T-wave inversion. Troponins remain the most specific laboratory markers for myocardial injury. Percutaneous coronary intervention, PCI, also known as angioplasty, aims to open blocked arteries using balloon inflation, stent placement, or plaque removal, and must be performed within 90 minutes of symptom onset, the critical door-to-balloon time. Pre-procedure care includes NPO for 8 hours, screening for iodine or shellfish allergy due to contrast dye, and assessing renal function. During the procedure, sedation is provided with agents like midazolam or fentanyl. Post-procedure, patients are kept flat for 4 to 6 hours, with frequent vital sign monitoring to detect hypotension or tachycardia, which may indicate bleeding. The groin site must be inspected for hematoma or bleeding, and pedal pulses, skin color, and temperature are checked frequently. Fluids are encouraged to flush the contrast dye, and if a stent is placed, antiplatelet therapy such as aspirin or clopidogrel is continued, while strenuous activity and heavy lifting are avoided. A critical complication to monitor is cardiac tamponade, identified by Beck's triad. Hypotension, jugular vein distension, and muffled heart sounds, often accompanied by a paradoxical pulse. Treatment requires pericardiocentesis, an emergency procedure to remove excess pericardial fluid. For patients undergoing coronary artery bypass grafting, CABG, the saphenous vein or internal mammary artery is used to bypass blocked coronary arteries. Postoperative care involves encouraging coughing, deep breathing, and incentive spirometry to prevent pneumonia, monitoring chest tube drainage carefully. Over 150 milliliters per hour is concerning for hemorrhage, controlling pain, promoting early ambulation, preventing infection, and providing lifestyle education on diet, smoking cessation, and exercise. For peripheral artery bypass grafting, used in patients with peripheral arterial disease, symptoms include intermittent claudication, rest pain, decreased or absent pulses, hairless shiny legs, dusky or mottled skin, and thick toenails. Postoperative care involves NPO 8 hours pre-procedure, no leg crossing, bed rest for 18 to 24 hours with legs straight, frequent neurovascular checks, and compression stockings to promote blood flow. Be alert for compartment syndrome, a medical emergency caused by bleeding or swelling that increases pressure and decreases perfusion, manifested by the 5 Ps: pain out of proportion, pulselessness, paresthesia, paralysis, and pallor, which requires urgent fasciotomy. High-yield NCLEX pearls include that PCI must be done within 90 minutes of MI symptoms. Post-PCI patients remain flat for 4 to 6 hours while monitoring groin site and pulses. MI in women can present atypically. CABG chest tube drainage over 150 milliliters per hour requires immediate provider notification. Cardiac tamponade is an emergency diagnosed by Beck's triad. PAD pain improves in a dependent position, and compartment syndrome requires prompt fasciotomy. Now that we've covered heart failure and pulmonary edema, let's transition to valvular heart disease, which affects the structure and function of the heart's valves. The key concept is that valves either narrow, called stenosis, which restricts blood flow, or become insufficient, also called regurgitation, which allows blood to flow backward. Both conditions almost always produce murmurs or extra heart sounds, making auscultation critical in assessment. The causes of valvular disease are varied. Rheumatic fever following untreated strep infections is a major contributor, while infective endocarditis, often from streptococcal bacteria, can directly damage valves. Other risk factors include prolonged hypertension that increases afterload, congenital malformations, connective tissue disorders such as Marfan syndrome, and even normal aging, which leads to fibrotic thickening and calcification of the valves. Clinically, patients may present with murmurs, extra heart sounds, and arrhythmias like atrial fibrillation. Mitral valve dysfunction can lead to pulmonary congestion, so you might hear crackles in the lungs. Other symptoms reflect decreased cardiac output and include fatigue, dyspnea, chest pain, and syncope. Accurate diagnosis is essential and usually involves echocardiography, which provides the best visualization of valve structure and ejection fraction, chest X-rays to identify chamber enlargement, and EKGs to detect arrhythmias. Management involves medications to address preload, afterload, and contractility. Loop diuretics, such as furosemide or bumetanide, reduce preload but can cause hypokalemia, so patients should consume potassium-rich foods like potatoes, leafy greens, melons, and oranges. An IV potassium replacement should never exceed 20 milliequivalents per minute. ACE inhibitors reduce afterload, but may cause cough, angioedema, and hyperkalemia, while ARBs are used as alternatives. Beta blockers lower heart rate and workload, and calcium channel blockers, such as diltiazem or verapamil, reduce afterload as well. To increase contractility, digoxin is employed, but it must be held if heart rate is below 60 beats per minute, and nurses must monitor for toxicity, including fatigue, weakness, nausea, vomiting, and visual changes like yellow halos. When medications are insufficient, procedural interventions are indicated. Percutaneous balloon valvuloplasty uses a balloon to open a stenotic valve, while valve repair aims to preserve the native valve whenever possible. If repair is not feasible, valve replacement with a prosthetic or bioprosthetic valve is necessary. Mechanical valves require lifelong anticoagulation with warfarin, targeting an INR of 2 to 3.5, while all patients with prosthetic valves or valve repairs require prophylactic antibiotics before dental or surgical procedures to prevent infective endocarditis. High-yield NCLEX pearls to remember include that a history of strep infection is the biggest risk factor for valve disease. Always assess for murmurs. Loop diuretics can cause hypokalemia, while ACE inhibitors can lead to hyperkalemia. Digoxin should only be given if heart rate is above 60, with careful monitoring for toxicity. And prosthetic valves require antibiotics before procedures, with mechanical valves needing lifelong warfarin therapy. Recognizing these details is essential for both patient safety and NCLEX success. As we move forward from valvular heart disease, let's focus on inflammatory disorders of the heart, which are largely caused by infection and immune responses. The most important risk factor is streptococcal infection, which can progress to rheumatic fever, rheumatic endocarditis, or infective endocarditis, emphasizing the NCLEX principle that promptly treating strep throat with antibiotics is critical to prevent cardiac complications. Additional risk factors include intravenous drug use, overcrowded living conditions, and low socioeconomic status, all of which increase the likelihood of bacterial infections affecting the heart. Starting with pericarditis, which is inflammation of the pericardium, patients typically report chest pain and pressure, often accompanied by a pericardial friction rub, a grating sound heard on auscultation, and dyspnea. A hallmark feature is that the pain improves when the patient sits up and leans forward, which is a classic NCLEX cue. A serious complication is cardiac tamponade, a life-threatening condition characterized by Beck's triad: hypotension, jugular venous distension, and muffled heart sounds. Moving to rheumatic endocarditis, this usually occurs after an untreated strep throat or upper respiratory infection. It causes lesions in the heart, particularly on the valves, leading to murmurs, and patients may also present with fever, chest pain, shortness of breath, petechiae or rashes on the trunk and extremities, friction rubs, and muscle spasms. This reinforces the NCLEX principle that strep infections should never be ignored, as they can trigger both valvular and inflammatory heart disease. Infective endocarditis is often due to strep infection or intravenous drug use and presents with fever and flu-like symptoms, a new or changing murmur, and skin manifestations such as petechiae, splinter hemorrhages under the nails, Janeway lesions on the palms and soles, and Osler's nodes on fingers or toes. NCLEX students should note that the combination of murmur plus peripheral lesions is a classic hallmark of endocarditis. Diagnostics focus on identifying the causative organism and assessing cardiac damage. Blood cultures are critical to identify bacteria, while throat cultures help confirm streptococcal infection. Inflammatory markers such as elevated erythrocyte sedimentation rate, ESR, and C-reactive protein, CRP, support the diagnosis. An echocardiography may reveal valve damage or vegetations. Treatment and nursing care emphasize both infection control and symptom management. Long-term intravenous antibiotics are the cornerstone, especially for endocarditis. NSAIDs help reduce fever and inflammation, while glucocorticoids may be used in severe inflammation. If a patient develops cardiac tamponade or significant pericardial effusion, pericardiocentesis is an emergency intervention. Additionally, prophylactic antibiotics are required before dental or invasive procedures for patients with valve disease or a history of endocarditis to prevent recurrence. Complications can be severe. Cardiac tamponade is an immediate emergency. Valve damage can lead to regurgitation or stenosis, resulting in heart failure. An embolization from vegetation in infective endocarditis can cause strokes, organ infarctions, or other systemic complications. High-yield NCLEX pearls include that streptococcal infection is the primary cause of both rheumatic and valvular heart disease. So, always treat strep promptly. Pericarditis pain improves with leaning forward. Endocarditis is indicated by a murmur plus petechia or splinter hemorrhages. Cardiac tamponade is an emergency requiring pericardiocentesis, and patients with valve disease or prior endocarditis must receive prophylactic antibiotics before dental or invasive procedures. Recognizing these signs and interventions is essential for both patient safety and NCLEX success. Transitioning from cardiac disorders, let's now focus on peripheral vascular disorders, which involve problems with blood flow in the extremities, either through arteries or veins. Starting with peripheral arterial disease, or PAD, the primary cause is atherosclerosis, which reduces arterial blood flow to the legs and feet. Key risk factors include smoking, obesity, hypertension, diabetes, hyperlipidemia, and a sedentary lifestyle, all of which accelerate plaque buildup. Patients often present with intermittent claudication, a burning or cramping pain during exercise that is relieved by rest or dangling the legs. Pain is typically worse when the legs are elevated and relieved when dependent. And on examination, you may notice delayed capillary refill, greater than 3 seconds, weak or absent pulses, shiny hairless skin, thick toenails, cool mottled skin, and pallor on elevation with rubor when dependent. PAD ulcers tend to occur on the toes or feet, appearing dry, black, and sometimes progressing to gangrene, which makes early recognition essential. Nursing interventions include encouraging walking until pain develops, then resting, and gradually increasing distance, avoiding leg crossing or restrictive clothing, keeping legs warm, and eliminating vasoconstrictive factors like nicotine, caffeine, and stress. Medications include antiplatelets such as aspirin or clopidogrel, statins to lower cholesterol, and procedures such as angioplasty, stent placement, or bypass grafting, with the important post-bypass instruction to keep the limbs straight for 6 to 8 hours. Complications like graft occlusion can present as diminished pulses, color and temperature changes, and increased pain, while compartment syndrome is recognized by the 5 Ps: pain, pallor, pulselessness, paresthesia, and paralysis, and requires immediate intervention, often a fasciotomy. On the venous side, we encounter venous thromboembolism, venous insufficiency, and varicose veins. Venous thromboembolism, including deep vein thrombosis, DVT, results from Virchow's triad: venous stasis, hypercoagulability, and vessel wall injury. Risk factors include hip or knee surgery, immobility, pregnancy, oral contraceptive use, obesity, and heart failure. Patients often report calf or groin pain and tenderness, sudden unilateral extremity swelling, warmth, and induration, with the serious risk that a clot can dislodge and cause a pulmonary embolism, presenting as chest pain and sudden dyspnea. Nursing care involves elevating the extremity above heart level, applying warm, moist compresses, never massaging the leg, using compression stockings once swelling subsides, and avoiding pillows under the knees. Medication management includes heparin intravenous, with a PTT monitoring and protamine sulfate as the antidote, and warfarin orally, with PT/INR monitoring and vitamin K as the antidote, remembering the bridging strategy of overlapping heparin and warfarin until INR is therapeutic. Safety measures include soft toothbrushes, electric razors, and avoiding aspirin to reduce bleeding risk, while thrombolytics like alteplase are reserved for severe clots due to high bleeding risk. Chronic venous insufficiency arises from incompetent valves, causing blood pooling in the lower extremities. Patients develop brown discoloration from the ankles to the calves, edema, and stasis ulcers, usually on the ankles or medial malleolus. Nursing management emphasizes frequent leg elevation, wearing compression stockings after swelling decreases, and avoiding prolonged standing or sitting. Varicose veins are more common in females, those who are pregnant, obese, older, or with a family history, presenting as enlarged, twisted, bulging superficial veins. Management includes elevating legs when supine, sclerotherapy to collapse veins, or vein stripping surgery for severe cases. Diagnostics for venous disorders include D-dimer testing, which increases with clot formation, and venous duplex ultrasonography to confirm DVT. High-yield NCLEX pearls include that PAD pain improves when legs are dependent, whereas venous pain improves with elevation. PAD ulcers appear on toes and are dry/black. While venous ulcers are wet, stasis-related, and located near the ankles, PAD presents with weak or absent pulses, while venous disorders usually have normal pulses. But edema, antidotes include protamine sulfate for heparin and vitamin K for warfarin, and that you should never massage a DVT leg. Additionally, recognizing compartment syndrome early using the 5 Ps is critical to prevent permanent damage. Shifting from vascular disorders, let's now focus on hypertension, a condition often called the silent killer, because many clients remain asymptomatic until organ damage occurs. Blood pressure classifications are essential to recognize. Normal is less than 120 over 80 millimeters of mercury. Elevated or pre-hypertension is 120 to 129 systolic with a diastolic below 80. Stage 1 hypertension is 130 to 139 systolic or 80 to 89 diastolic. Stage 2 is greater than or equal to 140 systolic or 90 diastolic. And a hypertensive crisis occurs at 180 systolic or 120 diastolic and above. Hypertension can be primary, with no identifiable cause and the most common type, or secondary, due to another condition like kidney disease, Cushing's syndrome, pheochromocytoma, or certain medications. Key risk factors include African American ethnicity, excess sodium intake, obesity, sedentary lifestyle, smoking, alcohol use, hyperlipidemia, stress, and family history. Clinically, many clients show no symptoms, but when blood pressure is uncontrolled or severe, headaches, dizziness, and visual changes may occur, and long-term damage can affect the heart, brain, kidneys, and eyes. Before we jump into the next NCLEX topic, I want to give you something that could completely change your preparation. If you're aiming to pass on your very next attempt, the Ultimate NCLEX Crash Course is your shortcut. Already trusted by more than 100,000 nursing students who cleared their exams successfully. What makes it different? It's an all-in-one package designed to cover every part of your NCLEX prep. Interactive live classes and easy-to-watch recorded lectures. 5,000 exam-style practice questions. 30 complete practice tests. Ebooks and PDF notes for revision. A ready-to-use student planner. Nigerian Naira questions broken down in detail during comprehensive lectures. This isn't just another review, it's everything you need in one place. Scan the QR code right now or use the link in the description to enroll instantly and grab free content, including PDF notes, practice tests, and NCLEX quizzes. You'll also get access to our Telegram and WhatsApp channels for even more free resources to keep you ahead. Medication management is a cornerstone of therapy. Diuretics such as thiazides like hydrochlorothiazide or loop diuretics like furosemide can cause hypokalemia, while potassium-sparing diuretics like spironolactone can cause hyperkalemia. So monitoring electrolytes is essential. Calcium channel blockers, including verapamil, amlodipine, and diltiazem, may cause constipation, hypotension, and peripheral edema. And clients should avoid grapefruit juice due to increased drug toxicity. ACE inhibitors, such as medications ending in pril, can lead to a persistent dry cough, angioedema, and hyperkalemia, while ARBs, sartan, may also cause angioedema and hyperkalemia and can exacerbate heart failure. Aldosterone antagonists like eplerenone and spironolactone similarly risk hyperkalemia, hyponatremia, and increased triglycerides. And clients must avoid salt substitutes high in potassium. Beta blockers, LOL, can result in fatigue, weakness, and sexual dysfunction, and importantly, mask hypoglycemia symptoms, requiring caution in diabetic clients. Non-selective beta blockers should be avoided in asthma or COPD due to bronchospasm risk. Central alpha agonists, including clonidine and methyldopa, may produce sedation, orthostatic hypotension, and rebound hypertension if discontinued abruptly, highlighting the importance of gradual tapering. A hypertensive crisis, defined as a blood pressure greater than or equal to 180/120, is a medical emergency. Clients may present with severe headache, blurred vision, dizziness, and confusion, requiring ICU admission. Intravenous antihypertensives such as nitroprusside, nicardipine, or labetalol, and careful BP monitoring to avoid rapid drops that could cause organ ischemia. Nursing care includes slow position changes to prevent orthostatic hypotension, dietary sodium restriction with a DASH-style diet, promoting weight loss and regular exercise, encouraging smoking cessation, home blood pressure monitoring, and reporting facial or lip swelling, as this may indicate angioedema from ACE inhibitors or ARBs. High-yield NCLEX pearls include remembering that ACE inhibitors are associated with cough, angioedema, and elevated potassium. Calcium channel blockers require avoiding grapefruit juice. Beta blockers can mask hypoglycemia and are contraindicated in asthma. Hypertensive crisis presents with severe headache and visual disturbances requiring IV nitroprusside, and that hypertension is often asymptomatic until organ damage occurs, reinforcing the need for early detection and consistent management. Let's quickly review hemodynamic shock, a life-threatening state of inadequate tissue perfusion causing cellular hypoxia and organ failure. Key signs include low blood pressure, elevated heart rate, and urine output below 30 milliliters per hour. Shock types differ by cause. Cardiogenic shock stems from pump failure, like myocardial infarction or heart failure. Management includes oxygen, diuretics, vasodilators, and inotropes, such as dobutamine. Hypovolemic shock is due to fluid or blood loss. Treat with intravenous crystalloids and transfusions if hemorrhage. Obstructive shock occurs from blockages like pulmonary embolism, tension, pneumothorax, or tamponade, requiring relief of the obstruction. Distributive shock involves widespread vasodilation. Septic shock presents with initial warm skin, hypotension, tachycardia, and later cold extremities. Care includes blood cultures, broad-spectrum antibiotics, intravenous fluids, and vasopressors. Neurogenic shock is unique with hypotension plus bradycardia after spinal cord injury above T6, treated with fluids, vasopressors, and atropine. Anaphylactic shock is an allergic emergency with airway compromise, wheezing, hypotension, and tachycardia. Immediate epinephrine and airway support are critical. General signs include tachypnea, hypotension, tachycardia, low urine output, cool, clammy skin, except early septic shock, altered mental status, and elevated lactic acid. Nursing priorities: leg elevation, oxygen therapy, IV fluids, vasopressors, and close hemodynamic monitoring. Complications of untreated shock include MODS and DIC, which are often fatal. High-yield NCLEX pearls. Septic shock needs antibiotics plus fluids. Neurogenic shock equals hypotension plus bradycardia. Anaphylaxis equals epinephrine first. Urine less than 30 milliliters per hour equals renal hypoperfusion. Cardiogenic shock equals nitroprusside to reduce preload/afterload. And MODS/DIC equals late deadly signs. Let's review aneurysms, which are ballooning or dilation of a vessel wall that can rupture and cause life-threatening hemorrhage. Key risk factors include male sex, smoking, hypertension, aging, atherosclerosis, and family history. Types and clinical signs are essential for NCLEX. Abdominal aortic aneurysm, AAA, presents with flank or back pain and a pulsatile abdominal mass, but never palpate the mass because of rupture risk. A bruit over the aorta may also be present. Rupture leads to sudden severe pain and shock, making it a medical emergency. Aortic dissection is characterized by sudden, severe, tearing or ripping pain in the chest, back, or abdomen, with hypotension, tachycardia, diaphoresis, nausea, vomiting, and decreased or absent peripheral pulses. Thoracic aneurysms may cause severe back pain, cough, shortness of breath, dysphagia, and hoarseness. Diagnosis is by chest X-ray, CT scan, or ultrasound for AAA screening. Nursing care focuses on frequent vital signs every 15 minutes, continuous cardiac monitoring, hourly urine output, IV access, and strict blood pressure control with beta blockers or nitroprusside to maintain systolic blood pressure between 100 and 120 millimeters of mercury. Surgical management includes AAA repair or resection. Ruptured AAA is an emergency with roughly 50% mortality, while elective repair is recommended for aneurysms larger than 6 centimeters. Postoperatively, monitor for bleeding, graft occlusion, renal failure, and paralytic ileus. High-yield NCLEX pearls. Never palpate a pulsatile abdominal mass. AA presents with back/flank pain plus pulsatile mass. Aortic dissection equals tearing pain plus shock. Thoracic aneurysm equals back pain with cough or dysphagia. Keep BP 100 to 120 to prevent rupture. Ruptured AAA is an emergency, and aneurysms over 6 centimeters require surgical repair. Let's cover hematologic diagnostic procedures and lab values, which are critical for NCLEX. Normal labs. White blood cell 5,000 to 10,000 per cubic millimeter. High in infection, inflammation, or leukemia. Low in immunosuppression or bone marrow suppression. RBC 4 to 6 million per cubic millimeter. Elevated in dehydration or polycythemia. Low in anemia or hemorrhage. Platelets 150,000 to 400,000. Below 150,000 increases bleeding risk. Above 400,000 increases clotting risk. Hemoglobin 12 to 18 grams per deciliter carries oxygen. Transfuse if less than 7. Hematocrit 37 to 52% reflects the percentage of RBCS and is roughly 3 times hemoglobin. Coagulation studies. A PTT normal 30 to 40 seconds. Therapeutic on heparin is 1.5 to 2.5 times control, around 60 to 80 seconds. PT normal 11 to 12.5 seconds. Prolonged on warfarin, with INR normal 1, therapeutic 2 to 3, sometimes 2.5 to 3.5 for prosthetic valves. Bone marrow biopsy is performed to diagnose blood disorders like leukemia, anemia, or cancer. The most common site is the posterior iliac crest, with the patient in prone or side-lying position. Post-procedure, apply firm pressure for 5 to 10 minutes, monitor for bleeding or infection, keep the site clean and dry, and expect mild soreness. High-yield NCLEX pearls. A PTT monitors heparin, PT/INR monitors warfarin, hemoglobin below 7 requires transfusion, platelets below 50,000 increase bleeding risk, below 20,000 equals severe spontaneous bleeding risk, and hematocrit is roughly 3 times. Let's review blood transfusions and safety, which are high-yield NCLEX points. Autologous transfusion is when a patient donates their own blood for future surgery, ideally from 5 weeks up to 72 hours before surgery. Blood type compatibility. Type A has antigen A and anti-B antibodies, receives A or O. Type B has antigen B and anti-A antibodies, receives B or O. Type AB has both antigens, no antibodies, and is the universal recipient. Type O has no antigens, anti-A and anti-B antibodies, and is the universal donor but can only receive O. Rh factor. Rh positive can receive Rh positive or negative. Rh negative cannot receive Rh positive. Administration safety. Use 20 gauge or larger IV, verify with 2 nurses, only use normal saline as the fluid, and monitor vitals before transfusion, and every 15 minutes for the first hour, staying with the patient during the first 15 minutes, which is the highest risk period. Transfusion reactions. 1. Acute hemolytic, fever, chills, low back pain, hypotension, hemoglobinuria. Stop transfusion, start NS via new line, notify provider. 2. Febrile, chills, fever, headache. Stop transfusion, give acetaminophen. 3. Mild allergic, itching, hives. Stop transfusion, give antihistamine. 4. Anaphylactic, wheezing, hypotension, angioedema. Stop transfusion, give epinephrine. Antihistamines, oxygen, vasopressors, maintain airway. 5. Circulatory overload, dyspnea, JVD, hypertension, crackles, slow infusion, may give diuretics. High risk in heart failure patients. General rule for all reactions, stop transfusion, infuse normal saline via separate line, notify provider and blood bank, send blood tubing for testing. High-yield NCLEX pearls, blood type O equals universal donor, AB equals universal recipient, Rh negative never receives Rh positive. First 15 minutes critical for monitoring. Acute hemolytic reaction presents with back pain, fever, chills, heart failure. Patient's risk overload, and NS is the only fluid used with blood transfusions. Let's review anemia, a condition of low red blood cells or hemoglobin, resulting in reduced oxygen delivery to tissues. Causes include blood loss from trauma, surgery, GI bleed, or heavy menstruation, bone marrow suppression from chemo or radiation causing aplastic anemia, increased RBC destruction as in sickle cell disease, and nutritional deficiencies like iron, folic acid, or vitamin B12. Iron deficiency is most common in children and pregnant women, often associated with pica, eating non-food items. Clinical manifestations include pallor, fatigue, dyspnea on exertion, tachycardia, dizziness, syncope, neurological symptoms like numbness, tingling in B12 deficiency, and spoon-shaped nails in iron deficiency. Treatment and nursing care, iron deficiency anemia, oral iron with vitamin C for absorption. IM iron via Z-Track to prevent staining. Expect black stools and constipation. Increase fluids and fiber. Vitamin B12 deficiency, pernicious anemia. Oral B12 if dietary, but monthly. IM injections for life if intrinsic factor is absent. Neurological symptoms like paresthesia, confusion, memory loss are key findings. Folic acid deficiency. Supplement, especially in pregnancy, but always rule out B12 deficiency first, as high folate can mask B12 deficiency. Bone marrow suppression, aplastic anemia. Apoetin alpha stimulates RBC production. Monitor HGB/HCT twice weekly. Discontinue if HGB greater than 12 to avoid hypertension, stroke, MI. Complications. Chronic anemia can lead to heart failure due to prolonged tachycardia and cardiomegaly. High-yield NCLEX pearls, iron absorption arrow with vitamin C, Z-track for IM iron, B12 deficiency equals neurological signs, lifelong injections if intrinsic factor absent. Folic acid can mask B12 deficiency. Epotin alpha requires close HGB/HCT monitoring. Chronic anemia equals heart failure risk. Now let's focus on coagulation disorders, starting with idiopathic thrombocytopenic purpura, or ITP, which is an autoimmune condition causing a shortened platelet lifespan. It occurs more often in females and those with autoimmune diseases like lupus, sometimes after a viral infection, especially in children. Patients present with petechiae, ecchymoses, and mucosal bleeding from the gums or nose and are at risk for severe bleeding after trauma. Labs show low platelets and low hemoglobin. Treatment involves corticosteroids to suppress immune destruction, immunosuppressants, platelet transfusions if severe, and splenectomy in chronic cases, since the spleen is a major site of platelet destruction. Next is disseminated intravascular coagulation, or DIC, a life-threatening disorder where widespread microclots form, using up platelets and clotting factors, leading paradoxically to simultaneous bleeding. Common causes include sepsis, trauma, obstetric complications, and malignancy. Findings include spontaneous bleeding from gums, IV sites or incisions, petechiae, ecchymoses, oozing at puncture sites, along with tachycardia, hypotension, and microemboli causing cyanotic nails or organ ischemia. Labs reveal low platelets and hemoglobin, prolonged PT and APTT high D-dimer, and low fibrinogen. Treatment focuses on addressing the underlying cause using heparin to prevent further microclots, and transfusing blood products like platelets, fresh frozen plasma, or cryoprecipitate. Nursing care for both ITP and DIC includes bleeding precautions, minimize needle sticks, avoid IM injections, use a soft toothbrush and electric razor, avoid NSAIDs or aspirin, and implement fall precautions. Monitor vital signs, bleeding sites, CBC, and coagulation studies, and administer transfusions as ordered. High-yield NCLEX pearls, ITP equals autoimmune, steroids or immunosuppressants. DIC equals clotting plus bleeding. Treat the cause, use heparin for microclots, and replace clotting factors. Petechiae and oozing at IV sites are classic early signs of bleeding disorders. Always monitor a PTT when giving heparin, and both conditions require strict bleeding precautions. Let's now move into fluid and electrolyte imbalances, starting with fluid volume deficit, or FVD, which can be classified as hypovolemia, loss of both water and electrolytes from vomiting, diarrhea, bleeding, third spacing, or NPO status, or dehydration, which is loss of free water as in hyperventilation, fever, or diabetic ketoacidosis. Older adults are at higher risk due to reduced thirst and lower body water. Key findings include tachycardia with thready pulse, hypotension or orthostatic hypotension, tachypnea, dizziness, thirst, oliguria less than 30 milliliters per hour, cool, clammy skin, poor turgor, sunken eyes, delayed capillary refill, and weight loss. Labs show increased hematocrit, serum osmolality over 295, BUN above 25, and urine-specific gravity above 1.030. Nursing care involves strict intake and output monitoring, daily weights, fall precautions, slow position changes, oral fluids if mild, or isotonic IV fluids such as normal saline or lactated ringers if moderate to severe. In shock, provide oxygen, crystalloids or colloids, and vasopressors if unresponsive to fluids, and always report urine output less than 30 milliliters per hour. On the other hand, fluid volume excess, or FVE, occurs in conditions like heart failure, renal failure, cirrhosis, high sodium intake, or prolonged corticosteroid therapy. Patients present with tachycardia with bounding pulse, hypertension, tachypnea, edema, jugular vein distension, crackles in lungs, ascites, and rapid weight gain. Labs typically show decreased hematocrit and hemoglobin, low serum and urine osmolality, and low BUN. Nursing interventions include I and O monitoring, daily weights, sodium and fluid restriction, loop diuretics, turning and skin care every 2 hours, and semi-Fowler's positioning. Always notify the provider if there's weight gain of 1 to 2 pounds per day or 3 pounds per week. Be alert for pulmonary edema, indicated by tachycardia, dyspnea at rest, and pink frothy sputum, requiring high Fowler's positioning, oxygen, IV diuretics, and possibly morphine or vasodilators as per protocol. Now let's review electrolyte imbalances. Sodium ranges from 135 to 145. Hyponatremia causes confusion, seizures, and neuro changes. Treated with fluid restriction or hypertonic 3% saline, slowly under ICU monitoring if severe. Hypernatremia causes thirst, dry mucosa, fever, and agitation, managed with free water or hypotonic intravenous fluids, and correcting the underlying cause. Potassium ranges 3.5 to 5.0. Hypokalemia presents with weakness, ileus, U waves or flat T waves, and arrhythmias, requiring replacement carefully. Never IV push, 10 milliequivalents per hour peripherally. Up to 20 centrally with monitoring and correct magnesium first if low. Hyperkalemia causes peaked T waves, wide QRS, weakness, and arrhythmias. Treat urgently with intravenous calcium gluconate to stabilize the heart, insulin with dextrose, albuterol, sodium bicarbonate, and remove potassium with diuretics, sodium polystyrene, or dialysis. Calcium ranges 8.5 to 10.5. Hypocalcemia causes tetany, trousseau, and Chvostek signs, laryngospasm, and seizures, treated with intravenous calcium or vitamin D. Hypercalcemia leads to stones, bones, groans, weakness, and shortened QT, managed with intravenous fluids, loop diuretics, and calcitonin, or bisphosphonates. Magnesium, 1.5 to 2.5, is critical. Hypomagnesemia leads to hyperreflexia, tremors, torsades, treated with magnesium sulfate with DTR and airway monitoring. Hypermagnesemia causes decreased reflexes, hypotension, bradycardia, and respiratory depression, requiring stop magnesium, give calcium gluconate, and airway support. Phosphate, 2.5 to 4.5, inversely relates to calcium. Hypophosphatemia causes weakness and rhabdomyolysis, treated with replacement, while hyperphosphatemia often occurs in renal failure, managed with binders, diet restriction, or dialysis. Finally, acid-base imbalances follow a structured NCLEX approach. Normal ABGs, pH 7.35 to 7.45, PaCO 235 to 45, HCO 322 to 26, PaO 280 to 100. First, determine acidosis or alkalosis by pH, then match the abnormal value to CO2 for respiratory or HCO3 for metabolic causes, and check the other parameter for compensation. Respiratory acidosis results from hypoventilation, COPD, opioid overdose, pneumonia, and is treated with airway support, ventilation, and cause correction. Respiratory alkalosis is from hyperventilation, anxiety, pain, early salicylate toxicity. Treatment includes calm breathing and treating pain or fever. Metabolic acidosis, low pH and HCO3, occurs in DKA, diarrhea, renal failure, or shock, managed by treating the cause, insulin and fluids for DKA, or bicarbonate if severe. Metabolic alkalosis, high pH and HCO3, arises from vomiting, NG suction, diuretics, or antacids, treated by stopping suction, antiemetics, replacing chloride and potassium, or using acetazolamide if needed. High-yield NCLEX pearls. Daily weights are more reliable than I and O for fluid tracking. Urine output less than 30 milliliters per hour. Signals renal hypoperfusion. FVD labs show high hematocrit, osmolality, and urine-specific gravity, while FVE shows the opposite, hyperkalemia. With peak T waves requires calcium first, then shift/remove potassium. Hypomagnesemia prevents correction of potassium and calcium until magnesium is fixed. Hyponatremia with seizures requires slow hypertonic saline in ICU. DKA presents with metabolic acidosis and Kussmaul respirations. And elderly are prone to dehydration, so schedule fluids and educate caregivers. Before we jump into the next NCLEX topic, I want to give you something that could completely change your preparation. If you're aiming to pass on your very next attempt, the Ultimate NCLEX Crash Course is your shortcut. Already trusted by more than 100,000 nursing students, who cleared their exam successfully. What makes it different? It's an all-in-one package designed to cover every part of your NCLEX prep. Interactive live classes and easy-to-watch recorded lectures. 5,000 exam-style practice questions. 30 complete practice tests. Ebooks and PDF notes for revision. A ready-to-use student planner. Nigerian Naira questions broken down in detail during comprehensive lectures. This isn't just another review. It's everything you need in one place. Scan the QR code right now or use the link in the description to enroll instantly and grab free content, including PDF notes, practice tests, and NCLEX quizzes. You'll also get access to our Telegram and WhatsApp channels for even more free resources to keep you ahead. Electrolyte imbalances. NCLEX quick review. Let's start by grounding ourselves in the normal laboratory ranges, because without these baselines, interpreting imbalances becomes tricky. Sodium should sit between 135 and 145. Potassium ranges from 3.5 to 5.0. Calcium floats around 9 to 10.5. Magnesium rests between 1.3 and 2.1. Chloride lies at 98 to 106. Phosphate at 3.0 to 4.5. And BUN at 10 to 20. Keep these numbers in mind. They're the foundation of everything that follows. Now that we have our baseline, let's dive into sodium imbalances, starting with hyponatremia, where sodium drops below 135. Risk factors include diuretic therapy, nasogastric suctioning, gastrointestinal losses, heart failure, SIADH, and renal disease. Clinically, you might notice confusion, especially in older adults. Seizures, muscle weakness, hypothermia, tachycardia, and hypotension. The care approach depends on severity. Fluid restriction is key in dilutional states like SIADH or heart failure. Oral sodium intake should be encouraged. And in severe cases, 3% sodium chloride IV is administered slowly with continuous monitoring. On the other end of the spectrum, hypernatremia, where sodium rises above 145, often occurs in diabetes insipidus, renal failure, Cushing's syndrome, or with excessive sodium intake. Patients typically present with thirst, dry mucous membranes, hyperthermia, tachycardia, irritability, muscle twitching, and orthostatic hypotension. Management focuses on correcting fluid balance with hypotonic IV solutions like 0.45% sodium chloride or D5W, encouraging oral water intake, and restricting further sodium intake. With sodium covered, let's seamlessly shift to potassium, the electrolyte most closely tied to cardiac stability. Hypokalemia, defined as potassium below 3.5, often results from loop diuretics, gastrointestinal losses, diaphoresis, or wound losses. Clinically, watch for dysrhythmias, think U waves or flat T waves, muscle weakness, potential respiratory collapse, paralytic ileus, and constipation. Nursing interventions include promoting potassium-rich foods such as bananas, citrus fruits, potatoes, dark leafy greens, avocado, and cantaloupe. Oral or IV potassium replacement is indicated, but never exceed 10 milliequivalents per hour peripherally, and never give IV push. Remember, low potassium increases digoxin toxicity risk, so continuous ECG monitoring is essential. Conversely, hyperkalemia, where potassium exceeds 5.0, is commonly seen in renal failure, with potassium-sparing diuretics like spironolactone, diabetic ketoacidosis, or severe tissue breakdown. Key findings include peaked T waves, wide QRS complexes, diarrhea, cramping, hyperactive bowel sounds, and muscle weakness. Immediate care includes holding potassium supplements, administering loop diuretics, giving calcium gluconate to protect the heart, shifting potassium intracellularly with insulin plus D50, using sodium bicarbonate if acidosis is present, and removing excess potassium with kayexalate or dialysis. Having tackled potassium, we now move to calcium, the powerhouse of muscles and nerves. Hypocalcemia, defined as calcium below 9, can result from hypoparathyroidism, accidental parathyroid damage during thyroidectomy, vitamin D deficiency, or pancreatitis. Look for tetany, muscle twitching, a positive Kvostek sign, facial twitch, a positive Trousseau sign, spasm with blood pressure cuff, seizures, and even laryngospasm. Management focuses on increasing dietary calcium with dairy and dark greens, ensuring adequate vitamin D, and administering intravenous calcium gluconate in severe cases. Hypercalcemia, on the other hand, is usually due to hyperparathyroidism, bone metastases, or prolonged immobility. Patients present with weakness, decreased reflexes, constipation, kidney stones, and shortened QT intervals. Nursing care includes intravenous fluids plus loop diuretics, medications like calcitonin or bisphosphonates, and encouraging ambulation. From calcium, let's flow naturally into magnesium. The reflex modulator. Hypomagnesemia, magnesium below 1.3, often occurs in alcoholism, malnutrition, or diarrhea. Symptoms include hyperreflexia, tremors, positive Chvostek and Trousseau signs, seizures, and paralytic ileus. Care involves oral or intravenous magnesium sulfate, intravenous for severe deficits, but remember, oral magnesium can cause diarrhea. Always monitor deep tendon reflexes and respiratory status. Hypermagnesemia, exceeding 2.1, usually arises from renal failure or magnesium-containing antacids and laxatives. Key findings are hypotension, bradycardia, decreased reflexes, respiratory depression, and even cardiac arrest. Interventions include stopping magnesium intake, giving calcium gluconate, and dialysis if severe. Next, let's touch on phosphate, the often overlooked partner of calcium. Hypophosphatemia, below 3, can present with weakness, rhabdomyolysis, and confusion. Replacement therapy is essential. Hyperphosphatemia, above 4.5, usually occurs in renal failure and inversely affects calcium levels, potentially causing tetany. Management includes phosphate binders, dietary restrictions, or dialysis. Before we wrap up, here are the high-yield NCLEX pearls that you must ingrain. Sodium imbalances primarily affect the nervous system. Potassium disturbances threaten cardiac stability. Calcium is critical for muscle and nerve function. Magnesium governs reflexes. And phosphate generally runs opposite calcium. Remember, never IV push potassium. Always dilute and monitor continuously. Hypokalemia heightens digoxin toxicity risk. For hyponatremia with seizures, hypertonic saline should be infused slowly. And for hyperkalemia, follow the treatment sequence. Stabilize with calcium gluconate, shift potassium into cells with insulin/D50, and finally, remove excess with diuretics, dialysis, or Kayexalate. Acid-base imbalances. Let's start by laying the foundation with normal arterial blood gas values, because understanding these is essential for interpreting any acid-base imbalance. The normal pH ranges from 7.35 to 7.45. PaCO2 is 35 to 45 millimeters of mercury. HCO3 ranges 22 to 26 milliequivalents per liter. PaO2 is 80 to 100 millimeters of mercury. And SaO2 sits comfortably between 95 and 100%. Keep these numbers in mind. They're your reference point for everything else we discuss. Now that we know what normal looks like, let's explore the body's defense mechanisms, starting with buffers. Chemical buffers, like proteins and bicarbonate, are the first line of defense, acting immediately to neutralize pH changes. Next, the respiratory system kicks in, which acts rapidly, within minutes, by regulating CO2 levels to balance pH. Finally, the renal system is the slow but powerful player, taking hours to days to adjust pH by reabsorbing or excreting bicarbonate and hydrogen ions. When analyzing acid-base status, you'll often hear the terms uncompensated, partially compensated, and fully compensated. Uncompensated means the pH is abnormal, but only one system, respiratory or metabolic, is affected. Partially compensated indicates both CO2 and HCO3- are abnormal, yet pH remains off balance. Fully compensated? That's when the body has brought pH back to normal, but both CO2 and HCO3- are still abnormal, showing how hard your body works to maintain homeostasis. With this background, let's move into specific acid-base disorders, starting with respiratory acidosis. Here, pH drops and CO2 rises due to hypoventilation. Common causes include airway obstruction, pneumonia, COPD, pulmonary edema, or sedative overdoses like opioids. Clinically, expect shallow, slow, ineffective respirations, hypotension, tachycardia, confusion, drowsiness, headaches, and warm, flushed skin. Nursing care focuses on maintaining a patent airway, oxygen therapy, ventilatory support if needed, bronchodilators, and reversal agents such as naloxone for opioid overdose. From here, Let's shift to the mirror image. Respiratory alkalosis, where pH rises and CO2 falls. This usually stems from hyperventilation, triggered by anxiety, fear, pain, salicylate toxicity, or hypoxemia. Patients may show rapid, deep respirations, lightheadedness, dizziness, paresthesias, tetany, or palpitations. Nursing interventions aim to reduce anxiety, encourage slow rebreathing using a paper bag or rebreather mask, and sedate if the condition is severe. Now, moving to the metabolic side, we have metabolic acidosis, characterized by low pH and low bicarbonate. Causes include overproduction of H+, like in DKA, lactic acidosis, sepsis, salicylate overdose, bicarbonate loss through diarrhea or GI fistulas, and renal failure where acid excretion is impaired. Look for dysrhythmias, weak pulses, hypotension, tachypnea with Kussmaul respirations, flushed skin, GI upset, and hyperkalemia, as H+ shifts out of cells in exchange for potassium. Care is targeted at the underlying cause: insulin for DKA, antidiarrheals for GI losses, dialysis if kidneys fail, and IV sodium bicarbonate if severe. On the flip side is metabolic alkalosis, with elevated pH and bicarbonate. Causes include vomiting, NG suction, excessive antacids, prolonged diuretics, and hypokalemia. Patients may present with confusion, lethargy, muscle cramps, tetany, seizures, and hypoventilation as compensation. Nursing care focuses on stopping causative GI losses, replacing fluids and electrolytes, especially potassium, chloride, and normal saline. At this point, let's simplify NCLEX-ABG interpretation with a quick stepwise approach. 1. Look at pH. Less than 7.35 indicates acidosis. Greater than 7.45 indicates alkalosis. 2. Check PaCO2 for the respiratory component. Greater than 45 equals acidosis. Less than 35 equals alkalosis. 3. Check HCO3- for the metabolic component. Less than 22 equals acidosis. Greater than 26 equals alkalosis. 4. Match the cause with pH to identify the disorder. 5. Assess compensation. Are both PaCO2 and HCO3- abnormal? Is pH normal? Finally, let's cement the high-yield NCLEX pearls you must remember. Respiratory problems are always linked to CO2, while metabolic issues are tied to HCO3-. DKA presents with metabolic acidosis and Kussmaul respirations, prolonged vomiting or NG suctioning, metabolic alkalosis, anxiety attacks, respiratory alkalosis, opioid overdose, respiratory acidosis. Hyperkalemia is common in metabolic acidosis. And remember, lungs compensate quickly, kidneys slowly. Timing matters. By internalizing these steps, you can confidently interpret ABGs, recognize the underlying cause, and prioritize patient care in any NCLEX scenario. Gastrointestinal Diagnostic Procedures, NCLEX Review. Let's dive into gastrointestinal diagnostic procedures, starting with liver and pancreatic labs, because understanding lab values is essential for identifying liver or pancreatic disorders early. For liver function tests, alanine aminotransferase and aspartate aminotransferase should both be less than 40 units per liter. An elevation suggests liver disease, hepatitis, cirrhosis, or hepatotoxic medication effects. Bilirubin normally stays under 1 milligram per deciliter, and elevations can indicate jaundice, bile duct obstruction, or hemolysis. Albumin ranges from 3.5 to 5 grams per deciliter, and low levels point to malnutrition, chronic liver disease, or nephrotic syndrome. Ammonia levels should remain below 100 micrograms per deciliter, but elevations may cause hepatic encephalopathy, presenting as confusion or asterixis, which is a flapping tremor of the hands. Switching to pancreatic labs, both amylase and lipase normally remain below 100 units per liter, but lipase is more specific for pancreatitis and stays elevated longer in acute pancreatitis, making it the preferred diagnostic marker. Next, let's focus on stool tests. The fecal occult blood test screens for gastrointestinal bleeding from sources like peptic ulcers, colon cancer, or colitis. In cases of persistent diarrhea, C. difficile testing may also be indicated. Preparation is key to avoid false positives, so patients should avoid red meat, iron supplements, aspirin, and vitamin C for 48 hours before the test. Moving on to endoscopic procedures, these are commonly used when evaluating anemia, abdominal pain, distension, suspected cancer, or GI bleeding. Let's start with the colonoscopy, which involves inserting a scope through the anus to examine the entire colon. The patient must undergo bowel prep with polyethylene glycol, follow a clear liquid diet for 24 hours, while avoiding red, purple, or orange liquids, and remain NPO after midnight. Sedation is moderate, and the left side with knees to chest is the proper position. After the procedure, monitor for perforation, indicated by rectal bleeding, severe abdominal pain, distension, or fever. The EGD, or esophagogastroduodenoscopy, enters through the mouth to inspect the esophagus, stomach, and duodenum. Patients must remain NPO for 6 to 8 hours, and moderate sedation is used. Post-procedure care focuses on ensuring the gag reflex returns before oral intake and watching for aspiration or perforation, signaled by pain, bleeding, or infection. A sigmoidoscopy examines only the sigmoid colon, requiring a clear liquid diet for 24 hours, bowel prep, and NPO after midnight. Sedation is minimal or not used, and the patient lies on the left side. Across all endoscopic procedures, nurses must vigilantly monitor for complications. Hemorrhage presents as tachycardia, hypotension, tachypnea, and pallor. Aspiration, particularly post-EGD, requires keeping the patient NPO until the gag reflex returns. Perforation is the priority complication and manifests as severe abdominal pain, a rigid abdomen, fever, and tachycardia. These signs demand immediate action. Next, GI series or barium studies involve ingesting a barium prep, which an X-ray tracks through the GI tract. Patients must remain NPO after midnight. Follow a clear liquid or low residue diet and avoid smoking or chewing gum, as both stimulate peristalsis and may alter results. After the study, encourage fluids to help eliminate barium. Expect chalky white stools for 24 to 72 hours and monitor for constipation or impaction. Finally, let's summarize the high-yield NCLEX pearls. Remember, colonoscopy equals left side, knees to chest. EGD equals NPO until gag reflex returns. Sigmoidoscopy equals no anesthesia, left side. Barium studies equals encourage fluids. White stools are expected. For GI bleed suspicion, a positive FOBT is telling, but PrEP and false positives must be ruled out. And always remember, the priority complication across all procedures is perforation, which presents with severe abdominal pain, rigid abdomen, fever, and tachycardia. Mastering these points ensures you can safely prepare patients, monitor for complications, and prioritize nursing care during gastrointestinal diagnostics on the NCLEX. Now that we understand gastrointestinal diagnostics, let's explore therapeutic procedures that help manage GI conditions, starting with enteral feedings via nasogastric or percutaneous endoscopic gastrostomy tubes, which are indicated for patients who are comatose, intubated, or have swallowing difficulties. As nurses, it is critical to verify tube placement before each feeding, initially by X-ray, and subsequently using pH aspirate or CO2 monitoring. Gastric residuals should be checked every 4 to 6 hours, and feedings should be held if residuals exceed 100 to 200 milliliters due to aspiration risk. Always elevate the head of the bed 30 to 45 degrees during feeding and for 30 to 60 minutes afterward, and flush the tube with water before and after medications or intermittent feedings. Be alert for complications such as aspiration pneumonia, diarrhea, and fluid or electrolyte imbalances. Moving to total parenteral nutrition, or TPN, this is administered through a central line like a PICC, subclavian, or internal jugular, and is reserved for patients with malabsorption, bowel obstruction, severe malnutrition, or hypermetabolic states such as burns or sepsis. Nursing care includes changing tubing and solution every 24 hours using filter tubing, checking blood glucose every 4 to 6 hours, monitoring daily labs and weight, and providing 10% dextrose in water if TPN is unavailable to prevent hypoglycemia. Remember, the TPN line should never be used for IV medications or bolus fluids. Watch closely for air embolism, which presents a sudden shortness of breath and chest pain. If suspected, clamp the catheter, position the patient on the left side in Trendelenburg, provide oxygen, and notify the provider. Infection at the site is also a concern, so maintain strict aseptic technique and monitor for hyper or hypoglycemia, particularly during initiation or discontinuation. Next, paracentesis is performed to remove acidic fluid, relieve abdominal pressure, and improve breathing. Pre-procedure, always verify consent, have the patient void, measure baseline weight and abdominal girth, and obtain vital signs. The patient should be positioned upright in Fowler's or high Fowler's position. Afterward, monitor vitals, abdominal girth, and weight, and watch for hypovolemia indicated by hypotension or dizziness. Fluids or albumin may be administered to prevent vascular collapse. For patients undergoing bariatric surgery, the diet starts with clear liquids and is advanced slowly, limiting intake to 30 milliliters at a time with small, frequent meals 6 times daily. Nurses must monitor for dumping syndrome, which presents as diarrhea, cramping, tachycardia, dizziness, sweating, and fatigue. Prevention strategies include eating small meals, avoiding liquids with meals, limiting simple sugars, and increasing protein and fiber intake. NG tube decompression is indicated for intestinal obstruction, paralytic ileus, vomiting, or abdominal distension. Placement must be confirmed initially by X-ray and subsequently by pH check while monitoring bowel sounds and abdominal girth. Assess drainage carefully. A sudden decrease or worsening nausea and vomiting may indicate displacement. Irrigation with normal saline is done only if prescribed, and frequent oral and nasal care is essential for patient comfort and infection prevention. Finally, let's review ostomy care. An ileostomy is located in the ileum and produces frequent liquid stools, posing a risk for fluid and electrolyte imbalance, whereas a colostomy is in the colon and produces formed stools. A healthy stoma is pink, moist, and protruding, while pale, dusky, bluish-purple, or dry stomas indicate ischemia and must be reported immediately. Nursing care includes emptying the bag when it is 1/4 to 1/2 full, using a skin barrier or paste to protect surrounding skin, and encouraging fluids, particularly for ileostomies. Common complications include skin breakdown, obstruction, and ischemia. Let's wrap up with NCLEX high-yield pearls. For enteral feedings, always hold the feeding if residuals exceed 100 to 200 milliliters. For TPN, monitor glucose every 4 to 6 hours. Never stop abruptly, and use 10% dextrose if unavailable. Paracentesis requires voiding and careful measurement of weight and abdominal girth before and after the procedure. In bariatric surgery, prevent dumping syndrome by giving small, frequent meals and avoiding liquids with meals. For NG tubes, high-pitched bowel sounds may indicate obstruction, and decreased drainage may indicate displacement. And for ostomies, the stoma must remain pink and moist, with dusky or pale coloring signaling ischemia, which requires immediate action. Before we jump into the next NCLEX topic, I want to give you something that could completely change your preparation. If you're aiming to pass on your very next attempt, the ultimate NCLEX crash course is your shortcut. Already trusted by more than 100,000 nursing students who cleared their exams successfully. What makes it different? It's an all-in-one package designed to cover every part of your NCLEX prep. Interactive live classes and easy-to-watch recorded lectures. 5,000 exam-style practice questions. 30 complete practice tests. Ebooks and PDF notes for revision. A ready-to-use student planner. Nigerian Naira. Questions broken down in detail during comprehensive lectures. This isn't just another review. It's everything you need in one place. Scan the QR code right now, or use the link in the description to enroll instantly and grab free content, including PDF notes, practice tests, and NCLEX quizzes. You'll also get access to our Telegram and WhatsApp channels for even more free resources to keep you ahead. Transitioning from gastrointestinal procedures, let's focus on esophageal disorders, beginning with GERD, or gastroesophageal reflux disease, which occurs when gastric contents and enzymes backflow into the esophagus, causing irritation and inflammation. Risk factors include obesity, older age, pregnancy, or ascites, as well as dietary triggers such as fatty or fried foods, caffeine, chocolate, peppermint, spicy or tomato-based foods, citrus, and alcohol. Lifestyle factors play a role too, including bending at the waist, lying down after meals, and smoking. Patients often report epigastric pain that worsens when lying down, straining, or bending, and pain after meals, along with chronic cough, sore throat, hoarseness, or a bitter taste in the mouth. The pain usually improves with water, sitting upright, or antacids. Diagnostics include esophagogastroduodenoscopy to detect inflammation, strictures, or Barrett's epithelium, which is precancerous, and 24-hour pH monitoring. Treatment includes proton pump inhibitors like omeprazole or pantoprazole to reduce gastric acid, keeping in mind that long-term use can increase osteoporosis risk. Antacids, such as aluminum hydroxide, are used for quick symptom relief and are given 1 to 3 hours after meals and at bedtime, with at least a 1-hour separation from other medications. H2 blockers like ranitidine or famotidine also decrease acid secretion, while prokinetic agents such as metoclopramide enhance gastric emptying and motility. But nurses must monitor for extrapyramidal symptoms. For refractory cases, fundoplication surgery wraps the stomach around the esophagus to reinforce the lower sphincter. Lifestyle modifications are equally important. Avoid trigger foods, eat small meals, remain upright after eating, avoid late-night meals, avoid tight clothing, lose weight, and elevate the head of the bed. Shifting to esophageal varices, these are dilated fragile veins in the esophagus resulting from portal hypertension, commonly due to cirrhosis. They are at high risk of rupture, which can cause massive, life-threatening hemorrhage. Patients may present with hematemesis, melena, and signs of shock such as tachycardia, hypotension, pallor, or dizziness, along with jaundice and ascites indicating underlying liver disease. Labs often reveal low hemoglobin and hematocrit due to bleeding, and elevated ammonia from impaired liver clearance. Endoscopy identifies the bleeding site. Nursing care priorities include establishing large-bore intravenous access, preparing for blood transfusions, fluids, and vasopressors, while non-selective beta blockers such as propranolol are used prophylactically to lower portal venous pressure, but not during an active bleed. During active bleeding, vasopressin or octreotide constrict the splanchnic circulation, and endoscopic variceal ligation or sclerotherapy may be performed. In severe cases, balloon tamponade with a Sangstaken-Blakemore tube may be necessary. Nurses must monitor for hypovolemic shock, indicated by tachycardia and hypotension, which is a priority NCLEX red flag, and be vigilant for aspiration pneumonia in patients with significant hematemesis. Let's summarize the NCLEX high-yield pearls. For GERD, proton pump inhibitors like omeprazole are best for healing, while antacids provide quick relief. Patients with Barrett's esophagus should be monitored closely, as it is premalignant. For esophageal varices, bleeding is an emergency, so airway protection, intravenous access, and blood transfusion are top priorities. Propranolol prevents rebleeding, but is contraindicated during active bleeding, and never insert an NG tube in a patient with varices unless specifically ordered by the provider, due to the high risk of rupture. Peptic ulcer disease, NCLEX review. Moving on from esophageal disorders, let's discuss peptic ulcer disease, or PUD, which is characterized by erosion of the mucosal lining in the stomach, duodenum, or occasionally the esophagus. The most common cause is Helicobacter pylori, a gram-negative bacterium, while other contributing factors include chronic NSAID or corticosteroid use, severe stress, trauma, surgery, alcohol, smoking, and family history. Patients often present with epigastric pain or burning that may radiate to the back, heartburn, bloating, nausea, and vomiting. And more concerning signs include hematemesis or melena, which may indicate active bleeding. Orthostatic hypotension and tachycardia can also occur if significant blood loss is present. It's important for nurses to distinguish gastric versus duodenal ulcers because the timing of pain in relation to meals helps guide assessment. Gastric ulcer pain occurs 30 to 60 minutes after eating and often worsens with food, while duodenal ulcer pain usually occurs 1.5 to 3 hours after meals or at night and is often relieved by food or antacids. A helpful NCLEX tip is gastric equals gain pain with food. Duodenal equals diminish pain with food. Nursing care focuses on monitoring vital signs for orthostatic changes, tachycardia, and signs of bleeding, educating patients to avoid milk, caffeine, decaf coffee, spicy foods, and NSAIDs, encouraging small, frequent meals, and instructing patients to report black stools or vomiting blood immediately. Medication management includes triple therapy antibiotics for H. pylori infection, such as clarithromycin, amoxicillin, and a proton pump inhibitor, ensuring the full course is completed. H2 blockers like ranitidine or famotidine and PPIs like pantoprazole reduce gastric acid and promote healing. Antacids such as magnesium hydroxide neutralize acid and are given 1 to 2 hours after meals with at least a 1-hour separation from other medications. Sucralfate, a mucosal protectant, coats the ulcer and should be administered on an empty stomach 1 hour before meals and at bedtime, ensuring it is not given with other medications. Complications include perforation or hemorrhage, which present as sudden severe epigastric pain, rigid and tender abdomen, rebound tenderness, and signs of shock such as hypotension and tachycardia. A true NCLEX emergency. Dumping syndrome may occur after gastric surgery, causing cramping, diarrhea, dizziness, tachycardia, and diaphoresis after eating. So teaching focuses on no fluids with meals, only 1 hour before or after. Small, frequent meals, high protein, high fat, low fiber, low carbohydrate diet, and avoidance of milk or sugar. Let's highlight NCLEX high-yield pearls. H. pylori infections require triple therapy with antibiotics, plus a proton pump inhibitor. Sucralfate must be given on an empty stomach and not with other medications. Perforation presents as a rigid board-like abdomen, with pain and shock and requires immediate emergency intervention. Gastric ulcer pain is early and worsens with eating, while duodenal ulcer pain is delayed and relieved by food, and dumping syndrome management centers on careful diet teaching. Acute and chronic gastritis, NCLEX review. Continuing our gastrointestinal review, let's examine acute and chronic gastritis, which is essentially inflammation of the gastric mucosa. Acute gastritis has a sudden onset and is often caused by irritants such as NSAIDs, alcohol, stress, or spicy foods, and it usually resolves once the cause is removed. On the other hand, chronic gastritis involves progressive destruction of the gastric lining, often linked to Helicobacter pylori infection, and can lead to pernicious anemia due to loss of intrinsic factor, which impairs vitamin B12 absorption. Risk factors for both forms include H. pylori infection, long-term NSAID or corticosteroid use, alcohol, caffeine, smoking, stress, autoimmune disease, and aging, which decreases the protective mucosal barrier. Patients with gastritis may report upper abdominal pain or burning, which can increase or decrease after eating, abdominal bloating, nausea, and vomiting. More concerning signs include hematemesis, melena, or occult blood in the stool, and fatigue may indicate chronic blood loss or anemia. Diagnostics include endoscopy with biopsy, which is definitive, H. pylori testing through breath, stool, or biopsy, and CBC to assess for anemia. Nursing care focuses on small, frequent meals eaten slowly, avoiding alcohol, caffeine, NSAIDs, and spicy or irritating foods, and reducing stress and encouraging smoking cessation. Monitoring for gastric bleeding is crucial, including vomiting blood, black tarry stools, and orthostatic hypotension. Medication management is tailored to both symptom control and cause. H2 blockers, such as famotidine and ranitidine, reduce acid secretion and are taken with meals. Antacids like aluminum hydroxide neutralize acid and should be given on an empty stomach, separated from other medications by at least 1 hour. Proton pump inhibitors like pantoprazole or omeprazole provide strong acid suppression and are taken before meals without crushing. Prostaglandin analogs, such as misoprostol, protect the mucosa and prevent NSAID-induced ulcers, but are contraindicated in pregnancy due to uterine contractions. Sucralfate coats the gastric lining, enhancing protection, and must be given on an empty stomach, separated from antacids by 30 minutes. For H. pylori eradication, antibiotics like amoxicillin, clarithromycin, metronidazole, or tetracycline are often prescribed in triple or quadruple therapy. Complications include gastric bleeding, presenting as tachycardia, hypotension, hematemesis, and black stools, dehydration and electrolyte imbalances, especially if vomiting is severe, and pernicious anemia and chronic gastritis, which requires lifelong monthly vitamin B12 injections. High-yield NCLEX pearls emphasize that acute gastritis often resolves when the irritant is removed, whereas chronic gastritis can lead to irreversible changes and increases the risk of gastric cancer. Sucralfate must always be given on an empty stomach. Misoprostol prevents NSAID-induced ulcers, but is never given to pregnant women, and monitoring for signs of bleeding, such as coffee ground emesis, melena, and orthostatic hypotension, is critical for patient safety. Non-inflammatory bowel disorders, NCLEX review. Moving on to non-inflammatory bowel disorders, let's start with hernias, which are defined as the protrusion of a portion of the bowel through a weakness in the abdominal muscle wall. Risk factors include male sex, aging, and increased intra-abdominal pressure from pregnancy, obesity, or heavy lifting. Clinically, patients often present with a lump or bulge at the site, which may become more noticeable with coughing, straining, or standing. Nursing care focuses on avoiding activities that increase intra-abdominal pressure, such as coughing, straining, or heavy lifting, and using a support binder if ordered. After hernia repair surgery, deep breathing and early ambulation are encouraged, but patients should support the incision and avoid straining to prevent recurrence. It is important to recognize that a strangulated hernia is an emergency, as it can lead to ischemia and necrosis of bowel tissue, requiring immediate surgical intervention. Next, we consider irritable bowel syndrome, IBS, a chronic functional disorder characterized by alternating diarrhea and constipation without inflammatory changes to the bowel. Patients may experience cramping abdominal pain, bloating, belching, mucus in the stool, and a sensation of incomplete evacuation. Diagnosis is primarily a diagnosis of exclusion, based on changes in bowel habits and symptom patterns, differentiating it from inflammatory bowel disease like Crohn's or ulcerative colitis, which causes bleeding, weight loss, and tissue changes. Nursing care includes stress management, maintaining adequate fluid intake of 2 to 3 liters per day, and increasing dietary fiber to 30 to 40 grams per day. Patients are encouraged to keep a food diary to identify triggers such as gas-producing foods, alcohol, caffeine, lactose, or gluten. Medications are tailored to bowel patterns. For IBS with diarrhea, alloxitron may be prescribed under strict monitoring for ischemic colitis, while for IBS with constipation, lubiprostone or linaclotide can increase intestinal fluid and motility. Finally, intestinal obstruction is an urgent consideration and can be mechanical, caused by adhesions, tumors, diverticulitis, hernia or fecal impaction, or non-mechanical such as paralytic ileus, neurogenic disorders, vascular issues, or electrolyte imbalances. Common findings include abdominal distension and pain, with high-pitched bowel sounds above the obstruction and hypoactive or absent sounds below. Small bowel obstruction often presents with sudden profuse projectile vomiting with a fecal odor, whereas large bowel obstruction manifests as ribbon-like stools, constipation, or diarrhea around the impaction. Diagnostics include abdominal CT or X-ray. Nursing care involves keeping the patient NPO, inserting an NG tube for decompression, providing oral care every 2 hours, administering IV fluids and electrolytes, and managing pain. Therapy includes clamping the NG tube before removal to assess tolerance and gradually advancing diet from clear liquids as tolerated. Severe cases may require surgery, including colon resection or colostomy. Always monitor for peritonitis, identified by rigid abdomen, rebound tenderness, fever, and tachycardia, as this is a medical emergency. High-yield NCLEX pearls remind us that strangulated hernias are emergencies. IBS does not cause bleeding or weight loss, helping differentiate it from IBD. Small bowel obstruction presents primarily with vomiting and electrolyte imbalance, and large bowel obstruction presents with distension, ribbon stools, and constipation, with vigilant monitoring for signs of peritonitis at all times. Before we jump into the next NCLEX topic, I want to give you something that could completely change your preparation. If you're aiming to pass on your very next attempt, the Ultimate NCLEX Crash Course is your shortcut. Already trusted by more than 100,000 nursing students who cleared their exams successfully. What makes it different? It's an all-in-one package designed to cover every part of your NCLEX prep, interactive live classes, and easy-to-watch recorded lectures. 5,000 exam-style practice questions, 30 complete practice tests, ebooks and PDF notes for revision, a ready-to-use student planner, Nigerian Naira, questions broken down in detail during comprehensive lectures. This isn't just another review, it's everything you need in one place. Scan the QR code right now, or use the link in the description to enroll instantly and grab free content, including PDF notes, practice tests, and NCLEX quizzes. You'll also get access to our Telegram and WhatsApp channels for even more free resources to keep you ahead. Shifting our focus to inflammatory bowel disease, we first examine ulcerative colitis, which is characterized by continuous inflammation that starts in the rectum and extends through the colon, affecting primarily the mucosa and submucosa. Patients often present with left lower quadrant abdominal pain, fever, and frequent liquid stools, up to 15 to 20 per day, containing mucus, blood, and pus. Physical findings can include abdominal distension and tenderness, and laboratory studies often reveal decreased hematocrit and hemoglobin, elevated erythrocyte sedimentation rate, elevated white blood cells, increased C-reactive protein, and low albumin. Diagnostics include colonoscopy, barium enema, and CT scan, and definitive therapy may involve colectomy with ileostomy, which can be curative. In contrast, Crohn's disease can affect anywhere from the mouth to the anus and involves all layers of the bowel wall, producing skip lesions. Clinical findings often include right lower quadrant pain, fever, and 5 or more loose stools per day containing mucus, pus, and sometimes fatty stools, steatorrhea. Like ulcerative colitis, labs may show anemia, elevated inflammatory markers, and hypoalbuminemia, but unlike UC, surgery is not curative and is reserved for complications such as strictures, fistulas, or obstruction. Chronic malabsorption can lead to malnutrition, making nutritional support a key nursing priority. Another related disorder is diverticulitis, which occurs when diverticula, small pouches in the colon wall, become inflamed or infected due to trapped food or fecal matter. Patients usually report left lower quadrant pain, fever, and chills. Nursing care focuses on dietary management, with clear liquids during the acute phase, gradually advancing to high-fiber foods while avoiding seeds, nuts, and popcorn, which can lodge in diverticula. Surgical interventions such as colon resection may be required for recurrent or severe cases. Risk factors across inflammatory bowel disorders include genetics, white ethnicity, Jewish heritage, and smoking, which particularly increases the risk for Crohn's disease. Nursing care emphasizes monitoring for complications such as perforation, which may present with fever, severe abdominal pain, vomiting, rigid board-like abdomen, rebound tenderness, and tachycardia, requiring NPO status, NG tube decompression, Fowler's positioning, and supplemental oxygen. During exacerbations, patients may need NPO status, followed by high-protein, high-calorie, low-fiber meals, avoiding caffeine, alcohol, and dairy if not tolerated, and providing small, frequent meals. Chronic diarrhea can result in electrolyte imbalances, especially hypokalemia, so careful monitoring is essential. Medication therapy focuses on controlling inflammation and managing symptoms. 5-ASA agents like sulfasalazine help reduce inflammation, while corticosteroids provide short-term control of flare-ups but require monitoring for infection, hyperglycemia, and GI bleeding. Immunosuppressants like cyclosporine and immunomodulators like infliximab suppress the immune response but increase the risk of infection. So, patients should avoid crowds and report early signs of infection. Symptomatic relief includes antidiarrheals, such as loperamide, and antimicrobials, like ciprofloxacin or metronidazole when infections are suspected. Complications are serious and require vigilance. Peritonitis presents with rigid abdomen, rebound tenderness, tachycardia, nausea, and vomiting. Toxic megacolon is a life-threatening dilation of the colon seen in UC. Crohn's disease can result in malabsorption, malnutrition, bowel obstruction, or strictures. High-yield NCLEX pearls include that ulcerative colitis causes continuous inflammation from the rectum through the colon, often with bloody diarrhea and increased colon cancer risk, while Crohn's disease features skip lesions, right lower quadrant pain, steatorrhea, and fistula formation, and diverticulitis requires careful diet progression from low fiber during acute illness to high fiber once stable, avoiding seeds and nuts. Helpful mnemonics to differentiate include UC equals ulcer, plus continuous plus colon only, and Crohn's equals cobblestones plus creeps anywhere plus complications. Fistulas, strictures, which can make recalling features easier during the NCLEX. Cholecystitis and cholelithiasis, NCLEX review. Next, let's focus on cholecystitis and cholelithiasis, two related gallbladder disorders. Cholecystitis is the inflammation of the gallbladder wall, most often caused by gallstones blocking the cystic duct, which leads to bile backup, inflammation, and impaired fat digestion. Cholelithiasis, on the other hand, is simply the presence of gallstones in the gallbladder, which may or may not cause symptoms. Classic risk factors follow the NCLEX mnemonic of the 5 Fs: female, fat, 40, fertile, and fair-skinned, though fair skin is less emphasized clinically. Additional risk factors include a high-fat diet, obesity, sedentary lifestyle, family history, and hormonal influences such as pregnancy or estrogen therapy. Patients typically present with sharp right upper quadrant pain, which may radiate to the right shoulder or scapula, often worsening after high-fat meals. Other findings include dyspepsia, burping, flatulence, clay-colored stools, fatty stools, dark urine, pruritus due to bile salts, and nausea or vomiting. Laboratory studies often reveal elevated white blood cell count from inflammation or infection and increased bilirubin if bile flow is obstructed. And amylase or lipase may rise if the pancreas is involved. Ultrasound is the test of choice to visualize gallstones, while CT scans or abdominal X-rays can detect calcified stones and an enlarged gallbladder. And a hepatobiliary scan, HIDA, evaluates bile duct obstruction. Treatment depends on the severity and surgical eligibility. Lithotripsy can break up small cholesterol-based stones in non-surgical candidates with normal weight, but the most common treatment is cholecystectomy, either laparoscopic or open. Post-operatively, patients often experience shoulder pain from residual carbon dioxide gas, which is relieved with early ambulation. If a T-tube is placed, it should be kept above the level of the abdomen, with drainage monitored for color and amount, and the tube clamped 1 hour before and after meals. Initially, stools may be clay-colored, but they should return to brown within a week, and diarrhea is common after gallbladder removal. Diet after surgery should be low in fat, avoiding gas-forming foods such as beans, cabbage, broccoli, and cauliflower. Complications can be severe. Peritonitis is a medical emergency, presenting with rigid abdomen, severe abdominal pain, fever, tachycardia, and hypotension, requiring immediate intervention. High-yield NCLEX pearls include recognizing right upper quadrant pain that worsens with fatty meals. As a classic clue, clay-colored stools with dark urine indicating biliary obstruction, and proper postoperative care, such as ambulation to relieve gas pain and vigilant monitoring for peritonitis. T-tube care is critical. Always keep it elevated above the abdomen, unclamp only as ordered, and monitor stool color for return to normal. Pancreatitis, NCLEX review. Moving forward, let's discuss pancreatitis, a condition in which the pancreas becomes inflamed due to premature activation of digestive enzymes inside the organ, leading to autodigestion and inflammation. Normally, the pancreas secretes enzymes like amylase, lipase, and proteases to aid in digestion. But in pancreatitis, these enzymes attack the pancreas itself. Chronic pancreatitis eventually leads to fibrosis, scarring, and permanent pancreatic dysfunction, impairing both endocrine and exocrine function. High-yield risk factors include gallstones or biliary tract disease, which are the most common cause, as well as alcohol use, a classic NCLEX risk gastrointestinal surgery, hyperlipidemia, hyperparathyroidism, trauma, penetrating ulcers, and certain medications that can cause drug toxicity. Clinically, patients present with severe epigastric pain radiating to the back, left flank, or left shoulder, which is often worse when lying flat and relieved when in the fetal position. Additional findings include nausea, vomiting, weight loss, jaundice, warm, moist skin, fruity breath due to hyperglycemia, ascites, and tetany from hypocalcemia, which can be identified by positive Kvostek and Trousseau signs. Classic exam clues include Cullen's sign, bruising around the umbilicus, and Turner's sign, bruising along the flanks. Laboratory findings are key. Markedly elevated amylase and lipase are hallmark indicators, accompanied by elevated white blood cell count, low calcium and magnesium, elevated liver enzymes and bilirubin, and hyperglycemia. Nursing care focuses on resting the pancreas by keeping the patient NPO initially, providing TPN if necessary, and later introducing a bland, low-fat diet with small frequent meals while strictly avoiding caffeine, alcohol, and smoking. Pain is managed with opioids, and antiemetics are given as needed. Monitoring is critical. Blood glucose may require insulin, electrolytes like calcium and magnesium need close observation, and hydration status must be maintained. Stress reduction should also be encouraged to prevent exacerbations. Medication therapy includes opioids for pain and pancreatic enzyme replacement, which must be taken with meals or snacks to aid in the digestion of fats and proteins. Patient education is essential. Emphasize lifelong abstinence from alcohol, provide a referral to alcohol abuse programs if needed, encourage adherence to a low-fat, bland diet, and ensure pancreatic enzymes are taken properly with meals. Complications can be life-threatening. Pseudocysts may form from leakage of pancreatic fluid and can rupture. Chronic pancreatic damage can lead to type 1 diabetes mellitus, malnutrition, and hypocalcemia, which may manifest as tetany or seizures. High-yield NCLEX pearls include recognizing severe epigastric pain radiating to the back, combined with elevated amylase and lipase, as a classic indicator of pancreatitis. Additionally, Cullen's sign and Turner's sign are important visual clues that often appear on exams and should immediately raise suspicion for pancreatic inflammation or hemorrhage. Let's dive into a critical topic in liver health: hepatitis and cirrhosis, conditions that affect millions worldwide and are a frequent focus on the NCLEX. We'll start with hepatitis, which is essentially inflammation of the liver. The most common cause? Viruses, though drugs and toxins can also trigger it. Hepatitis comes in different types, so pay attention. Hepatitis A is usually transmitted through the fecal-oral route, meaning contaminated food, water, or close contact can spread it. The good news is, there's a vaccine available. Moving on, hepatitis B spreads through blood and body fluids, such as sexual contact, intravenous drug use, or even perinatal transmission from mother to baby. Again, vaccination is an option here. Then we have hepatitis C, which is also transmitted via blood and body fluids. But unlike A and B, there is no vaccine yet. Now, who's at risk? Think of anyone using dirty needles, getting tattoos or piercings, engaging in unprotected sex, eating undercooked or contaminated food, traveling to underdeveloped countries, or living in crowded environments like prisons. Clinically, patients often present with flu-like symptoms: fever, nausea, vomiting, along with dark urine, clay-colored stools, jaundice, right upper quadrant pain, and fatigue. Lab findings are crucial. Expect elevated AST and ALT above 40 and bilirubin above 1. Definitive diagnosis is usually made with a liver biopsy, while treatment focuses on antiviral medications and supportive care, as there's no complete cure. Be aware that complications like chronic hepatitis can progress to cirrhosis, liver cancer, or liver failure. Speaking of which, let's transition to cirrhosis, a chronic condition that represents scarring of the liver due to prolonged inflammation. There are several types: post-necrotic, often from viral hepatitis; Lennox, usually linked to chronic alcohol use; and biliary cirrhosis, which stems from chronic biliary obstruction or autoimmune conditions. The key risk factors here are alcoholism, viral hepatitis, and hepatotoxic drugs. Early cirrhosis may just cause fatigue and mild abdominal discomfort, but as the disease advances, the symptoms escalate dramatically. Patients can develop ascites, edema, pruritus, jaundice, petechiae, spider angiomas, and palmar erythema. Gastrointestinal bleeding is common due to esophageal varices, and neurological signs like confusion, encephalopathy, and asterixis, along with fetor hepaticus, the classic musty or fruity breath, may appear. Laboratory values reinforce the diagnosis. AST, ALT, and bilirubin rise, while protein and albumin decrease, and hematocrit, hemoglobin, platelets, and RBC count fall. Expect elevated ammonia as well. Imaging and biopsies via ultrasound, CT, or MRI confirm the extent of liver damage. Now, let's shift our focus to nursing care, which is pivotal in managing these patients. Positioning is important. Keep the patient upright at 30 degrees with feet elevated to reduce discomfort from ascites. Strict intake and output monitoring, along with daily abdominal girth measurements, help track fluid accumulation. Dietary modifications include low sodium, low fat, high carbohydrate, and moderate protein. Unless encephalopathy is severe, encourage small, frequent meals to optimize nutrition. For pruritus, cold water and lotions can provide relief. Medication management is key. Lactulose binds ammonia and promotes excretion, but watch for diarrhea and hypokalemia. Beta blockers reduce the risk of variceal bleeding. Before procedures like paracentesis, Ensure the patient voids and maintain close monitoring of oxygenation and mental status. In cases where the liver is severely damaged, a transplant may be the last resort, requiring lifelong immunosuppressants to prevent rejection. Let's wrap up with NCLEX pearls that are high yield. Remember, hepatitis A equals fecal oral, often linked to food or travel. Hepatitis B and C equals blood and body fluids. Cirrhosis has a classic triad: ascites, varices, and encephalopathy. Treat encephalopathy with lactulose. Expect loose stools. Finally, after paracentesis, position the patient upright and ensure the bladder is empty. Now, let's shift our focus to renal diagnostic procedures, a topic that's essential for understanding kidney function and detecting disorders early. First, we'll explore the key laboratory tests that give us a snapshot of how the kidneys are performing. The most specific indicator of kidney function is creatinine, which rises when the kidneys are diseased or impaired. Alongside this, we monitor blood urea nitrogen, or BUN, which also increases with kidney disease, but can be influenced by other factors, such as dehydration. So, always interpret BUN in context. It's not as specific as creatinine. Next, urinalysis is a cornerstone of renal assessment. The ideal specimen is collected in the early morning, when urine is most concentrated. During analysis, we assess color, clarity, and specific gravity, which normally ranges from 1.010 to 1.025. We also check for glucose, ketones, protein, and drug metabolites, each offering clues to underlying renal or metabolic conditions. Moving from labs to imaging, let's talk about CT scans of the kidneys and urinary tract. These often require contrast dye, which is useful for visualization but carries a risk for acute kidney injury, especially in vulnerable patients. Always screen for iodine or shellfish allergies before administering contrast. After the procedure, encourage the patient to increase fluid intake to flush the dye and protect renal function. Next, we have cystoscopy or cystothroscopy, procedures that allow direct visualization of the bladder and urethra. Preparation includes NPO after midnight, and sometimes a bowel prep with a laxative or enema to clear the area. After the procedure, it's normal for urine to appear light pink, but monitor closely. Bright red clots or difficulty voiding are abnormal and should be reported immediately. Watch for infection as well. Another important imaging tool is excretory urography, which uses contrast to evaluate the entire urinary tract. Preparation mirrors cystoscopy, NPO after midnight, and bowel prep. Post-procedure care focuses on hydration to flush the contrast and monitoring renal function, ensuring no complications arise. Now, let's highlight some NCLEX pearls that you absolutely must remember. Creatinine is the most reliable lab for renal function, while BUN can fluctuate depending on hydration. Always check for iodine or shellfish allergies before contrast studies to prevent severe reactions. Encourage adequate fluids after contrast administration to protect the kidneys. And after cystoscopy, pink urine is expected. But bright red clots or inability to void require immediate action. By understanding these diagnostic procedures, lab markers, and post-procedure care, you can anticipate complications and intervene promptly, which is exactly what the NCLEX expects from competent nursing practice. Now that we understand renal diagnostic procedures, let's move forward and discuss dialysis, a life-saving therapy when the kidneys can no longer perform their essential functions. The primary purpose of dialysis is simple yet crucial. It removes excess fluid, electrolytes, and waste products that accumulate when the kidneys fail. Let's start with hemodialysis, the most common form. Access for hemodialysis is usually through an arteriovenous fistula or graft, but sometimes a central catheter is used. Nurses must ensure the patency of the access site. This means listening for a bruit, feeling for a thrill, and checking distal pulses. When caring for a patient with a fistula, remember these key precautions. Never take blood pressure, administer injections, start IVs, or draw blood from the access arm. Monitor vitals carefully, along with BUN, creatinine, electrolytes, hematocrit, and daily weight. Hemodialysis is typically scheduled 3 times a week for 3 to 5 hours per session. During dialysis, heparin is used to prevent clotting, so always keep protamine sulfate ready in case reversal is needed. Post-dialysis. Expect some common changes. Blood pressure may drop, labs will shift, and patients often need a comparison of pre- and post-weight, as weight loss equals fluid removed. Nutritionally, protein intake should be higher than before dialysis, and the access arm must be protected. No heavy lifting, no pressure, and encourage hand exercises to help the fistula mature. Of course, there are potential complications. Clotting or infection of the access site is a risk, so monitor for bleeding and always maintain a septic technique. Disequilibrium syndrome can occur due to a rapid decrease in BUN, leading to cerebral edema, which manifests as nausea, confusion, or seizures. Treatment includes slowing exchanges and giving anticonvulsants. Hypotension is also common and can be managed with intravenous fluids or colloids, slowing the exchange and lowering the head of the bed. Finally, anemia and infection are frequent challenges in dialysis patients. Now, let's transition to peritoneal dialysis, which uses the patient's own peritoneal cavity as a filter. The process involves instilling hypertonic dialysate, allowing it to dwell, and then draining it. This method is often preferred for older adults or those with poor vascular access. Before starting, patients may feel fullness and mild discomfort, which is expected. During dialysis, nurses must measure inflow versus outflow, ensuring the outflow is normally clear or yellow. Any cloudy, bloody, or frothy drainage signals infection or complication. Other important steps include warming the dialysate before installation and keeping the outflow bag lower than the abdomen to facilitate drainage. Complications to watch for include peritonitis, indicated by fever, cloudy drainage, or redness and swelling at the catheter site. There is also protein loss, so dietary protein should be increased, and hyperglycemia may occur due to the glucose in dialysate, requiring blood glucose monitoring. Poor inflow or outflow often occurs from constipation or kinked tubing, so encourage fiber, stool softeners, and gentle milking of tubing. Finally, let's highlight the NCLEX pearls you need to remember. For hemodialysis, Brute and Thrill confirm a patent fistula, and disequilibrium syndrome presents with confusion and seizures. For peritoneal dialysis, cloudy dialysate is a red flag for infection, and it's always essential to compare inflow and outflow volumes. Remember to protect the fistula arm like gold. No BP, IVS, or blood draws there. Now that we've covered dialysis, it's time to explore kidney transplantation, a definitive treatment for end-stage kidney disease when dialysis no longer effectively maintains life or quality of life. The transplant offers hope for better kidney function and independence, but it comes with critical nursing responsibilities. Immediately after surgery, urine output is the most important parameter. It should be greater than 30 milliliters per hour, and any sudden drop can indicate rejection or obstruction, which requires urgent intervention. Alongside this, nurses must monitor for infection, watch for dyspnea, fever, incisional drainage, or redness, as transplant patients are highly susceptible due to immunosuppressant therapy. Equally important is the monitoring for rejection, which often presents as fever, hypertension, or pain at the transplant site. Preventing respiratory complications is vital, so patients should perform pulmonary hygiene, including turning, coughing, and deep breathing to reduce the risk of pneumonia. If prescribed, bladder irrigation should be maintained to prevent clot retention, keeping the urinary tract clear. Medications are the cornerstone of post-transplant care. Immunosuppressants like cyclosporine help prevent graft rejection, while monoclonal antibodies, such as basiliximab or daclizumab, may be used as induction therapy. Nurses must educate patients about lifelong adherence to these medications to protect the new kidney. Patient education also extends to lifestyle and diet. Encourage a low-fat diet for cholesterol control, high-fiber intake to prevent constipation, and high-protein foods to support healing. Patients must also control blood sugar by avoiding concentrated sugars and carbohydrates, and avoid contact sports to protect the graft from trauma. Now, let's understand the types of rejection. Hyperacute rejection occurs within 48 hours, is antibody-mediated, and causes microblood clots. It is irreversible and requires graft removal. Acute rejection develops between 1 week and 2 years, and is usually reversible with increased immunosuppressants. Finally, chronic rejection occurs over months to years, resulting in a gradual loss of graft function. Here are some essential NCLEX pearls to remember. Always monitor urine output first after a transplant. It's the best indicator of graft function. Recognize that hyperacute rejection is irreversible and requires nephrectomy. Teach patients lifelong immunosuppressant therapy and strict infection precautions. And finally, remember that fever, hypertension, and graft pain are classic signs of acute rejection, which must be reported immediately. Let's now turn our attention to kidney disorders beyond dialysis and transplant, starting with polycystic kidney disease, or PKD. This is a genetic disorder in which fluid-filled cysts develop in the nephrons, causing the kidneys to enlarge progressively. Clinically, patients often present with flank pain, hematuria, hypertension, and an enlarged abdominal girth, sometimes accompanied by constipation. The major concern here is that PKD can progress to chronic kidney disease over time. Nursing care focuses on blood pressure control, monitoring renal labs, preventing infections, and providing supportive care to manage symptoms and slow progression. Moving forward, let's discuss acute kidney injury, a sudden decline in kidney function that can be life-threatening if not managed promptly. AKI progresses through 3 classic phases. First, the oliguric phase, where urine output drops to 100 to 400 milliliters per 24 hours, lasting 1 to 3 weeks. Next is the diuretic phase, characterized by large fluid output over 2 to 6 weeks, which requires careful fluid and electrolyte monitoring. Finally, the recovery phase can last up to 12 months, during which renal function gradually improves. AKI can be classified into 3 types. Pre-renal AKI is caused by decreased renal perfusion due to shock, sepsis, hypovolemia, or vascular obstruction. Intrarenal AKI results from direct kidney damage from trauma, nephrotoxic antibiotics, contrast dyes, or heavy metals. Lastly, post-renal AKI occurs when there is urinary obstruction, such as kidney stones, tumors, or benign prostatic hyperplasia. Lab findings include elevated creatinine and a sharp rise in BUN, sometimes reaching 80 to 100 in just 1 week. Nutrition management involves restricting potassium, sodium, phosphorus, and magnesium, while ensuring adequate protein intake unless contraindicated. Now let's shift to chronic kidney disease, a long-term progressive loss of renal function. CKD is staged according to glomerular filtration rate, GFR. Stage 1 is above 90, Stage 2 is 60 to 89, Stage 3 is below 60, 3 is 30 to 59, Stage 4 is 15 to 29, and Stage 5, also called end-stage kidney disease, is below 15, requiring dialysis or transplant. Major risk factors include prior AKI, diabetes, hypertension, nephrotoxic drugs, and autoimmune disorders like lupus. And older adults are especially vulnerable due to reduced thirst, increasing the risk of dehydration. Patients with CKD may present with multi-system effects. Neurologically, they might show lethargy, slurred speech, tremors, and jerky movements. Cardiovascular changes include jugular vein distension, heart failure, and hypertension. Respiratory issues like shortness of breath, tachypnea, and crackles are common. Gastrointestinal symptoms often include anorexia and vomiting, while the skin can exhibit pruritus and uremic frost. Classic late findings. Hematologically, anemia is prevalent due to decreased erythropoietin production. Lab and diagnostic evaluations show urinalysis with hematuria, proteinuria, and decreased specific gravity, along with elevated BUN and creatinine, low sodium and calcium, and elevated potassium, phosphorus, and magnesium. Imaging may include KUB X-ray, CT, or MRI to assess kidney size and structure. Nursing care focuses on daily weights to monitor fluid retention. Remember, a 2.2-pound weight gain equals roughly 1 liter of fluid retained, a favorite NCLEX testing point. Dietary management includes restricting sodium, potassium, phosphorus, and magnesium, while emphasizing high carbohydrates for energy and moderate fats. Medication considerations include avoiding non-steroidal anti-inflammatory drugs and nephrotoxic contrast dyes, administering apoetin alpha to stimulate red blood cells, giving iron supplements like ferrous sulfate, and using loop diuretics like furosemide to manage fluid overload. Magnesium-containing antacids should be avoided to prevent further electrolyte imbalances. Patient education is equally important. Encourage rest periods to prevent fatigue, smoking cessation, and control of blood pressure and blood sugar. Fluid restriction should be followed as ordered, and patients need ongoing support to adhere to diet and medications. Finally, let's summarize some high-yield NCLEX pearls. Remember the classic AKI sequence, oliguria, diuresis, recovery. For CKD, always restrict potassium, sodium, phosphorus, and magnesium, while ensuring adequate carbohydrates for energy. A 2.2-pound weight gain equals 1 liter of fluid retained, making daily weights crucial. Epoetin alpha and iron supplements are key for combating anemia, and pruritus with uremic frost signals late-stage CKD, something NCLEX loves to test. Now let's focus on renal and urinary infections. Urinary tract infections, mostly caused by E. coli, can progress to pyelonephritis or urosepsis if untreated. Risk factors include female anatomy, pregnancy, sexual activity, indwelling catheters, diabetes, incomplete bladder emptying, and poor hygiene. Classic findings are frequency, urgency, dysuria, lower abdominal discomfort, cloudy or foul-smelling urine, and fever. Confusion in older adults is a key warning sign. Labs show bacteria, white blood cells, leukocyte esterase, and nitrites. Management includes fluoroquinolones and phenazopyridine. Urine turns orange. Patient teaching: hydrate 3 liters per day, void regularly, wipe front to back, avoid wet swimsuits and bubble baths. Pyelonephritis affects the kidneys, presenting with CVA tenderness, flank/back pain, fever, tachycardia, nausea, and vomiting. Labs may show elevated WBC, BUN, creatinine, CRP, and ESR. Treat with antibiotics and analgesics, and monitor for sepsis, CKD, and hypertension. Glomerulonephritis often follows strep infections or autoimmune disease. Findings include oliguria, edema, hypertension, dyspnea, weight gain, and red-brown urine. Labs: RBCS/protein in urine, ARO-BUN/creatinine, ARO-ASO titer, ARO-ESR. Nursing care: monitor I and O, daily weights, restrict sodium and fluids, dialysis if severe. Meds: antibiotics, diuretics, corticosteroids, antihypertensives. Complications: pulmonary edema and anemia. Treat with iron plus epoetin alpha. NCLEX, pearls. Confusion in older adults equals UTI, CVA. Tenderness equals pyelonephritis. Red-brown urine plus edema plus HTN equals glomerulonephritis. Phenazopyridine equals orange urine, and daily weights plus strict I and O equals best fluid status indicator. Before we continue with the next NCLEX topic, let me share something that could be a real game changer for you. If you want to make sure you pass on your very next attempt, we've created the Ultimate NCLEX Crash Course, a shortcut that has already helped over 100,000 nursing students achieve success. It's an all-in-one program that includes live interactive classes and recorded sessions you can watch anytime, 5,000 high-yield practice questions, 30 full-length mock tests, ebooks and PDF notes, a complete student planner, in-depth NGN question discussions. Everything you need to pass the NCLEX is right here in one place. Simply scan the QR code on your screen or use the link in the description to enroll now and unlock instant free access to PDF notes, practice tests, and NCLEX quizzes. Plus, you'll also get entry to our Telegram and WhatsApp channels for even more free resources. Now, let's dive into the next NCLEX topic. Now let's discuss renal calculi, or stones in the urinary tract, commonly calcium phosphate, calcium oxalate, or uric acid. Risk factors include male gender, metabolic defects increasing calcium, urinary stasis, dehydration, and abnormal urine pH. Classic findings are severe flank pain radiating to the abdomen or groin, dysuria, frequency, oliguria, or anuria. If obstruction, hematuria, fever, diaphoresis, nausea, vomiting, tachycardia, and pallor. Diagnostics include KU-B X-ray, CT, and MRI. Nursing care focuses on straining all urine to save stones for analysis, encouraging 3 liters of fluid per day, and promoting ambulation to aid passage. Pain is managed with opioids or NSAIDs, and oxybutynin can relieve urinary spasms. Procedures like lithotripsy use shock waves or laser under moderate sedation with ECG monitoring, and post-procedure hematuria and bruising are expected. Diet teaching depends on stone type. Calcium stones, reduce sodium, moderate calcium. Oxalate stones, avoid spinach, nuts, rhubarb, tea, chocolate, limit sodium. Uric acid stones, Limit purines like organ meats, poultry, fish, alcohol, and use allopurinol if prescribed. Complications include urinary obstruction or hydronephrosis, which require immediate reporting to the provider. NCLEX, pearls, severe flank pain radiating to groin equals classic renal colic. Straining urine to catch stones equals diagnostic priority. Hydration plus ambulation equals non-invasive therapy. Diet modification equals key preventive measure. And any obstruction or sudden anuria equals emergency. Let's review key female reproductive procedures. Pap test screen for precancerous or cancerous cervical cells. Recommended starting at age 21. Repeated every 3 years if normal. Pre-procedure, the patient should not be menstruating, avoid sex, douching, or vaginal medications for 24 hours, and have an empty bladder. Post-procedure, minimal bleeding is expected. If the pap is abnormal, a cervical biopsy may be done. Post-biopsy care includes rest for 24 hours, avoid sex, douching, tampons until discharge stops. About 2 weeks. Avoid heavy lifting and report excess bleeding, fever, or foul discharge. Endometrial biopsy is indicated for uterine cancer or abnormal bleeding. Pre-procedure, administer analgesics, empty bladder, and expect cramping. Post-procedure, light spotting for 1 to 2 days is normal, and avoid sex, douching, tampons until discharge ends. HIV testing is done via ELISA, confirmed with Western blot. Mammograms start at age 40, and pre-procedure, ensure no deodorant, lotion, or powder, and confirm the patient is not pregnant. Hysterectomy is performed for cancer, fibroids, endometriosis, or prolapse. Post-op care includes monitoring vitals, urine, bowel output, breath sounds, incision drainage, and DVT precautions. Patient education emphasizes restricted activity for 6 weeks, no sex tampons, and report fever greater than 100 degrees Fahrenheit, foul drainage, calf pain, swelling, or dysuria. Removal of ovaries may cause menopausal symptoms. NCLEX, pearls, pap smear equals 21 years, mammogram equals 40 years, hysterectomy equals DVT precautions, plus activity restrictions, biopsy equals avoid sex talks, tampons until healing, and always report excessive bleeding, fever, or infection signs. Let's cover menstrual cycles and disorders. Normal cycles begin with menarche around age 12, last 28 days, with ovulation on day 14, and menstruation lasting 4 to 9 days. Menopause is the permanent cessation of ovulation, typically around age 52, confirmed after 12 months without menses. Menstrual disorders include amenorrhea, absence of periods, often due to low body fat in athletes or anorexia, premenstrual syndrome, PMS, irritability, mood swings, bloating, headaches, back pain, weight gain, and endometriosis, endometrial tissue outside uterus, pain, and infertility. Diagnostics may show low hemoglobin/hematocrit from heavy bleeding, elevated CA-125 for ovarian cancer, endometrial biopsy for uterine cancer, or transvaginal ultrasound for fibroids. Medications include oral contraceptives for PMS, dysmenorrhea, and dysfunctional bleeding, NSAIDs for pain, diuretics for bloating, fluoxetine for emotional regulation, leuprolide to suppress endometriosis, teratogenic, contraception required, and oral iron for anemia. Menopause findings, hot flashes, atrophic vaginitis, decreased vaginal secretions, mood swings, and decreased bone density. Hormone therapy, estrogen/progestin, relieves symptoms and reduces fracture risk, but increases MI, CAD, DVT, stroke, and breast cancer risk. Patient education. Quit smoking, avoid tight clothing and prolonged sitting, stretch legs, report unilateral leg pain, edema, redness, or warmth, possible DVT, and note that MI in women may present atypically, pain between shoulders, NCLEX. Pearls, amenorrhea equals athletes/anorexia. PMS equals physical plus emotional symptoms. Endometriosis equals pain plus infertility. Menopause equals 12 months. No menses. Hormone therapy improves quality of life, but watch for DVT/MI warning signs. Let's see other one where we'll focus on benign prostatic hyperplasia, or BPH, a common condition in aging men that can significantly affect urinary function. To start with the pathophysiology, As men age, the prostate gland gradually enlarges. This enlargement isn't cancerous, but it has a mechanical effect. It compresses the urethra and obstructs urinary outflow. Think of it like narrowing a garden hose. Urine can't flow freely, leading to a range of urinary symptoms. Speaking of symptoms, let's break down the clinical findings you need to recognize. Patients often experience urinary frequency and urgency, with hesitancy or even incontinence. They may feel that their bladder never fully empties, leading to dribbling after voiding. Nocturia, or waking up at night to urinate, is common, and the urinary stream may be weak or diminished, sometimes requiring straining. In some cases, hematuria, or blood in the urine, may also be present, though this isn't always seen. Recognizing these patterns is essential for early detection and management. Now, how do we confirm the diagnosis? First, PSA, or prostate-specific antigen, is measured to rule out prostate cancer, since BPH can mimic some cancer symptoms. Next, a digital rectal exam, or DRE, is performed. In BPH, the prostate typically feels enlarged but smooth. Remember, if it feels hard or irregular, cancer must be suspected. In cases where cancer cannot be ruled out, a transrectal ultrasound with biopsy, or TRUS, is indicated to provide definitive confirmation. Moving on to pharmacologic management, two main classes of medications are commonly used. Finasteride, a 5-alpha reductase inhibitor, works by reducing the effect of testosterone on the prostate, thereby gradually shrinking it. Patients should be counseled that finasteride may decrease libido and cause erectile dysfunction. And importantly, pregnant women should avoid handling the tablets or contact with the patient's semen. The second medication, tamsulosin, is an alpha-1 blocker that relaxes the bladder outlet and prostate smooth muscle, improving urine flow. A key side effect to watch for is postural hypotension, so patients should rise slowly from sitting or lying positions. If medications aren't enough, procedural interventions may be needed. A prostatic stent can be placed to physically keep the urethra open. Another common procedure is TURP, or transurethral resection of the prostate. Post-operatively, patients will have a 3-way catheter with continuous bladder irrigation, or CBI. The goal of irrigation is to maintain a pink or light pink urine return. This indicates everything is functioning as expected. Bright red, ketchup-like blood or clots is concerning for arterial bleeding. In that case, the CBI rate may be increased and the surgeon notified immediately. Obstruction, such as bladder spasms or decreased outflow, is managed by temporarily turning off the irrigation and manually irrigating with 50 milliliters of normal saline. Persistent issues require prompt surgical consultation. Also, the catheter balloon may create a constant urge to void, which is a normal postoperative sensation. Education is a cornerstone of post-procedure care. Encourage patients to drink 12 8-ounce glasses of water daily to maintain urinary flow. Bladder stimulants like caffeine and alcohol should be avoided. If urine appears bloody, the patient should rest and increase fluid intake, but any persistent bleeding, obstruction, or signs of infection should be reported immediately. Stool softeners are also recommended to prevent straining, which could disrupt healing. Finally, let's review the key NCLEX pearls. Remember, after TURP, pink is perfect, ketchup is concerning. A simple way to assess bleeding. Finasteride effectively shrinks the prostate but can reduce libido. Tamsulosin improves urine flow but may cause orthostatic hypotension, so safety precautions are vital. And continuous bladder irrigation is essential to prevent clot retention, a common post-operative complication. With that, we have a comprehensive overview of BPH, from pathophysiology to diagnosis, medications, procedures, and post-operative care. Up next, we'll explore prostate cancer, diving into risk factors, diagnostics, and treatment options that every NCLEX student must know. Now, let's move, where we'll explore musculoskeletal diagnostic procedures, tools that help us visualize, assess, and understand joint and bone disorders in detail. First up is arthroscopy, a minimally invasive procedure designed to let us look directly inside a joint. This is especially helpful for examining structures like the meniscus and ligaments to identify tears or other damage. However, it's important to note that arthroscopy is contraindicated in patients with an active infection or severe limitation in joint mobility, as it could worsen outcomes. After the procedure, post-care is key. Ice should be applied to the joint during the first 24 hours to reduce swelling, and the extremity should be elevated for 12 to 24 hours. Patients should be advised to report any swelling, increased joint pain, redness, or purulent drainage, as these could signal infection or thrombophlebitis. Simple measures like ice and elevation can make a huge difference in recovery and patient comfort. Next, let's talk about nuclear scans, which provide detailed imaging of bones and joints using radioactive isotopes. A standard bone scan involves injecting the isotope 2 to 3 hours before imaging, helping detect hairline fractures, tumors, or other bone diseases. On the other hand, gallium or thallium scans involve isotope injection 4 to 6 hours before the scan, with repeat imaging at 24, 48, and 72 hours to track changes. Sedation may sometimes be required to keep the patient still, especially for pediatric or anxious patients. Pre-procedure, we must assess for allergies to the isotope and explain the importance of lying still. After the scan, encouraging fluids is crucial to help the body excrete the radioactive material efficiently. Moving along, we have DXA, or Dual Energy X-ray Absorptiometry, which is the gold standard for detecting osteoporosis and determining the extent of bone loss. Baseline screening is recommended at age 40, especially for individuals at risk, and metallic objects must be removed prior to scanning to ensure accurate results. Lastly, let's cover EMG, or electromyography, a procedure used to assess muscle weakness and neuromuscular disorders such as ALS or myasthenia gravis. During EMG, thin needles are inserted into the muscle to record electrical activity during contraction. Patients are instructed to flex the muscle during the test so the electrical signals can be accurately measured and interpreted. To summarize the NCLEX pearls for musculoskeletal diagnostics, after arthroscopy, remember ICE and ELEVATE for bone, gallium, and thallium scans. Focus on isotope administration and hydration afterward. DXA is all about detecting osteoporosis early, and EMG involves studying muscle contraction through needle electrodes, giving valuable insight into neuromuscular function. With that, we've covered the essentials of musculoskeletal diagnostic tools. Up next, we'll transition into musculoskeletal disorders and their medical surgical management, connecting these diagnostic findings to real patient care and NCLEX-style scenarios. Let's dive, where we explore arthroplasty, the surgical procedure designed to replace a diseased joint, most commonly the hip or knee, with a prosthetic implant. The main goals of arthroplasty are clear: relieve pain, restore motion, and improve both function and quality of life. Patients often present with joint crepitus, swelling, and limited mobility before surgery, which signals the need for intervention. However, not every patient is a candidate. Contraindications include an active or recent infection and arterial impairment of the affected extremity, as operating under these conditions could lead to serious complications. Now, let's talk about preoperative care, which is crucial for optimizing outcomes. Epwedin alpha may be prescribed several weeks before surgery to increase hemoglobin levels in patients with mild anemia. Some patients may also participate in autologous blood donation. The surgical site should be scrubbed with antiseptic soap the night before and the morning of surgery, and antihypertensive medications are taken with just a sip of water on the day of surgery. These steps help reduce infection risk and stabilize the patient during the procedure. Focusing first on knee arthroplasty, postoperative mobility is a priority. Patients will often use a continuous passive motion (CPM) machine to promote joint mobility. It should be turned off during meals for safety. It is important to avoid the knee gach and pillows behind the knee, as these can lead to flexion contractures. Instead, place a pillow under the lower calf and foot, apply ice or cold therapy to reduce swelling, and perform neurovascular checks every 2 to 4 hours. Medications typically include analgesics for pain control, peripheral nerve blocks, antibiotics to prevent infection, and anticoagulants to reduce the risk of clot formation. Before we continue with the next NCLEX topic, let me share something that could be a real game changer for you. If you want to make sure you pass on your very next attempt, we've created the Ultimate NCLEX Crash Course, a shortcut that has already helped over 100,000 nursing students achieve success. It's an all-in-one program that includes live interactive classes and recorded sessions you can watch anytime, 5,000 high-yield practice questions, 30 full-length mock tests, ebooks and PDF notes, a complete student planner, in-depth NGN question discussions. Everything you need to pass the NCLEX is right here in one place. Simply scan the QR code on your screen or use the link in the description to enroll now and unlock instant free access to PDF notes, practice tests, and NCLEX quizzes. Plus, you'll also get entry to our Telegram and WhatsApp channels for even more free resources. Now, let's dive into the next NCLEX topic. Switching gears to hip arthroplasty, we know that a drop in hemoglobin and hematocrit is expected during the first 48 hours after surgery, with transfusion considered if hemoglobin falls below 9. Early ambulation is a key factor in preventing complications, and patients should use an abduction pillow between the legs when turning to maintain proper alignment. Monitoring for hip dislocation is critical. Sudden pain, a popping sound, a shortened extremity, or abnormal rotation are red flags. Similar to knee replacements, hip patients also receive analgesics, antibiotics, and anticoagulants as part of their regimen. Patient education is a cornerstone of recovery and long-term function. Patients should use elevated seating and a raised toilet seat, keep the abduction pillow in bed, and ensure that toes are externally rotated, not inward. Long-handled devices, like shoehorns or dressing sticks, help avoid hip flexion beyond 90 degrees. Most importantly, patients should avoid crossing their legs, bending forward at the waist, or internally rotating the hip. Complications can arise despite careful management. DVT and pulmonary embolism are significant risks, so use of sequential compression devices while in bed, anticoagulation therapy, and early ambulation are essential preventive measures. Infection at the surgical site and joint dislocation, particularly in hip replacements, are other concerns that must be closely monitored. To sum up the NCLEX pearls for arthroplasty. For hip replacement, remember, no crossing legs, no hip flexion beyond 90 degrees, and always use an abduction pillow. For knee replacement, utilize the CPM machine and avoid pillows behind the knee. Keeping these points in mind ensures safer recovery and optimal patient outcomes. With arthroplasty covered, we'll next transition into post-operative pain management and rehabilitation strategies, tying these procedures into broader musculoskeletal nursing care for NCLEX readiness. Now, let's move where we focus on amputations, a significant surgical intervention with both elective and traumatic indications. Elective amputations are often performed due to complications of peripheral vascular disease or malignancy, while traumatic amputations result from severe injuries that necessitate immediate intervention. Assessment of patients at risk or post-amputation is critical. Look for altered peripheral pulses, often assessed with a Doppler, cool extremities, and color changes such as cyanosis or gangrene. Patients may also experience loss of sensation in the affected limb, signaling compromised circulation or nerve damage. In the case of a traumatic amputation, emergency care is life-saving. Apply direct pressure to control bleeding and elevate the extremity above the heart to reduce blood loss. The severed part must be wrapped in dry, sterile gauze, placed in a sealed plastic bag, and submerged in ice water. Never place it directly on ice, as that can damage tissue. Prompt, correct handling can make a difference if reattachment is possible. One of the unique challenges after amputation is phantom limb pain, which is very real for patients. Acknowledge the pain and treat it appropriately. Beta blockers can help with dull, burning sensations, while anti-epileptics may be used for stabbing, sharp pain. Teaching patients to push the residual limb down and support it on a soft pillow can provide comfort and promote adaptation. Caring for the residual limb and preparing for a prosthetic is essential for functional recovery. Use figure 8 wraps, stump shrinker socks, or air splints to shape and shrink the limb. Additionally, limb strengthening exercises are crucial to ensure successful prosthesis use and maximize mobility. Complications can arise if preventive measures are not taken. Contractures are a major concern and can be prevented through range of motion exercises and proper positioning immediately after surgery. Encourage the patient to lie prone for 20 to 30 minutes several times a day and discourage prolonged sitting to maintain joint flexibility and prevent deformities. Summarizing the NCLEX pearls, for traumatic amputations, remember to stop bleeding, elevate the limb, and preserve the severed part properly. Post-operatively, prevent contractures with prone positioning and ROM exercises, and always acknowledge and treat phantom limb pain pharmacologically, emphasizing that the pain is real. With amputations covered, we are ready to transition into rehabilitation and adaptive strategies. linking surgical care to long-term functional outcomes and patient independence. An important focus for NCLEX clinical judgment. Moving forward, let's explore where we focus on osteoporosis, a condition often called the silent disease because it progresses quietly until a fracture occurs. The pathophysiology centers on low bone density, where bone resorption by osteoclasts exceeds bone formation by osteoblasts. Osteopenia is an early, milder stage and often serves as a precursor, signaling that bone loss is already underway. Prevention is key and begins with nutrition and lifestyle modifications. Calcium-rich foods like milk, green leafy vegetables, beans, and fortified juices or cereals are essential, while vitamin D can be obtained from fish, egg yolks, fortified milk, and cereals, and sunlight exposure for about 5 to 30 minutes twice per week. Lifestyle measures include limiting carbonated drinks, avoiding smoking, alcohol, and excess caffeine, and performing weight-bearing exercises to strengthen bones. Certain populations are at higher risk. Women who are postmenopausal, individuals over 60, those with a thin or lean build, and people with a family history of osteoporosis are particularly vulnerable. Other risk factors include low calcium or vitamin D intake, smoking, alcohol consumption, inactivity, hyperparathyroidism, and long-term use of corticosteroids or anticonvulsants. Clinically, osteoporosis may remain unnoticed until structural changes appear. Common findings include reduced height, acute back pain, especially after lifting or bending, a history of fractures, and spinal deformities like kyphosis. These signs often prompt further investigation. Diagnostics rely on the DXA scan, which remains the gold standard for detecting decreased bone density and assessing fracture risk. Early detection allows timely intervention and prevention of complications. Caring for patients with osteoporosis revolves around nutrition, safety, and activity. Ensure adequate calcium and vitamin D intake, preferably with food to improve absorption. Encourage weight-bearing exercise, sunlight exposure, and maintain a safe home environment by removing rugs, ensuring good lighting, and keeping walkways clear to prevent falls. Pharmacologic therapy may include calcitonin, which decreases bone resorption, estrogen, which increases bone density, but carries risks like breast or endometrial cancer and deep vein thrombosis, and raloxifene, a selective estrogen receptor modulator. Alendronate, a bisphosphonate, requires specific instructions. Take it with 8 ounces of water in the morning before food, remain upright for at least 30 minutes afterward, and monitor for esophagitis. Additional therapies focus on structural support and safe mobility. Orthotic devices may be used to immobilize the spine. Log rolling techniques ensure spinal safety when moving patients. And joint repair or arthroplasty may be necessary if fractures are severe. In summary, the NCLEX pearl is that osteoporosis is often silent until fractures occur. Prevention through proper nutrition, lifestyle modification, fall prevention, and early pharmacologic intervention is the cornerstone of care. Now let's shift our focus to musculoskeletal trauma, a critical topic for both clinical practice and NCLEX preparation. Trauma can manifest in various ways, but the most common injuries we encounter are fractures, and knowing their types is essential. Fractures can be closed or simple, meaning the bone is broken, but the skin remains intact, or open or compound, where the skin is broken, increasing the risk of infection. Fractures may also be complete, going through the entire bone, or incomplete, where only part of the bone is involved. More complex types include comminuted fractures, where the bone is shattered into multiple pieces, displaced fractures, where the fragments are misaligned, oblique fractures, which run diagonally, and spiral fractures, often caused by twisting injuries and sometimes suspicious for abuse. Certain populations are at higher risk for fractures. Postmenopausal women, individuals with osteoporosis, patients with bone diseases, and anyone involved in falls or motor vehicle accidents are particularly vulnerable. Clinically, fractures present with crepitus, deformity, muscle spasms, edema, and ecchymosis, all of which guide our initial assessment. From a nursing perspective, stabilization and early care are vital. Elevate the injured limb above heart level, apply ice, and perform meticulous neurovascular checks. Initially every hour for the first 24 hours, then every 1 to 4 hours, monitoring pain, sensation, temperature, capillary refill, pulses, and movement. When fractures require immobilization, casts are commonly used. Handle wet plaster cast with the palms, never fingertips, and elevate them for 24 to 48 hours. Patients should never insert objects inside the cast. For itching, use a cool air dryer. Watch for hot spots, foul odor, or drainage, which may signal infection. Some fractures require traction to maintain alignment and relieve muscle spasms. For instance, Bryant traction is used in children with congenital hip dislocations, while Buck's traction is commonly applied preoperatively for hip fractures. Always ensure weights hang freely and never rest on the floor or bed. Severe spasms should prompt immediate notification of the provider. For halo traction, remember to move the patient as a single unit and perform pin site care once per shift, monitoring for drainage, redness, or loosening. When surgical intervention is necessary, we may use external fixation, where pins and wires are attached to an external frame, or ORIF, which involves internal plates, screws, rods, or prosthetics. Pharmacologic support includes analgesics, muscle relaxants, and antibiotics as appropriate. It is crucial to be alert for complications, some of which can be life-threatening. Compartment syndrome is a medical emergency caused by increased pressure within the muscle compartment, leading to ischemia. Early signs include pain unrelieved by medications and paresthesia, while late signs progress to paralysis, pallor or cyanosis, pulselessness, and hard, swollen muscles. Immediate fasciotomy is required, and importantly, do not elevate or apply cold to the affected limb. Another serious complication is a fat embolism, typically occurring 12 to 48 hours after a long bone fracture or arthroplasty, presenting with dyspnea, tachypnea, hypoxemia, tachycardia, confusion, and later, petechiae. DVT and pulmonary embolism are always a concern. Prevention involves compression devices, stockings, and anticoagulants. Finally, osteomyelitis or bone infection presents with bone pain, erythema, edema, fever, and leukocytosis, requiring prolonged antibiotic therapy, possible surgical debridement, and hyperbaric oxygen therapy. Before we continue with the next NCLEX topic, let me share something that could be a real game changer for you. If you want to make sure you pass on your very next attempt, we've created the Ultimate NCLEX Crash Course, a shortcut that has already helped over 100,000 nursing students achieve success. It's an all-in-one program that includes live interactive classes and recorded sessions you can watch anytime, 5,000 high-yield practice questions, 30 full-length mock tests, ebooks and PDF notes, a complete student planner, in-depth NGN question discussions. Everything you need to pass the NCLEX is right here in one place. Simply scan the QR code on your screen or use the link in the description to enroll now and unlock instant free access to PDF notes, practice tests, and NCLEX quizzes. Plus, you'll also get entry to our Telegram and WhatsApp channels for even more free resources. Now, let's dive into the next NCLEX topic. Moving forward, let's explore osteoarthritis and low back pain, two musculoskeletal issues that are extremely common and highly tested on the NCLEX. Starting with osteoarthritis. This is a progressive degenerative disorder where articular cartilage slowly wears away and bone spurs form. Clinically, patients experience joint pain with activity that improves with rest, localized discomfort without systemic symptoms, and asymmetrical joint involvement. Classic signs include Heberden's nodes at the distal interphalangeal joints and Bouchard's nodes at the proximal interphalangeal joints, along with joint stiffness, crepitus, and visible enlargement. Risk factors are primarily advanced age over 60, female gender, obesity, smoking, and repetitive joint stress. Nursing education emphasizes balancing rest with activity, using heat therapy for stiffness and ice for acute inflammation, as well as assistive devices, splints, and physical therapy to maintain joint function. Medications commonly used include acetaminophen up to 4,000 milligrams per day, topical NSAIDs, and capsaicin cream applied with gloves, avoiding broken skin and eyes, with a burning sensation being expected. Glucosamine may support cartilage health, while intra-articular glucocorticoid injections reduce inflammation, and hyaluronic acid injections enhance joint lubrication. If conservative measures fail, total joint arthroplasty is indicated. Patients should be monitored for renal function and gastrointestinal bleeding, such as black tarry stools, especially if using NSAIDs. In contrast, rheumatoid arthritis is an autoimmune disorder causing inflammation of the synovial membrane, cartilage destruction, and bone erosion. Unlike osteoarthritis, RA typically presents with pain at rest or after immobility, especially morning stiffness, and symmetrical joint involvement. Systemic manifestations may affect the lungs, heart, skin, and other extra-articular tissues, and patients are often underweight, in contrast to OA, where overweight is common. Hands may show swan neck and boutonniere deformities, and laboratory testing often reveals a positive rheumatoid factor, confirming the autoimmune nature. Management focuses on controlling inflammation, preventing joint damage, and maintaining function. Shifting slightly to low back pain, which is another high-yield NCLEX topic. Common causes include muscle strain, herniated discs, or spinal stenosis. Nursing care emphasizes proper posture, avoiding prolonged sitting or standing, and using a firm mattress. Physical therapy is important for core strengthening, and medications may include non-steroidal, anti-inflammatory drugs or muscle relaxants as prescribed. Patient education highlights weight reduction, regular exercise, and avoiding lifting heavy objects with the back bent. For quick NCLEX comparison, remember, osteoarthritis is degenerative, localized, often asymmetric, and occurs in overweight patients with nodes, while rheumatoid arthritis is autoimmune, systemic, bilateral, affects underweight patients, and presents with joint deformities and morning stiffness. Understanding these differences is essential for both assessment and patient teaching. Now, let's move into integumentary diagnostic procedures, which focuses on how we identify and manage skin infections and lesions. Starting with bacterial infections, patient care involves daily bathing with antibacterial soap and gently removing crusted exudate before applying topical medications to enhance absorption. For superficial infections, topical antibacterial creams or ointments are sufficient, whereas cellulitis or deeper infections require systemic antibiotics. Laboratory diagnostics are key. A culture identifies the pathogen, while a sensitivity test determines whether the organism is susceptible or resistant to specific antibiotics, with results typically available in 24 to 48 hours. Next, viral lesions require slightly different care. Burroughs solution compresses, applied for 20 minutes 3 times daily, help promote crust formation and healing, and topical acyclovir is commonly prescribed. For diagnostics, a Zank smear can confirm the viral origin of the lesion, allowing targeted management. For fungal infections, the primary treatment is clotrimazole cream applied twice daily, continuing therapy for 1 to 2 weeks, even after the lesions resolve to ensure complete eradication. Confirmation is obtained through a potassium hydroxide KOH test, which detects fungal elements in the lesion. Finally, skin biopsies, which may be punch, shave, or excisional, are performed to rule out or confirm malignancy. Patients may experience mild discomfort, but it is important to report any excessive bleeding, erythema, swelling, or purulent drainage, which could indicate infection or poor healing. Remember these NCLEX pearls. Culture identifies the pathogen, sensitivity guides antibiotic choice, Burroughs solution and Zank smear are linked to viral lesions, KOH test confirms fungal infections, and skin biopsy is crucial for malignancy confirmation. Understanding these diagnostic procedures ensures proper treatment, patient safety, and effective education on integumentary disorders. Now let's move into burns, a critical topic where quick assessment and intervention can save lives. When assessing burn severity, nurses often use the rule of nines, which estimates the percentage of total body surface area affected. The head is 9%, 9%, each arm 9%, front torso 18%, back torso 18%, each leg 18%, and the perineum 1%. For more precise calculations, especially in children, the Lund and Browder chart is used, while the Palmer method, using the patient's palm as approximately 1% of TBSA, is helpful for smaller burns or scattered areas. Burn care progresses through 3 phases. The emergent phase, from 0 to 48 hours, focuses on airway management, fluid resuscitation, pain control, and wound care. The acute phase continues until wound closure, and the rehabilitative phase emphasizes mobility, preventing scars, and contracture prevention. Understanding burn depth is crucial. Superficial burns are red and painful without blisters. Superficial partial thickness burns involve the epidermis and part of the dermis, appear pink-red with blisters, and do not form eschar. Deep partial thickness burns extend further into the dermis, with red or white appearance, soft dry eschar, and edema. Full-thickness burns involve epidermis, dermis, and subcutaneous tissue with red, yellow, or black coloring, hard eschar, severe edema, and absent blisters. Deep full-thickness burns extend into muscle, tendon, or bone, are black, and have no edema. Inhalation injury is a life-threatening concern, and nurses should watch for singed nasal hairs, eyebrows, or eyelashes. Hoarseness, wheezing, sooty sputum, smoky odor, and nasal edema, as these require early airway management and often intubation. Laboratory changes occur in 2 phases. During the resuscitation phase, the first 24 to 48 hours, hemoconcentration results in elevated hematocrit and hemoglobin, sodium drops due to third spacing, and potassium rises from cell destruction. In the remobilization phase, around 48 to 72 hours, hemoglobin, hematocrit, sodium, and potassium all decrease. Fluid resuscitation is guided by the Parkland formula, calculating 4 milliliters times body weight in kilograms times the percentage of TBSA burned, with half of the volume given in the first 8 hours and the remainder over the next 16 hours. Large bore IV access is essential, while IM and subcutaneous routes are avoided due to poor absorption. Burns create a hypercatabolic state, so patients may require up to 5,000 calories per day, with early enteral nutrition preferred, and total parenteral nutrition if necessary. Nursing care also involves stopping the burning process, flushing chemicals with water, maintaining warmth, providing tetanus prophylaxis, humidified oxygen, and strict infection control, including restricting plants, flowers, raw fruits, and vegetables, and limiting visitors. Range of motion exercises and pressure dressings help reduce contractures and scarring. Medications include silver nitrate applied with gauze and silver sulfadiazine, which requires monitoring for transient neutropenia. Skin coverage options include allografts, cadaver skin, xenografts, animal skin, cultured grafts grown from the patient, and artificial grafts such as shark cartilage or beef collagen. Key NCLEX pearls are: know the rule of 9s and Parkland formula, with half the fluids in the first 8 hours. Identify inhalation burns early for intubation. Expect hyperkalemia initially and hypokalemia later. Monitor WBCS with silver sulfadazine. Maintain strict infection control. And during the rehabilitative phase, prevent contractures using ROM exercises, splints, and pressure dressings. Mastering these priorities ensures safe, evidence-based care for burn patients. Let's now turn our focus to endocrine diagnostic procedures, where understanding hormone function and diagnostic testing is essential for safe patient care. Starting with the posterior pituitary, we know it releases antidiuretic hormone, or ADH, which helps the kidneys reabsorb water. When ADH is low, diabetes insipidus occurs, producing large amounts of dilute urine, while high ADH results in syndrome of inappropriate antidiuretic hormone, SIADH, causing water retention, concentrated urine, and decreased urine output. To diagnose DI, a water deprivation test is used, where controlled dehydration evaluates the kidney's ability to concentrate urine. In contrast, SIADH labs show high urine osmolality and high specific gravity greater than 1.025, reflecting concentrated urine. Moving to the adrenal cortex, hormone imbalances can be life-altering. Excess cortisol leads to Cushing's disease, with features like weight gain, moon face, and hypertension, while cortisol deficiency results in Addison's disease, characterized by fatigue, hypotension, and hyperpigmentation. Diagnostic tests include the dexamethasone suppression test, where normal feedback lowers ACTH and cortisol. But in Cushing's disease, there is no suppression. The ACTH stimulation test distinguishes Addison's disease. A rise in cortisol is normal, but no increase indicates Addison's. The adrenal medulla can also be affected by tumors, specifically pheochromocytoma, which secretes excess catecholamines. Classic findings include uncontrolled hypertension, tachycardia, diaphoresis, and palpitations, making early recognition and blood pressure control critical. For diabetes mellitus, multiple tests help confirm diagnosis. A fasting blood glucose requires at least 8 hours of NPO status, and 110 milligrams per deciliter or higher may indicate diabetes. The oral glucose tolerance test evaluates blood glucose response over 30 minutes to 4 hours after a glucose drink, with 140 milligrams per deciliter or higher suggesting diabetes. Hemoglobin. HbA1c reflects the average blood glucose over the prior 120 days, and 6.5% or higher confirms a diagnosis of diabetes. Finally, the thyroid and anterior pituitary axis is evaluated with T3, T4, and TSH levels. Hyperthyroidism presents with high T3 and T4 and low TSH, while hypothyroidism shows low T3 and T4 with elevated TSH, following the classic feedback pattern. NCLEX learners should remember key endocrine principles. DI produces dilute urine. SIADH produces concentrated urine. Cushing's is too much cortisol. Addison's is too little. Pheochromocytoma causes uncontrolled hypertension with sweating and palpitations. HbA1c above 6.5% confirms diabetes. And TSH levels move opposite of thyroid hormones, high in hypothyroidism and low in hyperthyroidism. Understanding these patterns ensures prompt recognition, safe monitoring, and effective patient teaching in endocrine disorders. Let's now explore pituitary disorders, focusing on diabetes insipidus and syndrome of inappropriate antidiuretic hormone. Starting with diabetes insipidus, this condition results from low antidiuretic hormone, meaning the kidneys cannot concentrate urine. Causes include primary DI due to a hypothalamic or pituitary defect, secondary DI from head trauma, tumors, infections, or brain surgery, and nephrogenic DI, where the kidneys are resistant to ADH. Patients present with abrupt polyuria, often producing liters of dilute urine per day, and intense polydipsia. Signs of dehydration are prominent, including sunken eyes, tachycardia, hypotension, dry mucous membranes, decreased skin turgor, and fatigue. Laboratory findings show urine-specific gravity less than 1.010, urine osmolality under 200, serum osmolality above 300, and elevated sodium and potassium. Diagnostic tests such as the water deprivation test confirm the inability of kidneys to concentrate urine, while the vasopressin test differentiates central from nephrogenic DI. Management includes ADH replacement with desmopressin or vasopressin, careful monitoring of daily weights and intake/output, and promoting a high-fiber diet to prevent constipation from dehydration. On the other hand, SIADH, or syndrome of inappropriate ADH, results from excess ADH, causing water retention and dilutional hyponatremia. Risk factors include head trauma, tumors, and CNS disorders. Clinical findings reflect fluid overload, including confusion, seizures, and potentially coma from low sodium, as well as crackles in the lungs, distended neck veins, bounding pulses, tachycardia, and hypertension. Labs show increased urine sodium and osmolality, while serum sodium and serum osmolality are low, reflecting concentrated urine in the setting of dilutional hyponatremia. Nursing care focuses on strict fluid restriction, daily weights, meticulous intake, output tracking, and seizure precautions. Medications may include loop diuretics like furosemide, and in severe cases, hypertonic saline at 3% sodium chloride is used to correct dangerous hyponatremia. Complications to watch for include water intoxication, cerebral edema, and seizures from severe hyponatremia. NCLEX learners should remember the simple mnemonic: DI is dry inside, characterized by polyuria, dehydration, high serum sodium, and dilute urine, whereas SIADH is soaked inside, with fluid overload, low serum sodium, and concentrated urine. Both conditions demand careful fluid and electrolyte monitoring, early recognition, and prompt intervention to prevent life-threatening complications. Moving forward, let's focus on hyperthyroidism, primarily caused by Graves' disease, an autoimmune disorder where antibodies stimulate the thyroid to overproduce T3 and T4 hormones. This results in a hypermetabolic state, so patients often present with low TSH, high T3 and T4, weight loss despite increased appetite, nervousness, irritability, and insomnia. They may also experience heat intolerance, warm flushed skin, excessive sweating, diarrhea, exophthalmos or bulging eyes, hypertension, tachycardia, and even dysrhythmias. Nursing care emphasizes supporting metabolism while preventing complications. Encourage a high-calorie diet and monitor weight daily. Protect the eyes with taping eyelids closed at night if necessary. Avoid palpating the thyroid to prevent triggering a thyroid storm. and position the patient in high Fowler's post-thyroidectomy. Close observation is required for laryngeal nerve damage, indicated by hoarseness or stridor, and for hypocalcemia if parathyroid glands are affected, signaled by muscle twitching and positive Chvostek and Trousseau signs. Medications play a central role in managing hyperthyroidism. Propylthiouracil, PTU, inhibits thyroid hormone production, but carries risks of leukopenia and thrombocytopenia, while propranolol helps control tachycardia and hypertension. Iodine solutions temporarily inhibit thyroid hormone release, and radioactive iodine therapy permanently decreases thyroid function, but is contraindicated in pregnancy, requiring safety precautions such as avoiding close contact, not sharing utensils, and flushing the toilet twice. Post-surgical patients may need thyroid hormone replacement levothyroxine if hypothyroidism develops, and prednisone can help reduce postoperative edema. A critical complication to watch for is thyroid storm, often triggered by stress, infection, or surgery. It manifests with high fever, severe hypertension, delirium, tachycardia, vomiting, and chest pain. Emergency management includes acetaminophen for fever, avoiding aspirin, cooling measures like sponge baths or cooling blankets, PTU, propranolol, and supplemental oxygen. NCLEX learners should remember the mnemonic high and hot. Hyperthyroid patients have increased metabolism, heart rate, blood pressure, temperature, and exophthalmos. Early recognition and timely interventions, including monitoring, medication administration, dietary support, and patient education, are essential to prevent life-threatening complications and support recovery. Now that we have reviewed hyperthyroidism, let's shift our focus to Chapter 79. Hypothyroidism, a condition in which the thyroid gland produces insufficient hormones, slowing metabolism throughout the body. The most common cause is Hashimoto's thyroiditis, an autoimmune disorder, though cretinism in infants is another cause, and women are more frequently affected. Hypothyroidism can be primary, due to intrinsic thyroid gland dysfunction, secondary, due to inadequate TSH from the anterior pituitary, or tertiary, due to insufficient TRH from the hypothalamus. Clinically, patients often present with cold intolerance, fatigue, lethargy, constipation, weight gain. Despite a low appetite, pale dry skin, brittle hair and nails, hair loss, depression, and slowed cognitive processing, along with bradycardia and hypotension. Lab findings typically show low T3 and T4, with elevated TSH in primary hypothyroidism, and anemia may also be present. Nursing care focuses on supporting energy levels and preventing complications, including encouraging frequent rest periods, activity as tolerated, and a low-calorie, high-bulk diet to prevent constipation. Nurses should avoid fiber laxatives as they can interfere with absorption of thyroid medications, and levothyroxine therapy should be started at a low dose, taken on an empty stomach 1 to 2 hours before breakfast, and continued lifelong. Additional care includes skin protection, providing extra clothing and blankets for warmth, while avoiding electric blankets due to decreased sensation and risk of burns. A severe, life-threatening complication is myxedema coma, often triggered by untreated hypothyroidism, illness, or stress, which presents with respiratory depression, decreased cardiac output, cerebral hypoxia, hypothermia, bradycardia, and hypotension, and requires emergency management with IV levothyroxine, airway support, warming measures, and fluid replacement. For NCLEX recall, remember the mnemonic low and slow. Metabolism, heart rate, blood pressure, body temperature, energy, and mood all decrease, reflecting the systemic slowing characteristic of hypothyroidism. Before we continue with the next NCLEX topic, let me share something that could be a real game changer for you. If you want to make sure you pass on your very next attempt, we've created the Ultimate NCLEX Crash Course, a shortcut that has already helped over 100,000 nursing students achieve success. It's an all-in-one program that includes live interactive classes and recorded sessions you can watch anytime, 5,000 high-yield practice questions, 30 full-length mock tests, ebooks and PDF notes, a complete student planner, in-depth NGN question discussions. Everything you need to pass the NCLEX is right here in one place. Simply scan the QR code on your screen or use the link in the description to enroll now and unlock instant free access to PDF notes, practice tests, and NCLEX quizzes. Plus, you'll also get entry to our Telegram and WhatsApp channels for even more free resources. Now, let's dive into the next NCLEX topic. Moving on to Cushing's disease and syndrome, let's explore this endocrine disorder characterized by excess cortisol. The pathophysiology starts with the hypothalamus releasing CRH, stimulating the anterior pituitary to secrete ACTH, which then signals the adrenal cortex to produce cortisol. Cushing's can result from pituitary tumors that increase ACTH, adrenal hyperplasia or tumors, or prolonged use of glucocorticoids known as iatrogenic Cushing's. Clinically, patients present with a classic appearance of moon face, buffalo hump, and truncal obesity with thin extremities, alongside thin, fragile skin, easy bruising, purple striae, and poor wound healing. Cardiovascular and fluid changes include hypertension, dependent edema, and tachycardia, while metabolic disturbances are manifested as hyperglycemia and weight gain. Musculoskeletal complications include osteoporosis, fractures, bone pain, and muscle weakness, and gastrointestinal effects may include gastric ulcers. Other findings include hirsutism, acne, fatigue, depression, and increased susceptibility to infections due to immunosuppression. Lab tests typically reveal elevated cortisol, high glucose and sodium, low potassium and calcium, and a dexamethasone suppression test fails to suppress cortisol, confirming the diagnosis. Nursing care focuses on dietary management with low sodium, high protein, high calcium, and high potassium intake, fall risk precautions due to weakened bones and muscles, infection prevention, and gentle skin care for fragile skin. Medications such as spironolactone for potassium-sparing diuresis and chemo or radiation therapy for pituitary tumors may be indicated. Surgical interventions include hypophysectomy for pituitary removal, which requires careful monitoring for nasal drainage containing glucose or halo sign indicative of cerebrospinal fluid leak, and strict avoidance of coughing, sneezing, blowing the nose, straining, or bending at the waist, along with temporary avoidance of toothbrushing. Adrenalectomy is another option but requires lifelong hormone replacement and vigilant monitoring for adrenal crisis, which can present as hypotension, shock, severe weakness, and vascular collapse. For NCLEX recall, think Cushing's equals cushion of cortisol, highlighting high glucose, high sodium, low potassium, and low calcium, with the biggest patient risks being infection, fractures, skin breakdown, and gastrointestinal bleeding. Now let's discuss Addison's disease, an endocrine disorder resulting from adrenal insufficiency, meaning the adrenal cortex does not produce enough cortisol and often aldosterone. Most cases are due to autoimmune destruction of the adrenal glands, although other causes like infection or surgical removal can occur. Symptoms usually develop gradually and include hyperpigmentation of the skin, gums, and creases, unexplained weight loss, salt cravings, fatigue, weakness, nausea, and vomiting. A critical emergency, known as Addisonian crisis, can be triggered by infection, trauma, stress, or abrupt discontinuation of steroids, leading to severe hypotension, shock, and life-threatening electrolyte imbalances. Lab findings typically show hyponatremia, hyperkalemia, hypercalcemia, hypoglycemia, and a failure of plasma cortisol to rise during an ACTH stimulation test, confirming primary Addison's disease. Nursing care focuses on monitoring fluids and electrolytes closely, providing glucocorticoid replacement therapy, such as hydrocortisone or prednisone, and adjusting doses during illness or stress according to sick day rules. Glucocorticoid therapy requires vigilance for side effects, including hyperglycemia, osteoporosis, peptic ulcer disease, and increased risk of infection. Additional interventions may include insulin, calcium, sodium bicarbonate, or loop diuretics depending on specific imbalances. Patients require lifelong hormone replacement, education on medication adherence, and recognition of early signs of crisis. For NCLEX memory recall, think low and slow. Low cortisol, low sodium, low glucose, with Addisonian crisis as an emergency scenario involving shock and severe hypotension. Now, let's focus on diabetes mellitus, a chronic disorder of glucose metabolism caused by either inadequate insulin production in type 1 diabetes or insulin resistance in type 2 diabetes, which leads to persistent hyperglycemia and increases the risk for complications like cardiovascular disease, hypertension, kidney disease, neuropathy, retinopathy, peripheral vascular disease, and stroke. Populations at higher risk include Black, Hispanic, and Native American individuals. The types include type 1, which is autoimmune destruction of pancreatic beta cells. Type 2, characterized by insulin resistance often associated with obesity. And gestational diabetes, which develops during pregnancy. Risk factors are broad and include hypertension, obesity, physical inactivity, hyperlipidemia, smoking, family history, and elevated C-reactive protein levels. Classic symptoms include the 3 Ps, polyuria, polydipsia, and polyphagia, along with fatigue, weak pulses, and in diabetic ketoacidosis, metabolic acidosis with small respirations, fruity breath, abdominal pain, nausea, vomiting, headache, confusion, seizures, and potentially coma. Diagnosis is confirmed through casual blood glucose greater than 200 milligrams per deciliter, fasting blood glucose over 126 milligrams per deciliter, or a 2-hour oral glucose tolerance test above 200 milligrams per deciliter, requiring 2 abnormal results on separate days, and HbA1c goals under 7% indicate good glucose control. Insulin therapy varies. Rapid-acting Lispro has an onset of 15 minutes, peaks at 30 to 60 minutes, and lasts 3 to 4 hours. Short-acting regular insulin starts in 30 to 60 minutes, peaks in 2 to 3 hours, and lasts 5 to 7 hours. Intermediate NPH insulin begins in 1 to 2 hours, peaks at 4 to 12 hours, and lasts 18 to 24 hours. And long-acting glargine starts in 1 hour, has no peak, and lasts 24 hours, and should not be mixed. Always rotate injection sites, use a 90-degree angle, and remember to draw clear insulin before cloudy. Hypoglycemia, defined as blood glucose below 70 milligrams per deciliter, presents with shakiness, sweating, headache, confusion, blurred vision, lack of coordination, or seizures. If the patient is conscious, provide 15 to 20 grams of fast-acting carbohydrates. And if unconscious, administer glucagon intramuscularly or intravenously. Oral medications include metformin to decrease glucose production and increase tissue sensitivity, glipizide to stimulate insulin release, pioglitazone to enhance tissue sensitivity, repaglinide to boost insulin release before meals, and acarbose to slow carbohydrate absorption. Lifestyle management emphasizes foot care with daily inspection, washing and drying thoroughly, avoiding lotion between toes, trimming nails straight across after showering, wearing protective footwear, never walking barefoot, maintaining meal consistency, carb counting with 15 grams as one exchange, and staying hydrated with 2 to 3 liters of fluid daily. Complications to monitor include cardiovascular disease with blood pressure and cholesterol checks, annual eye exams for retinopathy, neuropathy assessment through sensation checks, and nephropathy monitoring with strict I&O and avoidance of nephrotoxic substances such as NSAIDs, acetaminophen, and alcohol. For NCLEX recall, remember DKA occurs in type 1 diabetes with small respirations, ketones, fruity breath, and acidosis, whereas HHNS is typical in type 2, presenting with extreme hyperglycemia and dehydration but without ketones. Let's now examine complications of diabetes, focusing on the 2 most critical acute emergencies: diabetic ketoacidosis, DKA, and hyperglycemic hyperosmolar syndrome, HHS. Starting with DKA, this primarily affects patients with type 1 diabetes and is often triggered by missed insulin doses, infections, illness, or undertreated diabetes. Blood glucose levels are usually above 300 milligrams per deciliter, and onset is rapid. The pathophysiology involves an absolute insulin deficiency, leading to fat breakdown, ketone formation, and metabolic acidosis. Classic symptoms include gastrointestinal upset such as nausea, vomiting, and abdominal pain, fruity breath odor, small respirations which are deep and rapid, polyuria, polydipsia, and dehydration. Laboratory findings reveal metabolic acidosis with positive ketones. Nursing care involves treating the underlying cause, administering isotonic fluids like 0.9% normal saline, giving intravenous regular insulin, monitoring and replacing potassium due to risk of hypokalemia. Once insulin therapy begins, and in severe acidosis, sodium bicarbonate may be administered. Transition to subcutaneous insulin occurs when glucose falls below 200 milligrams per deciliter. Patient teaching emphasizes frequent glucose monitoring during illness, never skipping insulin doses, maintaining hydration with approximately 3 liters of fluid per day, and contacting the provider if blood glucose exceeds 240 milligrams per deciliter or fever develops. In contrast, HHS occurs primarily in patients with type 2 diabetes, especially older adults with infections, dehydration, stress, or impaired kidney function. Blood glucose in HHS is typically above 600 milligrams per deciliter, and onset is gradual. Pathophysiology involves enough insulin to prevent ketone formation, so acidosis does not occur, but profound dehydration and hyperosmolarity develop. Patients present with severe dehydration evidenced by dry mucous membranes, tachycardia and hypotension, polyuria and polydipsia, and neurological changes including confusion, seizures, or coma, but notably no fruity breath or Kussmaul respirations. Laboratory findings reveal high serum osmolality with absent or trace ketones. Care involves treating the underlying cause, aggressive fluid replacement, intravenous regular insulin, and close monitoring of potassium and other electrolytes. For a quick NCLEX comparison, remember, DKA type 1 presents with glucose greater than 300 milligrams per deciliter, rapid onset, ketones and acidosis, Kussmaul respirations, dehydration, and requires fluids, plus insulin with potassium monitoring, whereas HHS, type 2, presents with glucose greater than 600 milligrams per deciliter, gradual onset, no ketones, normal breathing, severe dehydration with neurological changes, and requires aggressive fluids plus insulin with potassium monitoring. The key NCLEX tip is simple. If you see fruity breath and Kussmaul respirations, think DKA. If you see extremely high glucose with profound dehydration but no ketones, think HHS. Let's dive into WBC and immune system diagnostics, starting with the normal white blood cell count, which ranges from 5,000 to 10,000 per cubic millimeter. When the WBC count drops below 5,000, known as leukopenia, it may indicate autoimmune diseases or overwhelming infection due to bone marrow suppression. Conversely, a white blood cell count above 10,000, called leukocytosis, usually reflects infection, inflammation, or tissue injury. A special alert is for neutropenia, defined as less than 2,000 neutrophils, which places patients at high risk for infection and is commonly seen with chemotherapy. These patients require neutropenic precautions such as avoiding fresh flowers, limiting visitors with illness, and strict hand hygiene. Another important concept is the left shift, which is an increase in immature neutrophils or bands, indicating the body is mounting a strong acute response to infection. Moving on to types of WBCs and their roles, neutrophils, comprising 55 to 70% of WBCs, are the first responders and rise in acute bacterial infections. Lymphocytes, which make up 20 to 40%, provide long-term defense and increase in chronic bacterial or viral infections, such as mono, measles, or mumps. Monocytes, 2 to 8%, are the big eaters or macrophages, elevated in protozoal and viral infections. Eosinophils, 1 to 4%, rise in allergic reactions and parasitic infections. Think allergy and parasites. Finally, basophils, rare at half to 1%, release histamine and are mainly noted in leukemia. Regarding skin testing for allergies, allergens are introduced via intradermal injections or superficial scratches. Patients must avoid antihistamines for 48 hours, up to 2 weeks before testing to prevent false negative results. Assessment involves inspecting for erythema, wheal, or flare reactions at 15 to 20 minutes post-exposure. Key NCLEX clinical pearls include fever in a neutropenic patient is a medical emergency due to infection risk. A left shift signals acute bacterial infection, so initiating antibiotics promptly is a priority. High eosinophils suggest allergies or parasitic infection. And for allergy testing, antihistamines or corticosteroids should never be given before the test because they blunt the immune response. Remembering these patterns helps you rapidly interpret WBC results and prioritize care safely in clinical scenarios. Before we continue with the next NCLEX topic, let me share something that could be a real game changer for you. If you want to make sure you pass on your very next attempt, we've created the ultimate NCLEX crash course, a shortcut that has already helped over 100,000 nursing students achieve success. It's an all-in-one program that includes live interactive classes and recorded sessions you can watch anytime, 5,000 high-yield practice questions, 30 full-length mock tests, ebooks and PDF notes, a complete student planner, in-depth NGN question discussions. Everything you need to pass the NCLEX is right here in one place. Simply scan the QR code on your screen or use the link in the description to enroll now and unlock instant free access to PDF notes, practice tests, and NCLEX quizzes. Plus, you'll also get entry to our Telegram and WhatsApp channels for even more free resources. Now, let's dive into the next NCLEX topic. Let's review immunizations and types of immunity for NCLEX. Immunity can be active or passive, and natural or artificial. Active natural immunity occurs when the body produces antibodies after natural exposure, such as recovering from chickenpox, whereas active artificial immunity develops after a vaccine, like the MMR shot, where the body still generates its own antibodies. Passive natural immunity is when antibodies are transferred from mother to baby through the placenta or breast milk, providing temporary protection. In contrast, passive artificial immunity involves receiving antibodies through immune globulin, which provides immediate but short-term protection. When administering vaccines, comfort measures are important. Apply cool compresses for local tenderness, use an antipyretic for fever, and encourage movement of the injected extremity to reduce discomfort. Documentation is critical and should include vaccine type, route, site, manufacturer, lot number, expiration date, patient information, and nurse information. The preferred injection sites are the deltoid for intramuscular injections and the upper arm or thigh for subcutaneous injections. Key vaccines and schedules include Tdap boosters every 10 years, MMR as a live attenuated vaccine, avoid in pregnancy and immunocompromised. Clients: varicella in 2 doses, also avoid in pregnancy or immunocompromised. Pneumococcal for high-risk groups such as immunocompromised patients, those with chronic illness, smokers, or long-term care residents. Hepatitis A and B for healthcare workers or high-risk individuals. Annual influenza vaccination for all adults. Meningococcal for students 21 years or younger entering college dorms. HPV as a 3-dose series at 0, 2, and 6 months. And zoster, shingles, as a one-time dose for adults over 60. Absolute contraindications include anaphylaxis to vaccine components. Specific allergies apply. Avoid MMR in those allergic to eggs, gelatin, or neomycin. Varicella in those allergic to gelatin or neomycin. And in pregnant clients, influenza with egg allergy, though CDC still recommends vaccination, and HPV with latex allergy. Minor illnesses like a mild cold or low-grade fever are not contraindications. Adverse effects are usually mild, including tenderness at the injection site, low-grade fever, or malaise, while serious reactions like anaphylaxis are rare but require emergency management. For NCLEX preparation, remember to always ask about allergies, particularly eggs, gelatin, latex, and neomycin. And know that live vaccines like MMR, varicella, zoster, and flu mist are contraindicated in pregnancy and immunocompromised patients. The flu shot is given annually regardless of age, and meticulous documentation of lot number, expiration date, site, and nurse signature is a common testing point. A simple trick to remember is live equals no pregnant, no immunocompromised, which helps you quickly recall contraindications for live vaccines. This knowledge is critical for patient safety and is a high-yield NCLEX testing point. Now, let's break down HIV and AIDS for NCLEX review. HIV is a retrovirus transmitted through blood and body fluids that attacks CD4 plus T lymphocytes, progressively weakening the immune system. When HIV advances and the CD4 count drops below 200, or when opportunistic infections appear, the diagnosis becomes AIDS. HIV progresses in 3 stages. In stage 1, acute HIV, CD4 counts are above 500, and clients may experience flu-like symptoms, including fever, sore throat, rash, night sweats, headache, and weight loss. Stage 2, chronic or latency, is often asymptomatic or mild, but the virus continues to replicate. Stage 3, AIDS, is marked by CD4 counts under 200 and the emergence of opportunistic infections, which define the severity of the disease. Common opportunistic infections include oral or esophageal candidiasis, chronic herpes simplex, Kaposi sarcoma with purple skin lesions, tuberculosis, pneumocystis, girovecii pneumonia, wasting syndrome, and cytomegalovirus infections. Risk factors are important to remember for NCLEX. High-risk behaviors include unprotected sex and multiple sexual partners, intravenous drug use, occupational exposures like needle sticks, and perinatal transmission from mother to baby. Diagnosis begins with ELISA as the initial screen and is confirmed by Western blot. Disease progression is monitored through CD4 counts and viral load. Treatment relies on antiretroviral therapy, or ART, which usually involves a combination of drugs to reduce viral load, increase CD4 count, prevent resistance, and improve quality of life. Patient education is essential. Practice hand hygiene, avoid raw or undercooked foods, avoid cleaning pet litter boxes due to toxoplasmosis risk, and practice safe sex with condoms while limiting partners. Clients should also maintain regular follow-up visits to monitor CD4 counts and viral load and be encouraged to identify and use a support system for emotional and social assistance. Complications of HIV/AIDS include serious infections such as TB, PCP, CMV, and herpes, cancers like Kaposi sarcoma and lymphoma, wasting syndrome, and neurological issues including HIV-associated encephalopathy. For NCLEX purposes, a CD4 count below 200 automatically defines AIDS, regardless of viral load and opportunistic infections. At this stage are life-threatening, making early recognition and prompt ART management critical for patient survival. Let's dive into autoimmune and musculoskeletal disorders for NCLEX review, starting with systemic lupus erythematosus, or SLE. SLE is a chronic autoimmune disease that causes widespread inflammation and connective tissue damage across multiple organs, whereas discoid lupus, DLE, affects only the skin with localized lesions. The disease primarily affects women aged 20 to 40, especially those who are Black, Asian, or Native American. Clinical findings include fatigue, fever, hair loss, pleuritic chest pain, joint pain or swelling, lymphadenopathy, Raynaud's phenomenon, and the hallmark butterfly rash across the nose and cheeks. Diagnostics for SLE reveal a positive anti-nuclear antibody, decreased complement levels C3 and C4, an elevated BUN and creatinine if the kidneys are involved. Medications include non-steroidal anti-inflammatory drugs for pain and inflammation, corticosteroids for immunosuppression, though these carry risks of infection, osteoporosis, and hyperglycemia, methotrexate as an immunosuppressant, and antimalarials such as hydroxychloroquine to prevent flares and protect skin and joints. Patient education focuses on avoiding sun and ultraviolet exposure, using sunscreen, applying topical steroids for skin lesions, and balancing rest with activity. Complications can include lupus nephritis, which may necessitate a kidney transplant, as well as pericarditis and myocarditis. Next, gout is a disorder caused by urate crystal deposition in joints due to hyperuricemia. Risk factors include male gender, obesity, alcohol intake, diets rich in purines, such as red meat, shellfish, and organ meats, thiazide diuretics, and chemotherapy. Clients typically present with sudden, severe joint pain, especially in the big toe, along with swelling, erythema, warmth, and limited mobility. Diagnostics reveal elevated serum uric acid and ESR. Treatment for acute attacks includes NSAIDs like indomethacin, colchicine, and corticosteroids, while chronic prevention involves allopurinol to reduce uric acid production and probenecid to increase excretion. Education emphasizes avoiding purine-rich foods and alcohol and maintaining good hydration of 2 to 3 liters per day. Finally, fibromyalgia is a chronic pain syndrome characterized by widespread musculoskeletal pain and tender trigger points, most commonly at the back of the neck, upper chest, low back, and thighs. It predominantly affects middle-aged women and is associated with stress, sleep deprivation, chronic fatigue, and other rheumatoid conditions. Clients may experience fatigue, sleep disturbances, and cognitive difficulties known as fibro fog. Medications used include duloxetine, a serotonin norepinephrine reuptake inhibitor, or pregabalin, an anticonvulsant to decrease nerve pain, as well as tricyclic antidepressants to improve sleep. Education focuses on stress reduction, maintaining a regular sleep pattern, and engaging in low-impact exercises such as swimming, walking, or yoga. For NCLEX quick cues, remember, a butterfly rash is indicative of lupus. Severe big toe pain with uric acid over 6 milligrams per deciliter points to gout, and widespread pain with tender trigger points suggests fibromyalgia. Let's focus on rheumatoid arthritis, or RA, a chronic autoimmune disorder in which the body's white blood cells mistakenly attack the synovial tissue, causing inflammation, pannus formation, and eventual joint destruction. RA typically affects joints symmetrically and bilaterally, and it is a progressive systemic disorder, meaning it impacts more than just the joints. Key risk factors include being a woman aged 20 to 50 years, having a family history of autoimmune disease, and smoking, which not only increases the risk but also worsens disease severity. Clinical findings in early RA include morning stiffness lasting more than 1 hour, fatigue, joint pain or swelling, warmth, and redness, while late-stage RA can present with joint deformities such as ulnar deviation, swan neck, and Boutonniere deformities, subcutaneous nodules, and lymph node enlargement. Systemic manifestations may include low-grade fever, reddened sclera, and weight loss. Diagnostics commonly reveal a positive rheumatoid factor at titers of 1 to 40 to 1 to 60, elevated ESR and CRP indicating inflammation, positive antinuclear antibody titer, and arthrocentesis showing cloudy synovial fluid with increased WBCS and rheumatoid factor. X-rays may demonstrate joint space narrowing, erosion, and deformity. Nursing care emphasizes relieving morning stiffness with warm showers or heat packs, reducing edema, and pain with cold therapy, conserving energy through frequent rest and a safe environment, and maintaining joint alignment with splints. Physical and occupational therapy are key for preserving function. Medications used in RA include NSAIDs for inflammation and pain, antimalarials such as hydroxychloroquine monitor for retinal damage or vision changes, methotrexate as an immunosuppressant, monitor for bone marrow suppression, liver toxicity, and infection, corticosteroids for flare management, and occasionally plasmapheresis to remove circulating antibodies and reduce autoimmune attacks. Complications may include Sjogren's syndrome, characterized by dry eyes, dry mouth, and dry vagina, progressive joint deformities leading to disability, and an increased risk of cardiovascular disease. For NCLEX tips, remember, if a question describes symmetrical joint pain with prolonged morning stiffness, think rheumatoid arthritis, whereas asymmetrical joint pain that improves with rest points to osteoarthritis. When studying general principles of cancer, it is essential to understand the risk factors, diagnostic methods, and potential complications. Risk factors include age, with older adults being at higher risk, genetics or family history of cancer, race, since some cancers are more prevalent in specific populations, environmental exposures such as chemicals, toxins, radiation, and ultraviolet light, and lifestyle factors like tobacco use, excessive alcohol intake, a diet high in fat or red meat, and low fiber consumption. Diagnosis and staging commonly use the TNM classification system, where T refers to tumor size, N refers to lymph node involvement, and M indicates metastasis, which helps determine the stage of the disease and guides treatment planning. Patients with cancer frequently experience complications related to nutrition, because cancer increases metabolic demand as the tumor consumes nutrients, and treatments like chemotherapy or radiation can cause nausea, vomiting, taste alterations, and decreased appetite. Additionally, patients may have difficulty with ingestion, digestion, and absorption, leading to weight loss, cachexia, muscle wasting, and anorexia. Nursing interventions focus on supporting nutrition through small, frequent meals, high-calorie and high-protein diets, oral nutritional supplements, and parenteral or enteral nutrition if necessary. For NCLEX purposes, always remember that in a patient with cancer, experiencing weight loss and taste changes, prioritizing nutritional support often takes precedence over symptom management, because adequate nutrition is critical to maintain strength, immune function, and treatment tolerance. When learning about cancer screening and diagnostic procedures, it is important to recognize the early warning signs, commonly remembered by the acronym CAUTION. This stands for C, change in bowel or bladder habits, A, a sore that does not heal, U, unusual bleeding or discharge, T, thickening or lump in the breast or elsewhere, I, indigestion or difficulty swallowing, O, obvious change in a wart or mole, and N, nagging cough, or hoarseness. For NCLEX purposes, any persistent occurrence of these signs warrants prompt medical evaluation, as early detection significantly improves outcomes. The definitive diagnosis of cancer is always made by biopsy, which is considered the gold standard because it examines tissue under a microscope to identify malignant cells. In addition, secondary diagnostic tools like imaging studies are commonly used to detect or evaluate the extent of cancer. These include CT scans, MRI, PET scans, which assess the metabolic activity of tumors, and ultrasound to evaluate masses or organ involvement. However, for NCLEX, remember that while imaging can suggest the presence of cancer, only a biopsy can confirm the diagnosis, making it essential for definitive care planning and treatment decisions. When studying cancer treatment options, it is essential to understand the major modalities and their nursing considerations. Surgery or tumor excision is often performed to remove the tumor and can be curative, diagnostic, or palliative depending on the stage and type of cancer. Chemotherapy works by damaging DNA and killing rapidly dividing cells, but it also affects normal tissues like mucous membranes, bone marrow, and hair follicles, leading to significant complications. Immunosuppression and neutropenia are common. Patients must be monitored closely, with immediate reporting of fever above 37.8 degrees Celsius, 100 degrees Fahrenheit, ANC less than 1,000, necessitating neutropenic precautions, such as private rooms, restricting visitors, and avoiding invasive procedures, while medications like filgrastim can stimulate white blood cell production. Patients are taught to avoid crowds, fresh fruits and vegetables, undercooked meats, eggs, or fish, refrain from gardening or handling pet litter, prevent prolonged standing fluids, practice daily toothbrush disinfection, and avoid shared personal items. Nausea and vomiting are managed with pre- and post-chemotherapy antiemetics, oral care before meals, removing triggers, and encouraging cold, high-calorie, high-protein foods while avoiding liquids with meals. Alopecia often begins 7 to 10 days post-treatment, and patients benefit from discussion about wigs, scarves, or hats to support self-image. Mucositis requires avoidance of alcohol-based mouthwashes and glycerin swabs, use of non-alcoholic anesthetic rinses, soft bristle toothbrushes, and soft, bland, high-calorie foods while avoiding spicy, salty, or acidic foods. Anemia necessitates monitoring for fatigue, pallor, dizziness, and shortness of breath, scheduling rest periods, and administering medications such as epoetin or ferrous sulfate. Thrombocytopenia increases bleeding risk, so nurses should watch for occult bleeding, avoid intramuscular injections, NSAIDs, and razors, and apply pressure for 10 minutes after blood draws. Radiation therapy, typically external, requires patients to maintain tattoo markings at treatment sites. Gently wash with mild soap and water, pat dry, avoid lotions, perfumes, powders, deodorants, sun exposure, and tight clothing, and use soft, loose garments over irradiated skin. Hormone therapy blocks hormones that fuel tumor growth, such as tamoxifen for breast cancer, with nurses monitoring for increased risk of deep vein thrombosis and endometrial cancer. Immunotherapy, or biological response modifiers, enhances the immune system's ability to attack cancer cells, using agents like interleukins or interferons. For NCLEX, remember that fever in a chemotherapy patient is an emergency indicating possible sepsis. Biopsy remains the only definitive cancer diagnosis, and radiation tattoos should never be washed off, making these high-yield points for exam readiness. When reviewing cancer disorders, it is important to focus on risk factors, findings, screenings, and nursing priorities. Skin cancer is primarily caused by sunlight exposure, with squamous cell carcinoma presenting as rough, scaly lesions, basal cell carcinoma as small, waxy nodules, and melanoma appearing as new or changing moles, making it the deadliest form. Nurses should apply the ABCDE rule: asymmetry, border irregularity, color variation, diameter greater than 6 millimeters, and evolving lesions, with treatment options including topical chemotherapy such as 5-fluorouracil, cryosurgery with liquid nitrogen, or surgical excision. Leukemia, a cancer of white blood cells, results in immature cells crowding out platelets, red blood cells, and mature leukocytes. Infection is the leading cause of death, and bleeding is a major complication due to low platelet counts. Lymphoma affects lymph nodes, and nursing care focuses on infection prevention through strict hand hygiene, avoiding raw foods, and protecting patients from injury, with therapies including chemotherapy, radiation, and bone marrow transplant. Thyroid cancer occurs more frequently in females, especially with low iodine diets or prior radiation exposure. Findings include changes in thyroid size or palpable nodules, making airway and swallowing monitoring a priority, and treatment may involve radioactive iodine or thyroidectomy. Lung cancer is most commonly caused by smoking, with chronic cough and dyspnea as presenting symptoms, and generally carries a poor prognosis. Colorectal cancer typically begins as a benign polyp that may become malignant, with blood in stool as a key sign. Screening includes annual fecal occult blood test, occult blood testing from ages 50 to 75, and colonoscopy at 50, repeated every 10 years. Breast cancer has risk factors such as genetics, BRCA mutations, early menarche, late menopause, prolonged oral contraceptive use, smoking, hormone replacement therapy, and obesity, with findings including skin changes like peau d'orange, dimpling, firm non-tender immobile tumors, nipple discharge, retraction, or ulceration. Therapies may include hormone therapy with tamoxifen or leuprolide, chemotherapy, radiation, and surgery, such as mastectomy. Post-operative care emphasizes supporting the affected arm with a sling, avoiding blood pressure readings, blood draws, or injections on that arm, encouraging early range of motion exercises, and avoiding constrictive clothing. Cervical cancer is most often caused by human papillomavirus, accounting for 90% of cases, with Pap test screening recommended starting at age 21 or 3 years after first sexual intercourse. Prostate cancer risk factors include a high-fat diet and African American ethnicity, presenting with urinary hesitancy, retention, recurrent infections, hematuria, and hematospermia in later stages. Diagnostic testing involves prostate-specific antigen levels greater than 4 nanograms per milliliter, with PSA testing performed before digital rectal examination to avoid false elevation, and hormone therapy with leuprolide is a common treatment. Key NCLEX takeaways include recognizing melanoma as the most deadly skin cancer, prioritizing infection prevention in leukemia and lymphoma, remembering no blood pressure or IVs on the affected arm post-mastectomy, and understanding PSA greater than 4 is abnormal, with screening recommended after 50 years of age. When caring for cancer patients, pain management is a primary focus, especially in palliative care, where the goal is not cure but comfort, aiming to improve quality of life. Pharmacologic therapy is guided by pain severity, with non-opioids such as acetaminophen and NSAIDs used for mild pain, while opioids including morphine, fentanyl, and oxycodone address moderate to severe pain. Adjuvant medications play an important role. Antidepressants help relieve neuropathic pain and improve mood. Anticonvulsants control neuropathic pain. Corticosteroids reduce swelling and pressure-related pain. And muscle relaxants manage spasms. Other routes of administration include systemic local anesthetics via infusion pumps, topical anesthetics such as lidocaine patches, epidural or intrathecal infusions, and regional nerve blocks. Complementing pharmacologic therapy. Non-pharmacologic interventions, like TENS units for low-voltage nerve stimulation, heat or cold therapy, massage, vibration, and acupuncture, can significantly improve symptom relief. High-yield NCLEX points emphasize that multimodal pain therapy, combining opioids, adjuvants, and non-drug methods, provides the best relief, and pain should always be assessed before and after interventions to ensure efficacy. Transitioning to anesthesia and moderate sedation, general anesthesia is commonly used for major surgeries and can be administered via inhalation agents like nitrous oxide or IV agents such as benzodiazepines and propofol. The process involves 3 phases: induction, where intravenous access is secured and preoperative medications are given while the airway is prepared; maintenance, during which surgery is performed with continuous airway management; and emergence, marking the completion of surgery and removal of airway devices. Medications used may include opioids, benzodiazepines, antiemetics, anticholinergics, sedatives, and neuromuscular blockers. A critical complication to recognize is malignant hyperthermia, which is life-threatening and initially presents with tachycardia, followed by dysrhythmias, muscle rigidity, hypotension, tachypnea, mottled skin, cyanosis, and myoglobinuria. Immediate interventions include stopping surgery, administering intravenous dantrolene, providing 100% oxygen, applying cooling blankets, giving iced 4 normal saline, and obtaining arterial blood gases. Moderate sedation, often used for minor procedures, relaxes the patient while maintaining airway and protective reflexes. Pre-procedure preparation includes NPO status, 6 hours for solids and up to 2 hours for clear liquids, ensuring informed consent is signed and removing dentures. Intra-procedure monitoring focuses on level of consciousness, vital signs, cardiac rhythm, and respiratory status. Post-procedure, patients must be observed until fully awake, with discharge criteria including stable vitals for 30 to 90 minutes, ability to urinate, tolerate oral fluids, and absence of nausea, vomiting, shortness of breath, or dizziness. NCLEX priorities remind us that malignant hyperthermia is an emergency requiring early recognition of tachycardia, rising end-tidal carbon dioxide, and rigidity, while moderate sedation requires the patient to remain arousable with airway intact. When preparing a patient for surgery, preoperative nursing care focuses on safety, patient understanding, and readiness for the procedure. Key steps include verifying that informed consent is completed, signed, and properly witnessed, ensuring the patient is NPO for 6 hours for solids and 2 hours for clear liquids, and holding certain medications such as antihypertensives, anticoagulants, or antidepressants if ordered. Prophylactic antibiotics must be administered within 1 hour of incision to prevent surgical site infections. Regarding informed consent, the provider is responsible for explaining the procedure, its risks, benefits, and alternatives, while the nurse's role is limited to witnessing the signature, clarifying previously explained information, and notifying the provider if the patient has additional questions or does not understand. Nurses do not give new information or obtain consent on behalf of the provider. Consent requirements include the patient being at least 18 years old, or an emancipated minor, mentally capable of understanding risks, and not under the influence of medications such as opioids or sedatives that impair decision-making. NCLEX emphasizes that if a patient expresses confusion or states, "I don't really understand the risk," the nurse must immediately notify the provider, not the charge nurse, to ensure legal and ethical compliance. After surgery, post-operative care prioritizes the airway as the first and most critical focus. Nurses assess oxygen saturation, respiratory rate, depth, and pattern, check for symmetrical breath sounds, auscultate lungs, and suction secretions if needed. Circulatory assessment includes monitoring for internal bleeding, observing abdominal distension, tachycardia, and hypotension, assessing for hypo versus hypervolemia, checking skin color, temperature, and sensation, comparing peripheral pulses bilaterally, continuous EKG monitoring, and closely tracking fluid and electrolyte balance. Vital signs should be taken frequently until stable, typically every 15 minutes for the first hour, every 30 minutes for the next 2 hours, then hourly. Intake and output monitoring is essential, with urine output less than 30 milliliters per hour indicating potential hypovolemia, prompting immediate notification of the provider. Surgical wounds require inspection for bleeding or drainage, and pain medications should be administered as ordered. Discharge from the post-anesthesia care unit requires stable vital signs, absence of active bleeding, return of protective reflexes such as gag and swallow, minimal or absent nausea and vomiting, wound drainage that is minimal to moderate, and urine output of at least 30 milliliters per hour. NCLEX highlights that airway management is always the first priority. If oxygen saturation drops, repositioning and supplemental oxygen should be provided before calling the provider, ensuring patient safety is maintained. Thanks for watching.